that they do and these kind of numbers. Roughly half of the organization consists of IT development. We currently have still quite a lot of IT hosted within our office building, but we're transitioning to the cloud. Now, such a transition is not an easy one. As said, we have 8 countries, we have 8 legislations. The European legislation is very strict on what is allowed in the cloud and what not. So we have a fairly large infrastructure department. We have a lot of software development. We have 3 development teams, one for the donor side, one for the recipient side, and one for the allocation side. And of course, we do a lot of testing because it's essential that when we introduce something, that it's done in the right way. And then, partially historical, we have immunological support from the Eurotransplant Reference Laboratory that's hosted in the Leiden University Medical Center. And actually, this is also more an administrative role, but we have instant access to the wet labs in the Leiden University Medical Center. The way we develop our allocation is done by organ advisory committees. We have 5 committees that are focused solely on specific organs and what is going well, what's not going well, what should we change, and what, if we change something, what will happen? How will it influence our allocation? Will we deliver fair allocation? Will we serve the special populations that we want to serve? And all these committees are filled with experts from the 8 different countries that represent the medical scientific community in their country. This works very well. We're able to harmonize a lot of allocation rules. It doesn't always work. We have the challenge that sometimes the waiting list composition in specific countries is different than in other countries, simply due to donation practices. But in general, it works very well to harmonize all our allocation rules and to make sure that we implement a single allocation algorithm for all the 8 countries. We also have supportive committees, and then you look at the ones in green. They basically overlap all the organs. One is the OPCC, it's the Organ Procurement Chain Committee, and that committee makes sure that the process from donation to transplantation is also harmonized, that we have a certain quality of organ procurement, that we also make sure that the way we store our organs and when we transport those organs, that it's done in a harmonized way, that we have a good level of quality control, but they also focus on new developments like machine perfusion. And when I talk about machine perfusion, that's not something that is fully implemented in the Eurotransplant area, because this is a per country decision. But we have best practices within Eurotransplant, and that's then typically something we want to share and that we want to roll out throughout the Eurotransplant area. And at a certain moment in time, you will see that it becomes a discussion on what if we do machine perfusion in one country, can't we start exchanging organs on machines? That's a big challenge. We're working on this as we speak, and I expect that within 1 to 3 years we will have machine perfusion organ sharing throughout Eurotransplant. Another committee is the Tissue Typing Advisory Committee, focusing of course on the immunological challenges, and in particular they focus very strongly on highly immunized patients. That doesn't necessarily have to be in kidney allocation. It can also be one of the discussions we have right now is in the Thoracic Advisory Committee, is whether we should do virtual cross-matching for hearts. The ETEC is the Ethical Advisory Committee. There we discuss all the different aspects that we have concerning ethical challenges that we see within the Eurotransplant area. And we have a Registry Advisory Committee. Actually, as I speak, we are discussing on shouldn't we bring that registry, the Registry Advisory Committee, shouldn't we put that into the organ advisory committees, because then you have a very logical flow from donation and waiting list to transplantation and then to follow up, where you put the responsibility at the organ advisory committees. that have the interest in the end. From all these groups, the chairmen come together in the Council of Medicine and Science, and that's actually where we discuss more the strategic directions that we want to go with Eurotransplant. Now, this seems to be a pretty clear overview of how it works, but fortunately, Eurotransplant is Eurotransplant, and things are not always as they seem. So we can come up with all kinds of rules and regulations and recommendations on how to improve our allocation practices, but the reality is that we then have to check them with the national competent authorities in all those 8 countries. So you will see that this process is not always as fast as we hope, but this is typically one of my tasks where I contribute in engaging with the national competent authorities to make sure that we have the good interaction, that we discuss the challenges for specific countries, and then it's mainly related to legislation or to specific country demands that they have. Now, discussing with these national competent authorities is also very interesting because sometimes we talk with ministries, for example in Austria and in Belgium. At other moments we talk to transplant societies, like in the Netherlands or in Slovenia. Other moments we talk to the National Blood Bank, that is the delegated responsibility for transplantation. And in Germany we talk to the Bundesärztekammer, which is basically representing all the doctors in Germany. But my conversation partners there are lawyers. So we get a very interesting conversation there, because when I talk with lawyers, they have a different interpretation of the law than a doctor would have. If we say, if they say a patient can only be listed once on the waiting list, they also interpret as they can only follow one allocation algorithm. So that means for a kidney patient that is highly immunized, if this patient falls in a special program for highly immunized patients, it cannot fall under the regular kidney allocation, even though that could deliver a well-matched kidney for this person. So this is a very challenging process. In general, it will take us roughly 1 to 2 years to implement a recommendation that we have developed. Fortunately, within Europe, with all those 8 countries, it's of course, again, a little bit more complex when you look at the entire process from donation to transplantation and to follow-up. We do have the legal framework. That legal framework, again, is different than what I just described. Because, for example, if you look at Germany, my partner for discussing the allocation rules is the Bundesärztekammer. But when I talk about the financing of Eurotransplant, I suddenly have to talk to the Association of Hospitals, but I also have to talk to the Krankenkasse, to the health insurance companies. This is not the same in every country because, for example, in the Netherlands, I just talked to the Nederlandse Transplantatiestichting, the Dutch Transplant Foundation. So there I have a single spokesperson. By the way, this is a colleague I knew from MBA. That makes it a little bit more easy, and there we can move a lot faster. So these national challenges are a great challenge for us as an organization, but on the other hand, we focus a lot on relationship management, me and my colleague, the general director, in order to accelerate the process to avoid that we end up in endless loops of bureaucracy. Then, when you look at the process itself, we work with a lot of organ procurement organizations. We do not appoint those organizations. These are appointed by the countries, and we have to work with them. There is no alternative. So this is also another interface where we have to discuss a lot. And then again, you see that there are many, many differences between all those countries. In the Netherlands, it's the NTS, so it's basically the organization that the national competent authority that also does the organ procurement and coordinates everything. But in Germany, it's an independent organization that has been appointed by the ministry. And that is because in Germany, they want a very strict separation between donation and recipients. So there must be, call it a Chinese wall, between those two events. And other countries, for example, there it's fully organized, like in Belgium, it's fully organized by the transplant centers themselves. They go out, they talk to the donation centers or to all the hospitals, that if you have a donor, please come to me. Let's engage in interaction, and they actively recruit their donor centers. The only thing that's fixed is that Eurotransplant is the single entity doing the allocation. And we are responsible for a 100% complete documentation of donors, waiting list, and the allocation process. Yeah, once we do this and you go towards transplantation, we do this match rank based, so on a patient level. We have over 60 transplant transplant universities in the Eurotransplant area. We have over 200 programs, because certain universities have multiple organs that they transplant, others only transplant kidneys. And then when it comes to follow-up, there you get into an interesting situation that Eurotransplant takes care of follow-up, but actually we're not paid to do so. And in some countries, for example the Netherlands, the National Competent Authority takes care of the follow-up. So they have the combination between donation and follow-up. But in Germany, there has to be a strict separation, and they have a separate Transplantationsregister. So it's all very complex. We have a lot of different stakeholders that play a role and with whom we need to engage. Then there's one more element, and that is, I already mentioned it, it's about the financing. We have, what I just showed you is solely from the medical side. But we also have a business side. And that's what my colleague is doing, André Matera. He's the general director. His responsibilities are focused much more on finance, legal, IT, and quality. And he also has his own advisory board that he needs to manage in order to make sure that we have a good process, that we get our funding, and that we are able to continue our business. So we have a very, very complex structure, but on the other hand, it works since 57 years, and it will work for the next 57 years. I have no doubt about it. So, on the allocation process itself, I already showed you the complexity of the entire process and the different stakeholders. But one of the things that makes Eurotransplant work is that the objective for everyone in the process is to help those patients that really need an organ. And we have a tier system that has not changed over the last 57 years. We always focus on special populations first. In some cases this will be first on international, in other cases it will be much more nationally oriented, for example for hearts. But there you also have geographical and medical reasons to do so, because you have a limited time to transport the organ, at least currently. But for other organs like liver, we have as a special population the highly urgent patient. And there we see a lot of international exchange of organs to other countries to serve the patient, and in general we are able to deliver organs within 24 hours anywhere in the Eurotransplant area. That system also has a payback, so that we make sure that, for example, a big country like Germany is not getting all the organs. We need to make sure that it's equally divided, and using balances and payback is the way to do it. Once that is done, we go to the elective patients. That's always on a national level. And this is actually where you see that our allocation algorithms start to divert, because specific countries can easily make their own rules. It doesn't matter for us. We can implement this, and we can make sure that we allocate on a national level exactly the way they want it. That is important, because that's actually where we see the biggest differences, and we have huge differences in the donation rates for the different countries, which I will show later on. One of the great things of Eurotransplant is, of course, the organ sharing. If we have no recipients in a certain country, and it's very well possible because some countries are so small, then it always goes instantly into the international pool, and then it becomes international allocation again, and this is where Eurotransplant decides on the rules. As you will see, this is quite a tedious process. It takes time. It's patient-oriented. So as time proceeds, we do get into situations that we have constraints due to the distance that we need to ship the organ to. Then we go into extended allocation. Extended allocation still is patient-oriented. And if nothing else works, then we just say, well, you know, we offer it to a couple of centers in the region. Do what you can. And this in the end leads to a situation where we hardly discard any organs. We hardly export any organs from Eurotransplant because we always have a patient. The allocation itself, this will not be surprising. We have our priorities. Heart always goes first, then lungs, then liver and intestine, then pancreas and then kidneys. In general, we give centers, especially in the beginning, 30 minutes to decide, do I accept this offer or not? They instantly get the full donor report that you can also get on your PC screen or on your mobile phone. All it takes is an ET number. For kidneys, by the way, it's 60 minutes, but you know, the process works. We always make a backup offer in order to accelerate the process as good as possible. Yeah, and as I already mentioned, our matching depends on donor data. Recipient data are important. Organ-specific rules play a role. Country-specific rules play a role. But we simply execute this. We get the donor data fully digital, so the moment the data comes in, a minute later, we're running the matches already, and then within 5 minutes, we are able to start calling and to inform the centers that they have a donor organ offer. So these are the centers. As said, we have quite a few centers. It's sometimes surprising that certain smaller countries have multiple transplant centers, and other larger countries like the Netherlands, that's roughly 18 million people. They have 9 centers. A small country like Croatia, with 3 million people, already has 6 transplant centers. For us, it doesn't matter. The only essence is that in Croatia, you only have 2 airports. So if we ship from anywhere in Eurotransplant, we always ship to the same airports, and then the transplant centers take over. The largest number of transplant programs is, of course, kidneys. That's also not very surprising. We have only 4 centers doing intestine transplant, and if you look at the total number of intestine transplants within the Eurotransplant area, it is rather limited. An interesting number is also the 30 pancreas transplant programs. That's actually quite a lot, because we do in total 150 pancreas transplantations. So there you already see that we sometimes have a weird balance between the programs that are allowed to do pancreas transplantations and the volume. But in general, within Europe, we see that there is a strong focus on centralization of transplantation in order to make sure that centers have a sufficient experience in doing transplantations in order to improve the quality. As said, we have several mechanisms in place to make sure that we never lose an organ. And I have the numbers later on in the slide. Basically, the way it works is for extended allocation, we try to do that on a national level. In this case, the circle is in the Netherlands, but it could be anywhere in the map. The only difference is that in Germany, the distances are so huge that there we will focus on the specific Bundesland or the region where the organ is at that moment in time. If that doesn't work, then suddenly we go towards the centers that are known to be very liberal and that also are willing to accept organs that are more or less moving into a marginal state. And I said, yeah, the last level is outside of Eurotransplant, but it hardly happens. On the other hand, Eurotransplant does import quite a lot of organs into the area. because we are surrounded again by smaller countries, and those smaller countries sometimes do not even have a heart transplant program, and in that case they offer it to a European platform. Yeah, we get the data, we instantly match, and then we start calling, and that level of efficiency leads to being able to accept a lot of organs that otherwise would be discarded. Then these are the results of how we match, and as you can see, patient-based allocation is the core of our activities. And even though you see the extended allocation, that still is patient-based. So what we actually do on a rescue level is really minimal. The numbers are, of course, a little bit, or the percentages are a little bit different depending on the organ. It's clear that for kidneys, that level is rather low, for the simple reason that we have a lot of time to allocate organs. And I have to say that I expect that with the new developments like machine perfusion, it's likely that we can lower these numbers even further. Another thing you can see is pancreas allocation. If I'm really honest, you know, it's great that we do national allocation also for pancreata, but the reality is that we see that the transplant surgeons really prefer an organ that has been explanted in their own region, because pancreas transplantation is a big challenge. Pancreas procurement is a huge challenge, and being able to do so and receiving an organ that you can truly transplant, that's what it's all about. And we see a lot of challenges in the procurement quality, especially for pancreata. So then I wanted to go to some facts and figures. This is actually where all the numbers come. I'll try to point out the most important facts. This is the typical fact sheet that we always publish, just a general overview of what we do in Eurotransplant. But the reality again is different, because we have these different legislations and we have huge differences in the donation rates, and thus also in the waiting list consequences. But we do roughly 2,200 donors a year. This number is rather stable over the last 10 years. We transplant 7,150 donor organs. The number is actually growing a little bit, and the growth is surprisingly coming from heart transplants. And the reason that the heart transplants grow is due to machine perfusion, and in particular in DCD. Donation after cardiac death is very big in the Netherlands, in particular in Europe, in the Eurotransplant area. And they started 4 years ago with a heart transplant, DCD heart transplant program, where they put all the hearts on the machine. And that has doubled the number of heart transplants in the Netherlands. So those are really interesting developments. Those are, call them best practices. I think there are also a lot of ethical discussions on whether you do this or not. And here you see that neighboring countries, for example, like Germany, they do not allow DCD. And that has a historical perspective, because DCD is a form of active termination of life. It's interpreted there this way, and that is something that is a very, very sensitive topic in Germany. Then the numbers on cross-border exchange, and this is actually what Eurotransplant is all about. We facilitate to serve those special populations, and it's almost a quarter of all the organs that we allocate that cross a border. And then you see more in detail which special populations. High urgency, dominated by liver transplants. Pediatric recipients, because you can imagine if you have a very small waiting list with pediatric recipients, and especially if you have a pediatric patient waiting for a B heart, it's very unlikely that you will get this in Slovenia or in Croatia. And this is where the Eurotransplant collaboration really pays off. Then we have the immunized kidney recipients, where we have a lot of focus, and the zero HLA mismatch. And this is a very clear choice. This has a very strong historical perspective, because this is where Eurotransplant started, and this is the way we have always allocated the organs to the kidney recipients. Yeah, some donor definitions. This is important for the right interpretation of the next slides. DBD, DCD will be known to most of you. In principle, brain death is accepted in all Eurotransplant countries. There are very strict criteria for this. DCD is allowed in specific countries, and you will see this in the numbers. This is the Netherlands, it's Belgium, it's Austria. But it has a huge impact on donation practices. Then on living, I split out genetically related and genetically unrelated. I explicitly name this because what we do in the Netherlands, you can also do fully unrelated. Altruistic donation is fully accepted in the Netherlands, also in some other countries, but it's not allowed in Germany. There were discussions in Germany on this, but then the government fell, the discussions stopped, so I don't expect that this will change again in the next 2 to 3 years. But this is the statistics, this is the overall statistics of all donors reported in Eurotransplant. This is an overview of DBD, DCD, and living. And as you look at these numbers, you see that's actually overall quite stable. We did have a dip, of course, during the COVID period, but if you look into the numbers a little bit deeper, you will see that it mainly affected the living transplantations and not as much the deceased donation. So this is more in detail where you can see it. If you look at the trend, you will see that the DBD donation actually is quite stable, and that the growth seems to be coming the last couple of years, mainly from DCD. But these are the realities of the donation practices that we look at. The biggest country definitely is Germany, there's no doubt about it. But if you convert this to per million population, you see that there are 11 donors per million population. And that is low for Eurotransplant standards. The countries with the highest donation rates, Croatia, they have a fantastic donor or an education program for donation practices. They focused on this, and that was also the message that Eurotransplant brought. If you start, focus on the donation practice, the rest will come. But if the entry or the starting point does not work, you cannot develop the rest. Then we have Belgium, where they also have more than 30 donors per million population. That is also because they always had an opt-out system. The general culture is donation is a good gift. There's no objection. It's a historical perspective. They always been running on the front of transplantation. They're preaching this, and there you see the power of transplant hospitals going out to donation centers to actually actively promote and stimulate donation. The Netherlands then, now finally, after many years and a lot of activities focusing on donation, they finally reached the 20 per million population. That's been a huge success, and that's mainly attributable to DCD donation. But you see a lot of differences, partially driven by culture, partially driven by legislation, but we're still able to work with this very well. And this is then the split per country on the donation rates. And here you see that the Netherlands is by far the country where DCD donation happens. 60% of all donors are DCD donors, and the reason is actually pretty simple. It's well plannable. Netherlands is a very liberal country when it comes to donation, And they have been putting a lot of pressure on this to stimulate the whole practice of DCD. The government actively supports this. The fact that we now have DCD hearts on machine perfusion is simply because the government actively supports this, pays all the costs. And in fact, that was, I'm running a little bit out of time, so I will continue a little bit faster. Something on living donation. These are the numbers, small dip, especially in the COVID period. Here you also see the differences. Germany being the biggest country, the Netherlands is actively a country that has been stimulating this a lot as well. They have a relatively short waiting time, about 2 years, 2 to 3 years, comparable to Belgium. But Belgium has so many donors, they do not really need living donation. Some more into detail. Here you see crossover. That's something where the Netherlands has been very, very active. But if you look at the overall numbers, it's still relatively low. Then here's some survival data, and this actually, just to demonstrate, living definitely gives you the best survival rates. There used to be, 20 years ago, quite a considerable difference between DBD and DCD. So I was wondering, after coming back 20 years later, what are the results nowadays? And that's what you see here. And this is a very, for me, was a very surprising figure, because what you see is that the difference between DCD and DVD actually is minimal. And I think this is because of machine perfusion. Machine perfusion really improves the quality of your organs in DCD, and that really results then in better results and very good long-term outcomes where the difference between DBD and DCD is minimal. So we have a lot of benefits in organ sharing in Eurotransplant, and that's definitely that we are able to find always an organ for the right recipient. And we have a very efficient system, a lot of interaction with a lot of stakeholders, but we can make sure that if we have the shared infrastructure, that we can lower the costs for all those countries, and that's attractive for the smaller countries that participate in Eurotransplant. So then I wanted to go to kidney allocation, because I think it's very important to understand how we do it, because there are a lot of learnings in this process. Again, we have a lot of milestones. I will focus particularly on the allocation systems that we have. And this is the essence of how we allocate kidneys. For us, age is a very important factor, and immunology is a very important factor, and in particular, HLA matching is the basis, but immunization is really a very, very important factor. This is the fundament of our allocation algorithms. Age for donor and recipient. Then we have the geography. In principle, this is a Eurotransplant allocation, except for the ESP, the Eurotransplant Senior Program, the older donors with older recipients. That's where we focus on the region. And in some countries, the region is the country. In general, we always use HLA. We always include an acceptable HLA to make sure that we do not unnecessarily start shipping organs to a center that cannot transplant at all. The blood group roles are also very important, and that's something I can show here. In the past, we used to allocate ABO compatible, but then you clearly see that some blood groups clearly benefit with a shorter waiting time. So we changed the rule, and then you see that there's a harmonization of the waiting times. And that's the essence of how we look at how we allocate. So let me give a single slide on the Eurotransplant Senior Program. It was started as the Old for Old program, but this is a more politically correct name. The key goal is short ischemia times for marginal organs. That's the way we do it. It's actually very, very simple. We do include HLA. We do ABO compatible matching, focus on the region, and in fact, we simply rank according to dialysis time. And then it's up to the centers to decide, do I accept or not? Works very well. we transplant quite a few organs, and these are marginal organs in elderly recipients. As long as it works, it's great. Then on our general kidney allocation system, focused on HLA matching, we have something called mismatch probability, and actually the mismatch probability tells you what are the chances of having a mismatch. The point is that some HLA types and some HLA combinations are pretty rare. And if we would only allocate according to HLA, those patients would hardly get an offer. So we compensate this with mismatch probability. And the interesting point is that actually this, we compensate for the ad hoc chance, and then we change the post hoc chance. So if I approach this from an AI perspective, this is actually an AI approach to kidney or to a mismatch probability that's already in place since many, many years, but we never called it AI. Geographical distance also plays a role, time on dialysis, and we have again the kidney balances that we put in place, especially for certain age groups, to make sure that we do not get a continuous outflow of organs to specific countries. Why do we do the HLA matching? Well, I guess everybody knows, but HLA matching matters in kidney allocation. And that's why we give absolute priority to zero mismatches, because we know that the organ longevity, kidney longevity, is maximized if we do so. We also take into account specific populations again, pediatric patients, of course. We primarily want to allocate pediatric kidneys to pediatric recipients. We have an HU bonus in our system, but in reality, this is used 8 times a year in Eurotransplant, so it's actually really a really small number. We also have, of course, a very special bonus for those patients that have donated their living kidney, but that lost the kidney that they had left. We do this in Eurotransplant except for Germany, because there it's not allowed by the law. There's something on age matching. I think it's an open door, but old kidneys in young recipients lead sooner or later to graft failure, whereas a young kidney in an old recipient results in death with a functioning graft. And that doesn't contribute to longevity of the organ. And this is something we're actively looking into right now. How can we optimize this, and what can we do to change this? And then we go to a proposal that we have right now, where maybe we need to compensate with points that young kidneys go to young recipients before we send a young donor kidney to an old recipient. Second point, fair access to transplantation. This is the reality of the chances for immunized patients to receive an organ, and you see that actually you would like to have a flat line. But the higher your immunization grade is, the lower your chances of receiving a good organ offer. And when it's above 85%, then forget the chances of a good organ offer. So we're looking into this as well, and then we start to simulate and to see what can we do in order to actually ideally create a flat line. And here you see that if we change our points and start to balance, then we are able to improve the allocation and to improve the chances of those highly immunized patients. Then something on the AM program, and that's the program that especially focuses on those highly immunized patients. It was launched already in '89 by Frans Klaas, the late Frans Klaas. He unfortunately passed away end of last year. And it's been a very successful program where we have been able to help a lot of patients that actually had a very, very low chance of receiving an organ. And what you see here, it's the blue line. We can achieve the same results with the AM program as for long-time graft survival, as with our regular allocation. And that shows that this program really contributes to organ longevity and to a very high level of quality of life for those patients. Here we chose a different approach to the blood groups. It's very obvious that specific blood groups were really disadvantaged if we would use ABO identical. And if you then go to an ABO modified compatible, actually the difference is that an O and an A donor can donate to A, B, and B. If we modify it in this way, we are able to harmonize the waiting times. Then I have a couple of slides on virtual cross-match. I don't know if virtual cross-match is used in Saudi Arabia or here in the Middle East. Yeah, okay, then I don't have to say too much about it. You will know it. We used to have a system where for immunized patients, we would ship every 3 months for all those immunized patients samples to all the donor regions. So there was a huge logistical effort. And implementing virtual cross-match was essential to really accelerate the process to make it a lot simpler. And we have done that right now. You will understand the logic. Not much to be said about this. We have a calculator, but probably you have some calculator for yourself as well. We use ET database data. And this is also implemented throughout Eurotransplant, has been very successful and really saves us a lot of shipment of organs that cannot be transplanted. You can look at it at the website of the ETRL. And you can put in any kind of data you have. I think that's one of the key things that's very important and that also has helped us in this entire process is that we set up a system for electronic data exchange of the HLA data. This was not the case, so it had to be typed in by hand. We have been able to motivate all the companies doing HLA analysis to adopt a uniform way of transferring the data. And that's what we use nowadays, and that really accelerates the entire process of receiving all the data. And actually, one of the things we're considering right now is to also expand this into the recipient area. In a lot of countries, we have an overlap between donor and recipient HLA typing labs, not in every country, so it would take a little bit more effort to get this done. So yeah, my recommendations in general for if you set up a program like this, think about age matching. But this is a volume game. You need to have sufficient donor offers in order to start doing this. If you have a small waiting list, then it doesn't contribute. For us, it's really important the equality of people on the waiting list, that they have a comparable waiting time, that they have the same access regardless of blood type, regardless of HLA typing. We want to make sure that we can deliver organs also to those patients that otherwise would not get a reasonable chance of receiving an offer. And I guess that for us at Eurotransplant, the key outlook is that we will focus on all those best practices, that we want to roll this out also to other parts of our activities. And I guess that for us, the biggest challenge that we have nowadays is interoperability. When I look at how tough it was to roll out virtual cross-match, to enable data exchange with all the different manufacturers of HLA typing devices, with all the different centers, between all the different countries. Interoperability, data exchange, safe data exchange, and the harmonization of definitions is a major, major challenge. And this is actually where I think that this could even be on a global level, something where we could think about, is it possible to harmonize? Is it possible that we use the same definitions in order to be able to analyze the data we have on a global level and to identify those factors that really matter in allocation. Because even though at Eurotransplant we have quite a lot of donors, we have a lot of data, more data is better. And that means, harmonization of the definitions. Then this is my last slide, and these are just some photos I made in the last couple of weeks when I traveled around through the Eurotransplant area. And actually, when I looked at them, I thought, hey, there's an analogy to the donation practices in the countries. Because the first one is Belgium, and in Belgium, as you see, this is in Brussels, on the Market Square. Your house is really important. You have to show off. Yeah? And you go out and you want to demonstrate how good you are. And this is actually what happens in Belgium. Transplant centers are very active in the donation and in the waiting list registration to attract all the patients and all the donors. The Netherlands, completely different. This is about equality. Everyone is equal. It doesn't matter. It doesn't matter what type of donor you have or where you are on the waiting list. We treat you all the same. And then the last one is Austria. And Austria, a lot of mountains, of course, a lot of valleys. And donation and transplantation is just like melting water from the snow. In the end, it all flows down the mountains into the valley. And actually, there in the valley, that's where the transplantation center is located. And that's also how they operate. So very much on a transplantation center focus. So that's what I wanted to tell you, and I thank you for your attention.
Thank you, Dr. Erwin, for this enriched and interesting talk about Eurotransplant. Just to answer your question about the virtual cross-match, I think Scott has started applying the virtual cross-match directly to avoid any bias in the allocation. I think Eurotransplant has a long history with our country, especially in the 1979 when we started our kidney transplant, and at that time there was a couple of organs coming from the Eurotransplant. Due to the lack of time, and we are beyond our time, any question will be asked the speaker directly. Thank you, and we will move to the second session.
Assalamu alaikum. Good morning. We'll start our second session here for this great Congress, the third day of the Congress. And here we've got two speakers for this session. The session will be focused mainly on the cancer donors, recipients, and then we'll continue to interplay the outcomes in relation to that. I will start, Dr. Ibrahim Al-Hassan will be co-chairing the meeting with me, or the session rather, and we have two excellent speakers. Dr. Brian Keller will do a couple of talks, and in between Dr. Talia Baker will do the second one. So I'll introduce the first one. I think the first one is Brian Keller. Dr. Brian Keller is an assistant professor of medicine at Massachusetts General Hospital. He is the medical director there for the lung transplantation, and he's been there for the last 3 years. Prior to that, in his journey, started as a medical student trainee in Dallas, Texas, Southern Medical School, then the residency and fellowship training in Washington University in St. Louis. Between 2016 and 2022, he oversaw the research program and was the transplant pulmonologist at Ohio State University in Columbus. Great work done in relation to research, and by May 22 moved to Massachusetts General Hospital, and in this short period, great progress being made in clinical outcomes, research, and training. Dr. Keller is a member of the Lung Transplantation Committee in UNOS, and before he was the chair of the Advanced Lung Failure and Transplantation Interdisciplinary Network for the International Society for Heart and Lung Transplantation. So it's quite interesting. The first talk, Dr. Keller will be covering weighing the risks, donor with a cancer history. Dr. Keller, please.
Good morning, and thank you to the organizers for the opportunity to speak with you all. It's just a wonderful experience to be here with you in your beautiful country. It's my first time in Saudi Arabia, so thank you all for your warm hospitality. As was mentioned, I'm going to start off this first talk talking about donors with a cancer history, and then we'll come back a little bit later and talk about how we think about assessing donors who may have a cancer history or who have a known cancer history. Thank you for the introduction. These are my disclosures, and none of these are directly related to today's talk, and I will not be discussing any off-label or investigational use of any drugs or devices this morning. So for the next 20 minutes or so, we're going to cover the incidence of donor disease transmission. We'll talk about donor transmitted solid organ malignancy, and we'll also talk about hematologic malignancy history in the donor. And what I hope to do over the next few minutes is to provide an overview of the risks associated with accepting donors that have accepting organs from donors that have a history of cancer. We'll discuss various types of cancers, although with the number of different types of cancers that we see, we can't really go through everything, so we'll kind of touch on some high points. And we'll talk about their potential impact on organ viability and recipient safety. And then finally, we'll examine the potential for disease transmission to the transplant recipient. So to get us started, I thought we'd start with a case to get us thinking about malignancy in donors. So in this case, we have a 36-year-old male donor who's a non-smoker, admitted with seizures, and found to have a brain tumor. Heart and lung function, as well as kidney and liver function, were deemed to be excellent, and there were no other concerning medical history or clinical findings. So when you're looking at this donor, some questions might come to mind, and this is just an example CT image here, but questions would be, do you need a biopsy to determine the specific type of cancer that we're dealing with? Do you want a biopsy? What if a biopsy or surgery has recently been performed, and how might that impact your decision making? Does it matter if the cancer was previously known or just recently diagnosed? What if the donor had been treated with non-surgical therapy, such as chemotherapy or radiation therapy, prior to this current admission? And does it matter if the donor is a donation after brain death or a donation after cardiac death donor? And finally, what if the organ functions weren't otherwise perfect in this particularly young donor? And how would that affect your decision making? So keep in mind these questions as we go through the rest of the talk, and think about how or if these factors might influence your decision to accept or not accept this particular donor. But first, let's talk a little bit about donor disease transmission, which includes any disease transmitted from donor to recipient. This can include malignancy, but also infection, allergies, and even genetic diseases, among others. We also need to consider whether disease transmission is expected, as in the case of a known donor infection, or unexpected. So back in 2011, Michael Eisen and colleagues reported that unexpected donor disease transmission occurred in less than 1% of recipients. And here I'm showing you the first 10 years of data from the United States OPTN Disease Transmission Advisory Committee, or DTAC. This data is from 2008 to 2017, and this includes all reports of donor disease transmission, as well as those reports that were confirmed as either probable or proven. Nearly 2/3 of all reports related to potential transmission of infection, while the remaining 1/3 related to potential disease transmission of malignancy. As you can see, proven or probable transmission makes up a very, very small percentage of all reports. And in fact, in this early data, of the 43 reports of breast or thyroid cancer, none were found to be proven or probable, whereas renal, lung, and liver cancers made up nearly 50% of proven and probable transmissions. From several recent studies, as well as one from 2012, the overall incidence of donor-transmitted cancer was found to be between 0.2% and 0.11%. Overall, quite low relative to the total number of solid organ transplants performed. But what is the impact of these in these cases where a disease transmission occurs? What I'm showing you here is a table of proven or probable malignancy transmission from a United States cohort published in 2021. As you can see, there was a high degree of graft failure and recipient death when donor transmission of cancer occurred. These results were confirmed in a German cohort of patients over the period of 2016 to 2022, where a monitoring system similar to the American DTAC system is in place. While some forms of cancer, like renal cell cancer, were not associated with recipient death, most of the transmitted cancers were linked to death rates of 50% or higher. Thus, donor-transmitted cancer is a low-incidence, potentially high-risk event. And to help guide decision-making when it comes to donor malignancy, a risk stratification algorithm was introduced back in 2011. This system classifies risk as no significant risk to minimal to low, intermediate, or high risk based on the literature available at the time. And in this paper, the authors further went on to list specific cancers by their projected risk. Regarding CNS tumors specifically, procedures that disrupt the blood-brain barrier, such as surgery or ventricular peritoneal shunt placement, were placed into the high-risk category. You can also see that other cancers, such as malignant melanoma, breast cancers, colon cancers, lung cancers, and hematologic malignancies were also placed in the high-risk categories. Since the US DTAC risk stratification came out in 2011, a few other classifications from the UK, the Council of Europe, and most recently Italy have also been published. All of them are very similar, and since I don't have time to go through each individually or through the wide spectrum of potential donor-transmitted malignancy, I thought I would focus on two of the extremes as examples before coming back to our case. So there was recently a review of donor-transmitted melanoma published as recently as 2023. In this systematic review, the authors analyzed reports of donor melanoma history where recipient outcomes were also reported. Of 232 articles, 17 articles were available and were evaluated that included 9 database reviews and 8 case reports. Melanoma was present in donors from 32 years prior to donation up to the time of donation, and recipient melanoma was reported as any melanoma that occurred within the first six years after transplantation. In total, there were 41 donors with an ever history of melanoma who donated organs to 75 recipients. Of these 75 recipients, 43 or 57% developed melanoma within 6 years of transplant, with one of these cases being from a donor with a melanoma history of 32 years prior to their donation. In many cases, data was limited by a lack of tumor DNA confirmation and a lack of reported recipient outcomes. But still, I think this data should raise some concern regarding donors with a history of melanoma at any point in their lifetime. Switching gears, let's look at the other end of the spectrum. This is a couple of studies looking at brain tumors. These were both large retrospective reviews, one from England and Scotland, shown here on your left, with 13,724 donors, and the other one from Korea with over 2,800 donors. In the England and Scotland study, of these 13,000 solid organ donors, about 2% of them had a primary brain tumor at the time of donation. And these 282 donors donated organs to 887 recipients. In Korea, which is a little more contemporary from 2005 to 2014, there were a few more than 2,800 solid organ donors, and of these, 1% had primary brain tumors at the time of donation. And these donors donated to 91 recipients. In all of these recipients, there were 83 malignancies and 79 recipients. And yet, of these 7 to 8% recipients that developed any post-transplant malignancy, none of them were the cancer that was in the donor. So none of these CNS tumors were transmitted. And since this was a retrospective review of different registries, some of these donors had undergone brain biopsies, surgery, radiation, or had VP shunts in place, all factors that would have placed them into the high-risk transmission group based on current risk stratification guidelines. And yet, out of over 300 donors with a primary brain tumor, there were no reported transmissions in the 950 plus organ recipients. Also from the England and Scotland study, there was no difference in recipient survival from donors with brain tumors compared to those donors who did not have a tumor. The authors also evaluated donor utilization based on the grade of the CNS tumor and found that donor utilization did vary by tumor grade. Specifically, in low-grade tumors, there was similar utilization of those donors as in the donors without tumor. However, in donors with a high-grade tumor, they found that there was lower utilization in recipients of kidney, liver, and lung organs, but not hearts. And they feel in calculating the unrealized potential of transplant, had there been equal utilization in the high-grade tumors as compared to the low-grade tumors, they estimated that there was an unrealized potential of 61 lost transplants. So I'm only going to mention hematologic malignancies very briefly. And this is because historically, these diseases have been considered contraindications to organ donation, but the data on risk of hematologic malignancy transmission from donor to recipient is actually quite lacking. From the 2 large studies that I mentioned earlier, there were only a total of 19 reported cases of potential transmission, with only 4 of these confirmed as donor-derived. Of the confirmed cases, 1/3 to 1/2 of recipients acquiring hematologic malignancy from their donor organ died. Now, as therapies for hematologic malignancies have greatly improved over the years, more data is clearly needed, particularly in cases where potential donors have been previously treated for their hematologic malignancy and achieved remission or even cure. And finally, while not strictly a donor-transmitted malignancy, the transmission of certain viruses with oncogenic potential can result in malignancy in the solid organ recipient. Viruses of note include Epstein-Barr virus, or EBV, which causes post-transplant lymphoproliferative disease and lymphoma, human herpes virus 8, which is the causative agent of Kaposi sarcoma, and HTLV, or human T-cell lymphotrophic virus, which can lead to T-cell leukemia. Now, while screening for EBV is commonplace, donors may not always be screened for HHV8 or HTLV unless certain risk factors, such as a history of HIV infection or a specific clinical concern, is present. Recipients who are EBV negative and receive an EBV positive donor organ are the highest risk for development of PTLD. And I've personally seen one case of presumed donor-imported HHV8 infection leading to Kaposi sarcoma. So it is important to always consider donor importation as a source for malignancy in the transplant recipient. And our next speaker will be talking more about the transplant recipient's experience. So coming back to our case and these questions that I posed earlier, Certainly, the recent data from the UK and Korea is reassuring as it relates to CNS tumors, yet several of the items in this list potentially increase the risk of malignancy transmission. Ultimately, as with many things in transplant, it comes down to a balance of the risk of malignancy transmission with the risk of your patient continuing to remain on the waiting list, waiting for that next donor, and the risks of disease progression. So to summarize, donor malignancy transmission is a low incidence, potentially high risk situation. The risk of donor transmitted cancer does vary by cancer type, and I would recommend avoiding donors with a history of melanoma at any point in their lifetime, donors with a history of leukemia or lymphoma due to a lack of established data, and donors with a history of breast, colon, and probably also include lung cancer in this list. And finally, informed consent and close monitoring of the recipient post-transplant are key, and I'll touch on that more in my second talk. So a few recommendations. I think it's well established that countries should establish a mechanism for monitoring donor-derived disease transmission. And this should include things like donor disease transmitted malignancy, infection, allergies, and the like. We should try to avoid the use of organs from a donor with a history of melanoma, leukemia, lymphoma, breast, colon, and lung cancer. And finally, we should implement close monitoring of transplant recipients if organs from a donor with a cancer history are used. So with that, again, I'd like to thank the organizers for the opportunity to spend some time with you, and I'd be happy to take any questions I believe at the end of the session. Thank you.
That's right. I can talk, right? Yeah, so the questions at the end of the session. So can we move on now? Thank you.
We'll move to our second speaker, Dr. Talia Baker. Dr. Talia is a nationally recognized leader in living donor liver transplantation and treatment of liver disease, including hepatobiliary malignancy. She's an active researcher. Her work focus on liver transplant related topics such as downstaging and optimization, complex hepatobiliary tumor, to resectability and transplant, and the ethics implementation of using social media for organ donation and transplantation. Dr. Baker is recognized as a leader in the emerging field of liver transplant oncology, and founded and lead the transplant oncology task for the American Society of Transplant Surgeons. She will talk about pre-transplant solid organ malignancy from the recipient perspective.
Thank you for that kind introduction, and thank you for the organizers inviting me to give this talk. I'm going to take a lot of the data that's just been presented and flip it around to the recipient perspective. It's difficult to separate the two, but I appreciate that in terms of my disclosures, I have no disclosures, but I would like to say that I'm not an expert in this field, and I think as a liver transplant surgeon, the real importance of knowing this information is that we, in honor of the recipients, really need to know that we have to reach out to our colleagues in infectious disease who are experts and to be actively involved in the consent process for this, but also in the decision making as you go back to the case that we just saw of whether you consider accepting these organs for this particular recipient. And I'm going to go through some of those details. So as an introduction, as you've already heard, donor-derived malignancies are relatively rare, but when they do occur, there is serious complication in solid organ transplantation, often resulting in death. They result from unintentional, most often, transfer of undetected cancer from a donor to a recipient. And with the increased use of older and extended criteria donors, I think it's all really important that we remember this because we're trying to alleviate a critical donor shortage, but we really have to be vigilant about the possibilities of these occult malignancies in this older population. I would also include not just the older, but the population who comes in who we just don't have any medical history on. Transplant professionals have to balance life-saving benefit of transplant against the small but non-zero risk of potentially transferring a malignancy. And these are decisions which have to be made quickly. As you just saw from the beautiful talk from the keynote speaker earlier, these decisions often have to be made within 30 minutes. So the overall incidence and risk, I'll go through this very quickly because the prior speaker did this so well. The overall incidence is anywhere from 0.2 to 0.5%. In most of the literature. These figures are likely, though, to underestimate, as underreporting and underdiagnosing do occur. I think this is important as transplant programs are established as well, to know how important it is to contribute to every registry that's being developed. Historical series, we just heard some data, show up to a 43% transmission risk when high-risk donors were involved. So this is very important because, as you recall, you just heard that most of these result in fatality. There was an Israel-Penn registry in the United States which found that when organs were inadvertently recovered from donors with undetected malignancy, a large fraction could develop cancer, and the cancer risk resulted in significant mortality. So transplant centers and networks closely track these events, but perhaps need to be even more vigilant about how they do this. OPTN and UNOS Disease Transmission Advisory Committee, as you just heard, DTAC, monitors all potential donor-derived disease events nationally to continue to refine risk estimates and improve safety. And it's important to look at this data yearly to make sure we're working on the most up-to-date data. So we've already gone through the types of high-risk cancers, but I think the most important takeaway message is that certain cancer risks do account for a disproportionate share of the donor-derived cases that do occur. It's important to know what these are and have them, for those of us taking donor offer calls, have these as high-risk kind of flags that we see so that we can involve our colleagues in oncology and infectious disease. These tend to be tumors that were either small or clinically silent in the donor, for example, an occult renal cell cancer or lymphoma, or highly aggressive cancers capable of early spread. Again, any history of melanoma should be very concerning and raise red flags to an accepting surgeon, and lung cancer as well. I agree completely, should be something that we consider very highly. So in terms of the high-risk cancers, we've gone through most of these already. But what I want to emphasize is these are numbers which I hope that accepting surgeons will kind of have in the back of your head. Melanoma accounts for about 30% of all donor-derived malignancies, but they are of significant risk and probably should be considered absolute contraindications to accepting. And importantly, as the prior speaker spoke about, this not only includes a history of melanoma at the time of the donation, but any history prior. And often it's really important to ask whoever is presenting the case to you to make sure that they have a very remote history from the patient as well. Lung cancer, again, a very high transmission rate, likely should be considered an unacceptable risk. And choriocarcinoma is something that we don't really think about, but it's frequently fatal if transmitted. So we actually recently had a female donor of childbearing age who had an unexplained brain death from hemorrhage. That should be our flag, which tells an accepting surgeon that they should check a beta-HCG level to exclude an occult choriocarcinoma. High-grade CNS tumors, again, primary CNS tumors, this has already been explained, glioblastomas and other grade 5 brain tumors, were historically considered an absolute contraindication, if not a relative, because of the high transmission risk. But the data that has just been presented shows that transmission from primary intracranial tumors is actually quite low. And these tumors often do not cross the blood-brain barrier and should not be considered a absolute contraindication, but a relative contraindication. And often we as accepting surgeons consider the presence of a VP shunt an absolute contraindication, but as we've just heard, it really needs to be considered in terms of the risk-benefit to the patient. Low-risk donor cancers, again, these are really important to know also. So localized renal cell cancers can often be excised at the time of donation. So these should not, again, be absolute indications, and most cancers in situ should also be seriously considered for donation. For example, cervical cancer in situ or DCIS. So, as a recipient surgeon and as the accepting surgeon, I think it's really important to think about organ-specific considerations for the recipient as you take these donor-derived malignancies into consideration. So is this a life-saving or elective transplant? So for kidney and pancreas transplants, these are elective procedures. There's generally greater flexibility in waiting for a suitable donor. So we can impose stricter donor selection criteria when we have these questions. That being said, we all know that a recipient who is offered a kidney may not get a kidney offer again in an acceptable time period. So the risk-benefit has to be considered. For heart, lung, liver transplants, they are life-saving. They're often super urgent events. So the urgency has to be considered as you're making these decisions, not to increase the risk of donor-derived malignancies, but to make sure that the risk-benefit is being considered on a case-to-case basis for every patient and for every organ that you're transplanting. And you really have to include all of the decision makers, so the entire transplant team, the patient, the families, and all the caregivers. I want to touch a little bit on the ethical implications of informed consent, because transparency has to be part of what we do. The transparency and informed consent are ethical requirements where there is an elevated risk of donor malignancy. There has to be shared decision making. And we have to respect patient autonomy, and this has to be balanced against clinical urgency. Risk-benefit discussions should communicate the sense of urgency of a transplant so the patient understands, as well as the cancer risk. And I think for marginal and extended criteria donor, there even needs to be more transparency to make sure that the recipient understands the potential risk that you're taking with this specific donor. The consent process should always transparently include the discussion of the cancer type, what we know about the cancer type, the data that is most recent and available, the donor history, the urgency of transplant, et cetera. And importantly, as transplanting physicians, we have to document. The consent form should include explicitly mention the cancer transmission risk and the fact that you've discussed this with the patients. And I think importantly, we have to remember that even if we feel that it's an acceptable risk to take, the patients can decline a high-risk organ, but they should not be penalized that. For example, they should not be put on hold on your waiting list. And I think this is something that we have to remember in the heat of the moment, the 30 minutes that we have to make a decision. So in terms of donor screening and evaluation best practices, I know that this is going to be covered in the next talk, so I'll just go very quickly through it. I think the bottom line message is that meticulous donor screening and selection is really key, and the responsibility of everybody involved in the donation process. So there has to be a detailed review of the entire donor medical and oncological history, starting back from when they were young. A physical exam and gross organ inspection at the time of donation also has to be done. If you can preoperatively use imaging, CT and MR, more explicit imaging and tumor markers in high-risk donors. If there's a history, we really need to do targeted screening with a history of high-risk malignancies, and if possible, pathological examination intraoperatively at the time of donation. And there is an emerging role of liquid biopsy and AI for donor evaluation, and this really needs to be considered in the context of donor-derived malignancy. So in terms of the recipient also, immunosuppression and malignancy risk has to be considered. As we all know, immunosuppression can enable tumor proliferation if undetected cancer is present. Ongoing monitoring and potential for de-escalation or conversion strategies have to be implemented in all transplant centers. And again, we have to balance the risk of graft survival with that of cancer surveillance. So what are the possibilities? You can reduce or even in some cases withdraw therapy if a donor-derived malignancy is found. But again, you have to balance the rejection risk and cancer control. mTOR consideration should always be something that is thought of early as soon as you know there's a potential for a donor-derived malignancy because of its anti-proliferative properties. And this should be done probably early post-transplant, at least 4 to 6 weeks, depending on what your institutional biases are. In cases of non-life-saving organs, surgical removal of the graft or a metastatectomy is a possibility in patients with highly aggressive tumors. And even systemic chemotherapy involving our medical oncology colleagues should be considered in these cases. So again, the therapy has to be tailored for the balance of graft survival and oncological safety. And this again has to be a multidisciplinary approach involving oncologists, surgeons, and the entirety of the care team. So post-transplant monitoring in the recipient is probably one of the most important things we can do, because with early detection and immunosuppression modulation, as well as other interventions, the survival can be significantly increased, and hopefully we won't be talking about as high a mortality rate in the next several years. So we have to do routine age-appropriate cancer screening on all of our patients, but imaging and specific screening tailored to donor cancer risk should be implemented in those who are higher risk for donor-derived malignancies. And certainly there has to be prompt action on any aberrant findings to improve outcome. This includes all solid organ donor malignancies as well as liquid. Early detection, as I mentioned, we hope will result in significantly improved survival. And we have to remember that lifelong follow-up is essential for these patients. I am confident that my speaker has already gone through and will go through some of these guidelines, but I do want to point out that there are multiple guidelines which help us make these decisions. They're continually updated. The WHO and international publication, which is most recent, really emphasizes vigilance, traceability, and transparency. This is another way of looking at the data that was already been presented. I carry this image around in my iPhone so that when I get a call, I know how to stratify the donor risk, but these are important data to know. The summary of the current guidelines, I think, are the most important thing as a recipient surgeon that you have to remember. They're risk-tiered approaches to donors with malignancies. They will define which cancers are absolute contraindications and which may be allowable with caution. They all emphasize the primacy of patient safety and the necessity of specific informed consent for any elevated risk and importance of post-transplant vigilance and reporting. And importantly, they all also emphasize, although it's obvious, but we so often forget, the need to document that this consent has been thoroughly discussed with the patient. As data accumulates, guidelines are periodically revised to reflect new evidence, so this is also important because we have to constantly be reminding ourselves of the new updates. And ultimately, these efforts aim to maximize the donor pool safely, ensuring that no potentially life-saving organs is unnecessarily discarded, while still protecting recipients from preventable harm. So in conclusion, donor-derived malignancy is very rare, but its impact is significant, and we have to be aware of it as we accept donor organs, and especially in the high-risk urgent population. Careful donor selection, ethical consent, tailored immunosuppression, and surveillance are all part of how we can take care of our patients. Guidelines help standardize safety, but remember that they are continuously updated, so it's our responsibility to continuously look at them. There is a continued effort to better understand donor-derived malignancy, and this will hopefully improve recipient outcomes while also increasing donor pool utilization. I think the best example of this is CNS tumors, which we've all started to consider, which about 5 or 6 years ago we were all considering absolute contraindications, and all of those organs were being lost. There's increased research and standardization, which will improve patient safety and patient outcomes. Rigorous screening reduces, but does not eliminate the risk. Registry-based insights and innovation, genomics, imaging, et cetera, are key. And again, I want to emphasize that this has to be a multidisciplinary collaboration for safe transplant practices. So I think in terms of future direction for the recipient with donor-derived malignancies, we have to continually develop reporting to national, mandates for reporting to national registries to track outcomes of donor-derived malignancies. I think one of the places where this is most important is in hematological malignancies, where there is simply not enough data to really inform the decisions that we have to make. We need stronger consensus guidelines across transplant centers so that we're all doing the right things for our patients and for the generous donors who come forward. We should be using genomic profiling and machine learning to predict donor risk, and hopefully this will emerge in the next several years. And there has to be a greater emphasis on data sharing and reporting and multi-center collaboration in this field. And with that, I'd just like to say thank you for the opportunity to present.
Thank you very much. I think, sorry if you don't mind, just. Move on to the last talk of this session, and as I said earlier, following that, the speakers will be with us for questions and answers, and we have ample time for that. So, again, Dr. Brian Keller will be covering the cancer survivors as organ donors, navigating clinical insights and decision making. Dr. Keller, please.
All right, so the title of this talk is Cancer Survivors as Organ Donors, but I'm actually going to take a step back and approach the evaluation of a potential donor from a couple of different angles, because as you will see, there are a variety of scenarios where cancer in the donor may actually come into play. So the outline for the talk will be, we'll discuss roles in the donor malignancy assessment by various members of the team. We'll talk about novel approaches to donor malignancy assessment, and then we'll talk a little bit about transplant candidate-focused considerations, many of which were just covered by Dr. Baker. The objectives are to discuss the process for evaluating donors with a history of cancer, describe the importance of a multidisciplinary decision-making process to assess the risks and potential benefits of accepting such organs, and to explore some novel approaches to improve the use of donors who have a history of cancer. So the evaluation of the donor prior to transplant is truly a team effort that includes the donor's family and or representative, the donor hospital and organ procurement organization, and of course the transplant team, whose ultimate decision is whether to accept or reject the donor for their patient. In the case of living donation, the donor actively participates in sharing information, whereas in deceased donation, the donor or their surrogate may have provided important cancer-related information to the treating team, either at the time of hospital admission or even at the time of death in the situation of the donor's surrogate. In either case, this information provides the starting point for the evaluation and may shed light on the likelihood of cancer may play in the role of the donor assessment. Donors may have no history of cancer and be relatively healthy, both in cases of living donation and in deceased donation. Donors may also have a history of cancer that has been treated to the point of remission or even cure. There may be situations where some donors may not have a medical history to suggest cancer, but findings suspicious of malignancy may have been identified on imaging or through the course of the donor's clinical care. And finally, some donors may have active cancer at the time of donation. And with this may be cancer that has been untreated, maybe cancer that is currently undergoing treatment, or it may have been newly diagnosed during their current hospitalization. Irrespective of these different scenarios, the basic assessment is essentially the same, with some small adjustments for each particular situation. Now, there are some important differences in the assessments between deceased donors and living donors. With deceased donors, time is of the essence and decisions must be made on a shorter time scale. With living donors, the donor assessment can really be done over days, weeks, or even months, thus providing a cushion to kind of reach a final decision. Information may also be limited in the case of deceased donors, either because the donor or their surrogate were not able to provide information, or because the information is not readily available. Surrogates may have been estranged from the donor and not familiar with details such as cancer treatment and or resolution of the cancer history. These questions may not have also been asked at the admission to the hospital, depending on the donor's clinical situation. For example, in the case of an admission for a trauma such as a motor vehicle accident, cancer-related questions may not have been broached. With living donors, the donor is fully participatory in the process, and any missing information should be obtainable from either the donor, their surrogates, or from their treating physicians. Therefore, it is important to recognize the timeline and limitations for the donor in front of you when making your assessments. As I mentioned, the assessment of a donor is a team effort between the Organ Procurement Organization, or OPO, and the transplant team. Over the next few slides, I'm going to describe the responsibilities of each party to the process. And these responsibilities should complement each other, helping to get to the full story, or at least as close to the full story as possible. So let's start with the OPO and the donor hospital, which is where the assessment begins for deceased donors. The starting point in the donor assessment is gathering a detailed medical history. This is often accomplished using a standardized form for interviewing the donor surrogates. And in the United States, this form is called the Uniform Donor Risk Assessment Interview, or UDRA. And similar forms exist in other regions of the world. Regardless of the exact structure of the form used, it is important to gather information on known medical problems, previous surgeries, and habits and exposures, all of which could point to a history of cancer in the particular donor in front of you. Cancer should also be specifically queried as well, with attention to what type of cancer, the location of the cancer, when it was diagnosed, how it was treated, and what was the outcome of the treatment. This information alone can be critical in determining the relative risk from cancer to the recipient. Oftentimes, some or even all of this information may not be available, but it is critical to ask, as previously owned information may be elicited in the course of the interview. Just as important as the history taking is the role of the physical exam performed by the OPO or the donor hospital. Specific attention should be paid to identifying previously undiagnosed skin lesions, for example, a melanoma, that may not have come to light over the course of the patient's their clinical care. Or even masses in different parts of the body, such as a breast lump, as these can be the trigger for additional testing and even biopsy. In donors with a history of cancer, the OPO should attempt to obtain additional records, such as oncology documentation, pathology reports or results, and treatment history if it's available. The availability of this information likely varies from country to country and even between healthcare facilities within a country, so access to these records may be limited. Once the OPO has completed its assessment, it's now the transplant team's turn. And in the case of living donor donation and evaluation, the living donor transplant team essentially takes on the roles that I just outlined for the OPO in deceased donation. Utilizing the information collected by the OPO, it is incumbent upon the transplant team to carefully review the obtained medical, surgical, and other history. The transplant team also must carefully review any testing and especially imaging that has been performed and is available for review. For some cancers, findings may be obvious in or near the organ of interest, such as these pulmonary nodules on the CT scan shown here. However, abnormalities may also be seen in other areas of the body, such as this paratracheal mass on this second image, so it is important to approach reviewing imaging tests with a focus on a holistic review. It is also important to not be afraid to ask questions, particularly if something is unclear or information is missing. It is critical that the transplant team and the OPO and donor hospital work together to make sure everyone is comfortable with a donor before moving forward with an organ procurement and transplant. Finally, and most importantly, the transplant team must ultimately decide whether to accept a donor organ, balancing the risks of accepting the organ with a cancer from a donor with a cancer history or even an active cancer, with the risks of waiting for the next matching donor for their recipient. Oops, sorry about that. So when making these decisions about whether to accept a donor with an active or previous cancer, or even one with an abnormality on imaging that could be a malignancy, a multidisciplinary approach is critical. Now, different transplant programs, the approach to donor assessment can vary, with donor offers reviewed by the transplant surgeon at some programs or by the transplant physician at others. At our lung transplant program, all donor offers are first assessed by the transplant pulmonologist, who has an understanding of the degree of illness of the candidates on our waiting list. Suitable donors are then identified by the transplant pulmonologist and discussed with our transplant surgeon before final acceptance is made. We use this system for all donors, not just donors with a history of cancer, but I think it becomes even more important when you're considering a donor with a cancer history, as the discussion with a colleague can provide reassurance that all aspects of a donor's case have been reviewed fully. In addition, programs may want to involve an oncologist, a pathologist, or even a member of their hospital ethics board to further evaluate the balance of risks and benefits to accepting a donor organ from a donor with cancer history. Now, because donor offers can come through at all hours of the day, it may be challenging to obtain the input of these other experts in the middle of the night. And so it's recommended that transplant programs develop processes for commonly encountered situations. And that this may allow streamlining of the decision of whether to accept a donor in the middle of the night. Now, there's always going to be cases that fall outside of the protocol or the processes that have been established, and I think that's where it really comes in handy to tap into your local resources on specific cancers that you're not familiar with, or rare cancers for which there's no data on potential transmission risk. So following review of the clinical information and test results, it may be determined that additional information is required in the form of a biopsy. Coordinating a donor biopsy can be a challenging issue due to a variety of factors, including whether the donor is a living donor, a brain-dead donor, or a donor after cardiac death, the location of the donor and the availability of local resources, and finally, external factors such as time limits that may be imposed by the donor family or the donor hospital. The key here is early and effective communication between the transplant team and the OPO or donor hospital. Sometimes the biopsy may be needed before a donor can be accepted at all, and while at other times the donor will be accepted no matter what the results of the biopsy are, but the biopsy may provide critical information that will aid in the monitoring and treatment of the organ recipient should cancer transmission occur. What I've described so far is the current state of donor assessment, but is there more that we can do to facilitate the use of organs from donors with a history of cancer? It's not uncommon for organs to go unused based on the collected information, when in reality the risk of donor cancer transmission may have been extremely low or even non-existent. So how might we improve our ability to identify donors which are safe to use and which are not from a cancer standpoint? One area with the potential for use in the near future is that of national cancer registries. And in preparing this talk, I found that one of Saudi Arabia's earliest medical registries is the Saudi Cancer Registry, launched in 1992. Cancer registries like this one are typically used for monitoring cancer trends in a country and are primarily a data in, analysis out type of system. But in order to fully utilize the power of these national cancer registries for improving the safety of organ donation, we need to move from the one-way data in model to a bidirectional data in, data out model. In this new model, information on each malignancy are input into the registry with a linkage to the patient. When a potential donor is identified, the registry can then be searched to determine the cancer history of that particular donor, providing a central database of patient-level cancer data that can inform decisions such as organ transplantation, while also allowing analysis of local, regional, and national cancer trends. There's obviously some patient privacy issues that would need to be addressed in setting up a bidirectional registry system, but with proper safeguards, this may be an opportunity to streamline two very different areas of the healthcare ecosystem, both cancer care and organ donation. A second approach that was mentioned by Dr. Baker that is likely further in the distance than cancer registries is the use of liquid biopsy for cancer screening among donors. Liquid biopsy involves the analysis of various biomarkers from blood and other body fluids that typically require less invasive means of collection. Its potential in cancer screening has rapidly grown over the last few decades, and with the development of faster, more efficient, and more cost-effective technologies such as enrichment technologies, next-generation sequencing, and microarray, combined with the ever-expanding application of artificial intelligence, liquid biopsy will likely soon become standard of care for cancer screening and diagnosis. Currently, there are a number of liquid biomarkers that show promise or are being evaluated as targets for liquid biopsy. These biomarkers include everything from identifying circulating tumor cells themselves to identifying short-lived circulating tumor DNA using similar technology that we already use to monitor donor-derived cell-free DNA. Newer biomarkers include exosomes and their various components, a unique subset of platelets termed tumor-educated platelets that are increased in number in the setting of cancer and possess tumor-specific information, and then cancer-specific microRNAs and other non-coding RNAs. The utility of some of these biomarkers in cancer screening and monitoring response to therapy have already been reported, while others, like the tumor-educated platelets, are more in their infancy. Common to all of these biomarkers are complex isolation, enhancement, and detection technologies. And these various technologies can be expensive, they can be labor-intensive, and time-consuming. All of these factors are not likely to work well in our current time-constrained donor assessment period. So further improvements in these technologies are likely to get us to a place where liquid biopsy may be more readily applicable in the donor cancer assessment. The other current limitation to liquid biopsy is the number of distinct cancer-specific markers. As you can see in this schematic, for 8 representative organ-specific cancers, there are multiple markers for each cancer type, which would necessitate multiplexing cancer targets in order to accomplish more generalized screening in a single test. Thus, we are likely some ways away from realizing the full utility of liquid biopsy in screening organ donors for cancer, but I think the future is very, very promising in this arena. So returning to the current state of donor assessment, once all information has been collected, data reviewed, and risks assessed, how do we proceed with transplant using a donor with a cancer history, and how do we make sure our transplant candidate is as safe as possible? This was covered in detail by Dr. Baker, but just to reiterate, informed consent is imperative. And it's critical to discuss with your candidate the risks of transplanting an organ from a donor with cancer. Sufficient detailed information should be provided to the candidate to allow for true informed consent for transplant. This includes what the potential risk of cancer transmission might be, what steps have been taken to assess and reduce transmission risk, and an explanation of the monitoring strategy after transplant that will be implemented to screen for donor transmission. Alternatives to accepting this donor should also be divulged, including the option of waiting for a different donor and how that might impact the candidate's ability to receive a transplant given their current clinical state. Finally, in situations where a donor-transmitted malignancy has occurred or is suspected to have occurred, there are several key steps that must be taken. If at all possible, obtaining DNA confirmation of a match is key to determining a true donor-derived malignancy transmission. Second, recipients of other organs from the donor in question and their transplant teams should be notified of the potential or confirmed transmission. This allows them to increase surveillance for transmission in their patient or to identify transmission of cancer in their patient earlier. Communication to other organ recipients may vary based on national organ systems for donor-transmitted disease, and excuse me. And it could include reporting through a national system for donor-transmitted disease, such as the DTAC system in the US, or the system that's set up currently in Germany. It may involve communicating with the donor organs procurement organization or the donor hospital, or by contacting the receiving transplant programs directly. Next, the transplant program should reduce immune suppression as much as possible while still preventing rejection of the graft, with the goal of improved cancer immune control. Assessment of the risk to the graft and determining whether the graft should be removed, for example, in the case of a renal cell carcinoma transmitted during a kidney transplant, may be necessary, and that was discussed previously. And of course, early referral to oncology for cancer therapy is key. So to summarize, clinical insights and decision-making around the donor with a cancer history is a multidisciplinary process that requires cooperation between the transplant team, the organ procurement organization, and I would also include the donor and the donor's family or surrogates. Collection and review of detailed clinical information and testing allows for the evaluation of known and potentially unknown cancer in the donor. And there are novel methods for advanced cancer screening in donors that may include linkage with national cancer registries or the use of liquid biopsy technologies in the future. And finally, informed consent and close monitoring of the recipient post-transplant are key. So I just want to leave you with a few recommendations to consider. Consider evaluating for the presence of malignancy in donors and determining the relative risk of using organs from such donors. Create processes that facilitate the flow of information, including obtaining medical records, pathology reports, and cancer treatment histories to the organ procurement organizations and transplant teams so that streamlined decision-making can be made. Develop a bidirectional cancer registry that allows for the rapid determination of cancer history for potential donors. And finally, we need to continue to explore novel means of cancer screening, including liquid biopsy as an example, to improve cancer detection in the organ donor. And with that, I'd like to acknowledge again all of our patients and the donors who selflessly give of themselves to help others, as well as the conference organizers for the opportunity to be here with you all today. Thank you.
Thank you very much. I think we are again on time, so we have enough time to ask as many questions as possible. The two speakers are here, and the floor is open for questions, please.
Let me start with the Baker. Colon cancer is one of the commonest here, and it is not uncommon to have a recipient who has been resected like 2-3 years ago, T3N1. Now he is presenting decompensating liver disease. Will you consider these patients for transplant, or you say they are not cured yet, they have to pass the 5 years to consider them cured, or what is your view with this regard?
So it's a great question and a conundrum to all of us, because the traditional teaching has always been the 5-year wait period. But again, this comes back to shared decision making and really considering each patient on a selective basis. If you have someone who is 3 years out, has had a successful operation with routine monitoring, which has shown that they still have a disease-free interval at 3 years, they're in decompensated liver failure and obviously won't survive the extra 2 years, then I think it's a discussion between the patient, the family, and you, whether it's a risk that's willing to be taken. And certainly, we would consider significant immunosuppression modulation. Induction would be considered very carefully, probably with Simulect induction for its anti-cancer effects, which have not been proven, but are suggested by multiple studies, as well as delayed initiation of tacrolimus and possible initiation of an mTOR early post-transplant, and certainly post-transplant monitoring.
But will you consider these for deceased donor? Because this is a public graft, some patient in need of that. Would you still consider them for that?
Again, it's an individual decision. It's at the time of the offer. I would not rule out taking a deceased donor for that patient.
And what about repeating or doing liquid biopsy or ctDNA for these patients? Will you consider these mandatory, or if you don't have it, you will just pass it?
So it's a very interesting question because in North America, we have a very difficult time getting ctDNA actually paid for by the payers. So often, unless the patient has either grandfathered in or is able to be on some type of trial looking at ctDNA, it's a difficult thing to get. That being said, it's an incredibly helpful marker as we go forward. We are prospectively trying to enroll all of our patients who are on the transplant list who have a history of colon cancer, or especially our patients with PSC and IBD who have had resections, to do serial screening with ctDNA. So not mandatory, because it's difficult to make it mandatory because not everybody has access, but very highly suggested because it is an excellent tool.
Okay, from the donors who have had history of cancer, and that probably might be the focus here, would it be fair to say that the focus would be on life-saving transplants? In other words, would be liver, heart, and lung to a large extent. Would it be fair to say that, at least for whatever we'll do next?
Yeah, I think so. I think in cases where you have technology to support your transplant recipient, to buy them time and wait for a different donor, such as dialysis with kidney, you have that luxury. But things like lung transplant, liver transplant, where there's not really any way to support your candidate longer, and it really becomes an urgency or an emergency, then I think that's where we're more likely to accept those donors with cancer history.
That being said, I do want to mention that if you have a kidney patient, for example, who has a high urgency, I think an excellent example is somebody who's
Just kindly the microphone a bit, maybe, because I'm not sure
somebody,
of the
a
other.
kidney
Yeah.
transplant recipient who has a high urgency and is sensitized, and a good organ is offered that has a good match. I think it's difficult to automatically say no to that organ because although with the high urgency they should have access to more organs, it's possible because of their highly sensitized nature that they will have to wait a significant amount of time. So again, I think with each decision that you make, with each, it has to be an individualized decision based on the patient's status and urgency. So to say that kidney transplant patients shouldn't be offered patients with any type of risk of a donor-derived malignancy, I think is a difficult statement. You really have to consider who your recipient is and what their urgency is, not just based on the need for the organ, but where they are on the list. And then certainly include the recipient in the decision-making process.
If I can follow on, that's all right. Two areas in the journey post-transplant for a recipient of a graft from a donor with a history of cancer. I think the number one I will think of is, and we all agree that minimizing the immunosuppression is of paramount importance. And I think the one which really always been considered the culprit of the recurrence, the calcineurins. If so, I talk from the liver perspective, but you're covering different areas of transplant. How aggressive would you moving on to the everolimus as add-on, I wouldn't say an alternative, given its weakness as an immunosuppressive drug?
Yeah, I think it's an excellent question. If you want to address it from the lung perspective.
Yeah, so in lung transplant, we use a higher level of immune suppression than some of our colleagues in the other organs. We typically wait at least 6 months after transplant before initiating mTOR inhibitors, oftentimes because of delays in healing of the anastomosis. But we do use mTOR inhibitors if there's a concern for malignancy in the recipient. Less so across the board in a donor with a history of malignancy. Oftentimes we just continue to screen our recipient and look for malignancy there. But we use that. I will say in lung transplant there's not very good data and probably some concerning findings that transitioning off of a calcineurin inhibitor to an mTOR inhibitor strictly does increase the risk of graft failure, and so we're less likely to do that, more likely to decrease the doses of the calcineurin inhibitor and add on the mTOR inhibitor simultaneously. And that may be different than what you see.
I think in liver there's more room to, I think it's a great discussion because in liver there's certainly much more room to modulate the immunosuppression. So we would normally, as long as there are no significant issues, biliary issues or wound healing issues, drains, etc., at 4 to 6 weeks, consider converting to an mTOR. Again, induction with some type of anti-proliferative agent like Simulect, with delay in initiation of CNI inhibitors, and then hopefully transitioning by 4 to 6 weeks, and even going to single agent mTOR or mTOR with MMF or a very low dose tacrolimus. And generally the rule of thumb is something up to 10. So an mTOR at about a level of about 7 and the CNI inhibitor to make up to the 10.
If I can finish with my third area and with the questions, and that's the recurrence when it happens. Nowadays, cancer treatment largely becoming immunotherapy, and post-transplant is the major problem. There are few case reports, case series of trying it in liver transplant, and as far as I know, the kidney transplant. And of course, the risk, the major risk always will be bad rejection in liver setup, really. Recipients do die because of that. Where do we go from here?
Yeah, again, an excellent question, and I think the true answer is we don't know. I think you'd be very hard pressed to start immunotherapy in a patient post-transplant. I simply think, I'm very aggressive about this, but I think there's not enough data post-transplant to even consider it. There are several systemic options, and there are also local regional options, which can be very effective. We have a lot of tools in our toolkit to consider treating these tumors, whether it is a tumor that is localized within, for example, the liver, or the most common place of recurrence is often the adrenal glands, and those need to be monitored very carefully, or drop mets into the pelvis. So imaging is really key as you're surveying this. If you have a documented recurrence, again, it's a discussion with the patient, but I think starting immunotherapy would be very hard to do. I think modulation of immunosuppression, reliance on mTOR inhibitors, and consideration of other systemic options as well as local regional options way before you would even consider immunotherapy. I don't know if we're going to get to a point where immunotherapy is possible post-transplant. I'm not very optimistic, but we never know. We didn't think we were going to use immunotherapy before transplant until about 3 or 4 years ago. And now there was a recent publication which just showed that we can actually stop the immunotherapy 30 days before transplant and still have very successful outcomes.
Yeah, I mean, the BDL1 negative recipients, I mean, there are some data to show that they may be, they fare better than the others in terms of rejection. I mean, is there a place for expanding on these, really?
Yeah. I think it's still just, I don't think there's any data to support anything you would do.
Yeah.
But I would ask everybody, and I think that these international forums are so important, as we're kind of sorting out how we address these questions, it's really important that all of us agree to report our results, good and bad, when we are faced with these questions, because the only way we're going to answer them is by making sure that we're sharing data transparently.
Limited data. And maybe just move on, I think, unless there's some other questions here.
Yeah, thanks for the talk from all the panel here, and it was great. Just I am enlightening the issue about primary sclerosing cholangitis.
Can you raise your voice?
Yeah,
Because-
the primary sclerosing cholangitis sometimes incidentally found to be post-op in explanted liver. And people, they do well, and sometimes they don't do well. So there is a lot of work since 2020 to protocolize the immunotherapy and the chemotherapy on these type of diseases. So we can extrapolate this idea even in donors who have gene stable, let us say, who responded to chemotherapy. So after the transplant, there should be a consideration of some protocols for chemotherapy to cover maybe a remaining cells or something like this. So it's a protocol between chemotherapy and immunosuppression. And in primary sclerosing cholangitis, there's a lot of data coming now to inform that the protocol of chemotherapy should continue after transplant, not only pre. So thank you.
I have to apologize. I don't know whether it's me or the audio is not very clear. If you don't mind, just because I don't think that the...
Yeah, just in summary here, that when we do consider donors who have a background of cancer, the protocol of chemotherapy should be considered even post-transplantation. So if you have a gene stable and they responded to the chemotherapy, after transplantation, there should be some consideration and some protocols built up based on experience. If you go to the primary sclerosing cholangitis, the people, they were not with transplantation. Now there's a lot of reports coming. You can do the transplant for a patient, recipients, I mean, who are having primary sclerosing cholangitis with cholangiocarcinoma. So they can go for transplantation, but post-transplant, there should be some protocols for chemotherapy. So it's the same also for donors and for colon cancers and so on. So the chemotherapy should continue even post-transplant.
What do you think?
Yeah, I'm not, I will say in our practice, and I'm not aware of practices where empiric chemotherapy or cancer treatment is continued in a recipient of an organ from a donor with cancer. I believe our practice is surveillance and starting therapy if it's detected, and I think that falls on the incidence, like the risk of transmission is very, very low, and so I think a lot of it is we would be treating a lot of people that would not receive donor-transmitted malignancy, and you do have some risks from those therapies, the chemotherapies, but I'm not aware of people going ahead and empirically using chemotherapy early after transplant, given the risks of infection and things already with the immune suppression. Do you know, Benny?
I'm not aware of any incidents of that as well. Certainly in recipients who have a history of cancer, like cholangiocarcinoma, who are transplanted, there is data for restarting, extrapolating from the advanced biliary cancer trials, starting capecitabine at 3 to 6 months post, but not from potential donor-derived malignancy. This is from recipient native malignancy. I don't know of any data from donor-derived malignancy where there's been empiric chemotherapy, and I agree 100% that it would be difficult to impose the risks associated with chemotherapy when the incidence of transmission is so low.
The idea here is that you have to come out from the high immunosuppression use in the first initial transplant till he's stable, and then you fade out the chemotherapy. That's the idea there. So I don't know if there's any international work on this or not. That's why I raised the question.
Yeah,
Thank you.
it's a great question. I just don't know of any current
I
literature.
think if you are talking about cholangiocarcinoma, there are protocols already been in place. I'm sure this is evolving really. The Mayo Clinic protocol is there, and that largely is pre-transplant preparations before undergoing the transplant itself, both in terms of therapy or chemotherapy and so on before that. But I'm not sure post-transplant whether...
No, the idea that the MD Anderson and even my clinics are doing it now post-transplant as well.
Yeah.
So they continue for a while till you adjust your immunosuppression to a level that's acceptable. So
Yeah.
the risk of like flare-up of the cancer is less.
But the issue remains about the recipients from donors who had past history of malignancies or cancers, and whether once it's removed the high-risk ones, whether the benefit-risk justifies giving chemotherapy post-transplantation for this, given that the risk is very low.
There is no more question. Thank you, everyone, and we will close this session. Go for a break, and we'll come back.
which will be focused on innovation in transplantation in the digital era. We're going to talk about artificial intelligence and transplant medicine, focusing on a decision-making and outcome, as well as using an algorithm. Our first speaker will be Dr. Mamata Bhatt. She is a hepatologist and clinician scientist at the University Health Network. She is currently an associate professor at the University of Toronto. She earned her medical degree and residency at McGill University, followed by a transplant hepatology training at Mayo Clinic. She also earned Canadian Institute of Health Research Fellowship that led to PhD in medical biophysics. Her research focused on enhancing liver transplant outcome using artificial intelligence. She had multiple publications in top journals, as well as multiple awards from CASEL, as well as the American Society of Transplantation. Our first topic will be about artificial intelligence in transplant medicine, enhancing decision-making and outcome. Welcome, Dr. Bhatt.
Hey, well, good morning, everyone. It's a pleasure to be here, and I'd like to thank the organizers for the kind invitation to present on this topic to all of you today. So I co-lead our Transplant AI initiative at the University Health Network, and I lead a team of highly interdisciplinary researchers, particularly heavy on the computer science skill set, so postdocs and graduate students in computer science. So it's really a pleasure to lead this team wherein we have highly interdisciplinary discussions around how to optimize outcomes of liver transplant using AI. So in terms of my talk, I'll be going over what is AI and how it is highly relevant to use in transplantation. We'll talk about various projects that my group has worked on in this area, and just to offer you some insights as to how one can develop AI tools that are very specific to the clinical nuances of questions in transplantation, including predicting dynamic trajectories on the wait list, optimizing post-transplant patient survival, and optimizing transplant survival, graft survival in liver transplant recipients. So first of all, I'll start off with why AI in transplantation. So what is artificial intelligence? You heard about a bit of this from Dr. Klein yesterday, who very nicely provided an overview, an introduction as to why AI is interesting for use in transplantation. There's great opportunity. So basically, AI is intelligence demonstrated by machines and learning from large data sets in a goal-directed manner. And so there are various applications across the healthcare space, as you can see here, in terms of medical image analysis, AI-assisted robotic surgery, as well as various insurance-related AI tools. So lots of different types of AI tools that are already in use in healthcare. Now, why AI in transplantation? And I particularly work in the liver space. But the reason for this is, especially as a hepatologist, I was identifying, or I realized that I was working a lot with patterns and data. And, in our field, in transplant, we deal with such a complex patient population, and we want to do the best we can for that individual patient in front of us. So the reality is that guidelines don't apply to, we can't use a one-size-fits-all approach, because the reality is that every person has their own individual history, as well as their own individual trajectories in terms of their blood tests, et cetera. So there are complex patterns in the data that we're constantly trying to integrate in our minds to come up with personalized predictions for the given patient in front of us. But the reality is that the human brain can only account for 7 variables at a time. And this has been shown in the AI literature. So how can one improve predictive performance and learn from large data sets to really then ultimately individualize for the given patient in front of us? And that's where AI can serve as a co-pilot in decision making. And so these are all figures taken from various reviews that my group has published over the last years. This one is from Journal of Hepatology a few years ago. I think particularly in transplant, what's interesting to me as a physician is the ability to potentially bring greater objectivity to the decision-making in transplant. There's a lot of subjectivity in terms of the decisions we make in transplantation, and so, you know, this is a great opportunity to bring greater objectivity. And these tasks include identifying suitable donor organs, waitlist prioritization, donor-recipient matching, and optimizing outcomes. Now, certainly if there's biases in the data, the models will learn from those biases, so one has to be very cautious, of course, moving forward. Okay, so I'll start off with a few key projects in the transplant space around objectivity and decision-making, as well as waitlist prioritization and dynamic trajectories thereof. So first of all, this is a project wherein we used agentic AI. So AI agents are really nascent in the field of healthcare. They have been used in industry quite a bit, but in the field of healthcare, quite nascent. And so, you know, I was very interested in looking at whether we could bring greater objectivity to decision-making in our field using AI agents. So AI agents are basically large language models that can represent the domain of expertise of different individuals. So for example, on this AI selection committee, we had an LLM, or a large language model, representing the expertise of a hepatologist, of a surgeon, and then separately of an anesthesiologist and a social worker. And then basically those 4 different specialists reviewed over 8,000 cases, so 7,000 of whom had been successfully transplanted, and we looked at 1 year survival as a surrogate of the fact that they were a suitable candidate for transplant. And then we had over 1,000 patients who had absolute contraindications to transplant. So our AI selection committee was comprised of these 4 specialists, and then each of those specialists reviewed those over 8,000 cases and then came up with a decision around whether that patient was suitable or not, as well as providing a rationale. And so we used OpenAI and we used prompt engineering to ask these questions of these experts, and then finally ask them to discuss amongst themselves, so the LLMs, to then come up with a decision around whether a patient was suitable or not for transplant. And in fact, our AI selection committee was able to accurately identify those patients who would benefit from transplantation and identify those with absolute contraindication. So 92% predictive accuracy in terms of post-transplant survival. So thus, you know, providing the opportunity and, you know, highlighting the potential to have, say, an objective you know, member, an additional member of the liver transplant selection committee that would provide an objective voice there. Okay, and then secondly, this is another you know, project in this space on the pre-transplant side of things, looking at inequities in liver transplant allocation. So certainly, as you know, Dr. Kim gave a wonderful talk yesterday about his tremendous body of work on the model for end-stage liver disease, and certainly, you know, this is objectively decreased waitlist mortality for the overall waitlisted population. Now, this project was inspired by, again, inequities in terms of liver transplant allocation that I was witnessing as a hepatologist. And in our jurisdiction, unfortunately, we do have a very high waitlist mortality of 25 to 30%. And so I was witnessing these inequities in our system and certainly felt compelled to do something about it. So one was the important disadvantage to female patients. Certainly the MELD 3.0 rectifies that to an important extent. However, there are various other complexities. So the reality is that there's so many factors that are actually involved in predicting the risk of waitlist mortality or dropout. So there are patients, obviously, with PBC or PSC, cholestatic liver diseases. As you know, in the MELD 3.0 or MELD sodium, the bilirubin is underweighted, and hence, and that's because it was trained on a parenchymal disease-heavy population. So cholestatic liver disease is certainly going to be disadvantaged. So patients with PBC, and then also there's been a shift in the underlying patient cohort. Additionally, we want to highlight it we wanted to incorporate dynamic trajectories on the wait list, because certainly patients with acute on chronic liver failure, when they have rapid deterioration within a very short period of time, we intuitively know that they're actually much sicker than their instantaneous MELD would suggest. We know that we have to act quickly in order to get them an organ offer if they have a very high MELD score that is developed in a very short period of time. So what we wanted to do here was actually develop a dynamic model of end-stage liver disease for fair risk assessment. And this was driven by a computer science PhD student under the supervision of myself and a computer science colleague at University of Toronto. This is funded by our Canadian Institutes of Health Research. So he trained a deep surf model, which is a deep learning version of a Cox proportional hazards model, on over 53,000 patients with decompensated cirrhosis without exception points. And we included 13 static and time-varying covariates, excluding some of the more sort of subjective factors such as ascites or encephalopathy. But the interesting thing that we added on, and this was the computer science student's idea, actually having, come to my clinics and understood the clinical problem in greater detail, he incorporated rates of change, so velocity as well as acceleration over time on the wait list. And by doing this, actually, we had a higher concordance index, 90-day concordance index in terms of rank ordering by risk score versus rank ordering by time of death or censorship within 90 days with our score, which we called Dynamel, so 0.818 was the concordance index. And then looking at fairness, so we looked at a measure of fairness, which is a pooled group concordance index, and this is the concordance over pairs where the first member is part of a defined protected group. So in this case, women or PBC, other subtypes of patients who are currently disadvantaged. I'm sorry for this unusual, I think the format or the font has sort of changed, switched around here. But basically women and those with PBC and small statured patients particularly would benefit from this consideration of dynamics as well as individual risk factors such as, indication for liver transplant, PBC, or PSC. So then we did what's called Shapley analysis. So this is providing interpretability to the output of the predictions. And this is quite important in my mind to engender trust, instill trust among physicians as well as patients in terms of the predictions that are made by the algorithm. So here we have a deep learning algorithm and we applied Shapley analysis, and then we look at the top SHAP factors. So reassuringly, these are the factors that are used in the MELD 3.0 currently. So creatinine, bilirubin, or albumin, sodium, and patient sex. However, for many patients, the fact that they had a change over time, so the velocity in those various blood tests was actually pretty important. So each of those dots represents patients for whom that is the most important predictive factor in terms of their risk of waitlist mortality or dropout. And then the fact that they have PBC or PSC as well, you can see here, those are all important factors for those subgroups of patients. So what we're trying to do here is try to be as helpful to the overall patient population, but also help those patients who've been relatively disadvantaged thus far. So then you can obtain individualized interpretations. What is the relative weight of those different factors in the prediction? And then we can look at the dynamic trajectories of these patients. So for example, this 50-year-old woman with PBC, the fact that she had PBC was initially the dominant reason for her risk of waitlist mortality or dropout at 23 and 88 days after listing. But by 132 days, the fact that she was started on dialysis in the recent past was the most important factor predicting her risk of waitlist mortality or dropout. And that's actually very important for the clinician also to appreciate. They know this intuitively, but the fact that this model has made a prediction and said, okay, that is the top reason why I'm making this prediction, and that helps the physician have better trust in the output of that model. So next what we did was we then proceeded to a silent trial of this model within EPIC. So we have a data engineer who works very closely with our team at the Transplant AI Initiative. And basically he ran, did both the back end and the front end. So basically, he brought this as a dashboard into Epic, into a silent testing version of Epic, and has coded it such that those variables are pulled automatically from Epic to a cloud and then fed into the dashboard to provide individualized predictions for patients. And so, you know, there's nothing to input manually except for the dialysis status here. So here what we have is basically the dynamics over time, and then you have the SHAP analysis showing which are the factors, what is their relative weight on the prediction, and then what is the relative risk of that individual patient compared to all other patients on the wait list. So we actually ran this on over 400 patients in our liver transplant program as a silent trial to see dynamically how our score would have helped, especially those subgroups of patients who are currently disadvantaged. And we also basically then looked at how many would have been up versus down ranked. Clearly, there are going to be patients who are down ranked, but these were patients who could wait, we anticipated, for transplant. And so this is a nice illustration of how one can deploy a deep machine learning model via our electronic medical record system without having to input all of those parameters. So this is all automated. Okay, so next there are various other types of tools in transplant that are getting deployed out there. So I just wanted to highlight a few others. I think, you know, this is one interesting model at our own institution that is being used and deployed to predict the outcomes of allograft function. So I welcome you to, just so all of this was not too liver focused, but in the same space of pre-liver transplant, to predict the suitable use of organs. And so they leverage various physiological donor as well as recipient characteristics to accurately predict lung allograft function post-transplant. So very nice study there. This is another study that we ourselves have under review around matching patients. So basically this is the simulation of a clinical trial wherein we were comparing the outcomes of living donor versus deceased donor transplant. And so the idea here was to match those patients for various clinical factors and then identify over time, you know, those patients who had those match factors. So we matched them for 6 to 7 patient clinical characteristics to then look at the relative survival benefit of living donor versus deceased donor transplant. And we were able to generate this individualized survival benefit. And the idea here was to simulate a clinical trial with observational data. So we used a certain model called, and we developed this as a new model called decision path similarity matching to reduce confounders. And overall, it was quite well performing with an ROC of 0.83. Okay, so now I'll conclude with the section on graft survival, optimizing graft survival. So I think it's very important, as I mentioned earlier, to realize that it's possible to develop new tools to suit the clinical nuances of the questions in front of us. So I talked about Dynameld, for example, and then the more recent one, the DPSM. So in this study, what we wanted to do was predict the presence of significant graft fibrosis in liver transplant recipients at a given point in time. So this was a project led by a computer science postdoctoral fellow, Divya Sharma, in my group, and so she basically considered 29 longitudinal clinical and laboratory variables to predict the presence of significant graft fibrosis. But what she did was, because the data set was limited in terms of the number of cases vis-a-vis the controls, she then upweighted the training on the cases. So she incorporated something called a weight loss function to minimize bias and to upweight the training on the cases. And by doing that, she was able to achieve better performance with this new method, which she called weighted LSTM, or weighted long short-term memory network, as compared to the standard long short-term memory network. So these are say, deep learning algorithms that leverage longitudinal changes in data. And so with that, we had an AUC of 0.798. And then these were the top ranked features. So Shapley analysis on the right shows you recipient age, donor age, transplant primary indication as the top 3 features there that were predictive for the overall population, but then you can again individualize for the single patient. So now what we're doing is, and this was published in Lancet Digital Health a few years ago, but basically now what we're doing is predicting into the future, so 1 and 5 years into the future, which would then guide, say, performance of liver biopsy and individualized therapeutic strategies, perhaps modification of immunosuppression. So we did consider the tacrolimus level, sirolimus level, et cetera. And then what you could identify is whether in a given patient it would be appropriate to increase versus decrease immunosuppression. Now, this is the final study I'll talk about in this context. So we were interested in developing a model that could classify the causes of graft pathology. So as many of you will be aware, over 50% of our liver transplant recipients will have increased liver enzymes over time, and these are due to various causes. We often will start with an ultrasound with Dopplers, followed by liver biopsy, but liver biopsy has certain inherent risks, and we often perform it with a delay. So the reality is that we make subtle changes in the management of the patient before we get that liver biopsy and its result. And so, which isn't the ideal, safe situation. So, for example, a patient has a certain profile with test patterns, and it's a diagnostic puzzle. So what you have is a certain prediction. So each physician will make a certain prediction based on the patterns and the data. So what we wanted to do is simulate that. My postdoctoral fellow, Divya, at that time, basically developed a multi-class artificial neural network. So it's not a binary outcome, it's a 6-class prediction outcome. And basically, she was able to develop this multi-class ANN to predict whether patients fit into the categories of rejection, MASH, biliary obstruction, et cetera. So you can see that here. AUC average was 0.866. We then looked at the performance of this algorithm versus medics in our program, so 12 hepatologists, and the ML model was better performing. And then we identified that certain cases were not actually identified properly by the ML model. So then we fed clinical decision rules that were identified by physicians. Actually, some cases were identified by physicians, but not by the ML model. So then I told her, please feed some of these clinical decision rules to the model to teach the model better. So we brought the human into the loop to teach the model better, and in fact, that increased the performance. Finally, we did external validation of this refined algorithm. So we then validated this. We sent the code to Mayo Clinic in the States, then Singapore, and UHS in Singapore, and Hanover in Germany, and basically they were able to validate this algorithm, representing, really the generalizability of this algorithm across 3 continents. So, which is a very nice illustration of an AI tool being generalizable across diverse settings, because the clinical question in itself is a relatively sort of stable clinical question, not as susceptible to environmental factors. So in conclusion, certainly in transplant, we have such a complex patient population, and we want to do the best we can for the given patient in front of us. The reality is that one size doesn't fit all. There's so much complexity, and AI tools can really learn from large multimodal data sets. So if you have, say, there are newer types of tools, including multimodal AI tools that can bring together, fuse different types of data, whether it's clinical data, radiomics, pathology, et cetera, trying to simulate what the human brain is trying to do to generate individualized predictions for the given patient in front of us. I think the next years are going to bring about, clinical trials of AI tools, as well as AI agents, multimodal AI. These are all, the next frontiers in AI, and certainly there's a lot of opportunity for AI in transplant. So I'd like to acknowledge our Transplant AI initiative and my excellent collaborators as well as group, and welcome any discussion and collaborations. Thank you so much.
Our next speaker is a physician, a scientist, academic researcher, and a leader. Muhammad Hani Timsah is a pediatric intensivist. He's a professor. He is leading the pediatric intensive care unit in King Saud Medical City, King Saud University. He has been recognized among the top 2% of academic researchers globally in Stanford University's annual reports. And he was recently honored with Excellence in Health Research Lifetime Achievement Award in Saudi Arabia 2024 for his outstanding scientific contributions. His citations exceeds 100,000, and his main interest is pediatric critical care, vaccination, critical thinking, ChatGPT, and pediatrics. Welcome, Professor Muhammad Hani Timsah.
Mr. Chairman, thank you. Thank you all for the kind invitation. I know it's third day of the event, so unfortunately I missed the first couple of days, but hopefully we'll catch up. And thank you, Dr. Abad, for paving the issues for me, because you made my life easier in my next slides. So basically, I'm gonna just try to shift a little bit about our AI innovations, technologies. I'm a member of the AI lab in our King Saud University College of Medicine. It's still less than 1 year old, so it's still under the pediatric dimension. So, but I hope that this is really an excellent topic to explore, because this is the future is now currently. And the way I will go through some slides, I just wanted to shift gears about how we could utilize it, how we could a mixture between our local national champions, both in healthcare fields and in data science, and also the international collaborations that will be, I think that's the best mix at this stage. So basically, I have also no conflicts of interest to declare, except that I use, of course, everyone is using now, like ChatGPT or other models. So we are not promoting any, we're just utilizing them to improve the language. And as I told you, I'm just gonna focus about our national insights, and as well as highlight some potentials. And in particular, in my background, I'm from the Pediatric Intensive Care Unit at King Saud University Medical City, and also how we could apply some real-life examples and how we could utilize it. I'm going to show you a couple of examples how you can actually utilize it now, even before you have your own established AI models. Again, as Dr. Abad mentioned, there are several ways that the AI is being implemented currently, and I think it's time for us to catch up and even exceed in these potentials, whether from the pre-transplant to the prediction in the transplant rejection or acceptance, the post-operative patient outcomes. And already she addressed beautifully how to facilitate the personalized medicine in a transplant approach. I'm going to focus a little bit about how we could have a responsible AI use, and how we are respecting our, not only the patient, the donor, the families, the society values, but also at a moral level, going how we could utilize this co-pilot, as Dr. Abad mentioned, how we can utilize it appropriately without being overused or underused. Again, as you know, in Vision 2030, the AI plays a pivotal role, and the SADAIA is issued several publications about how to utilize these models, and I'm gonna put the QR codes for you to go to access the full papers. It's beautifully made. Maybe some of us did not go through them, but I would really advise, because they are really inclusive. And again, these are the laws that we must abide whenever we are talking about utilization of our clinical data into building AI models or applying these models concepts. Again, generative AI models already, as in the previous topic, it was mentioned how the large language models could be utilized, especially in accessing the more widely now accessible electronic health records. So some of these electronic health records, they don't have the full or the accurate ICD coding. So this is a valuable tool that it could be incorporated of generative AI models inside your EHR to pull out the data more, and hopefully it could be utilized more, keeping in mind that the AI is still not accountable. So the AI company is not accountable for the actions we do when we utilize any AI model. So it's us, the clinicians, the healthcare providers, we are the one accountable. So it's just to augment our decision abilities and not to replace them in whatever needs. Another important document I wanted to share with you, a few main points from it, is this, again, the AI ethical principles, again issued by SEDAIA, and I would really advise you to take it, keep it there, because you may need to reference it in your, whether academic writings or in your proposals whenever you do that. So this is, it's in its table of contents. They listed the main principles, which I will just go quickly through them: the fairness and integrity, privacy and security for our patients, reliability and safety of the AI systems, transparency and interoperability, accountability and responsibility, humanity and the social and environmental benefits. So all of these are beautifully written. These are just snapshots from this well-illustrated reference for us. Oops, so I'm having sorry for that, it's going back. Okay, so again, it's always, whenever we talk about AI models, we are talking about the roles and responsibilities, how we can keep this delicate balance between what the authorities, the regulations are there, and between the adopting entities, how we can adopt them in a ethically right framework, and also at the same time in a rapid way to adapt them. This is one of the recent publications. I just wanted to show you about one potential brainstorming you could already have with your AI, whichever large language models you're using. For example, this is a paper, I think it was published 2021, about the organ transplantation in the Arabian Gulf countries, about the ethical and legal practices. So what I did, I just thought, why don't I just take this paper and put it into my AI model and ask it, prompt it, what can I use from this paper? And it immediately gave me some ideas. For example, brain death criteria standardization among the Gulf nations. Is it yet there, or it's another, hopefully something to come in the near future? The informed consent support. So again, the large language models could help us in translating and explaining complex medical concepts in culturally sensitive manners. About how to combat the organ trafficking risk, since there are some various legislations across the region. So the AI suggested, why not to have a predictive analytics to flag unusual patterns in donor-recipient matches. So this is all building a brainstorming of what's currently in the literature to take it a step further. Another one, the willingness to donate monitoring. So the AI can analyze data, and it can suggest regions or demographics with a low donation acceptance, since the donation acceptance is already in the digitalized Tawakkalna healthcare app, and it's still underutilized. So this is something that could be improved, supporting the regional and collaborations, building AI-powered dashboards, as Dr. Bat showed also in her work, in her research, not only at the national or at the hospital level, going beyond the borders. Okay. Shifting gears, I went again and I went to one of our research that we published together, including esteemed members from the SCOT. So how can the AI advance to the next steps in organ donation awareness in Saudi Arabia? So this is something that we could really utilize it at this stage, because I don't want to wait a few years more. I want to do it from now, and it's doable. So I went and I asked this question, and it immediately gave me some more thoughts-provoking that you could discuss with your research teams, with your colleagues. So how can I have, maybe I can have a personalized awareness via the same tawakkalna, but with more AI integration. Again, it's doable. How the large language models could help us to address possible misconceptions, which are many misconceptions still circulate around. So how can I utilize them? How can I do predictive targeting for the awareness campaigns, which we have seen several beautifully made awareness campaigns, but can I optimize them? Can I target really the right audience in such awareness campaigns in our country? About also as you did in your the conversational AI app, how can I do it to also to support our SCOT team with a virtual assistant that could be available 24/7, not waiting for the working hours to be there. So this is something that can be done. Correlating the public sentiment with the registration trends. So this is something you could easily do it, since you have the data, we are having live data. And this is something that could really empower our nation towards further excellence in its transformation. Outcome benefits are hugely coming. And this is one recent paper, I think it's just this year, so I didn't go through it here, but maybe you can scan the code. It's a narrative review about going from theory to practice about AI at the bedside, so you can also go through it at your own time. Risk mitigation, of course, the risks are there. Whenever we are utilizing the data, we have to be aware, are we utilizing the public data, publicly available, or are we having a private data that requires special protection under the Sadaya and the Saudi law? And this is the personal data protection law that was, I think it's 2024 or 2023. But we have seen in last year, several of the companies, the banks, they sent us a new consents for us, because there is now the data protection is more empowered. So we have to be careful that we are really abiding by these data protection whenever you're utilizing or sharing the data, avoiding any potential of re-identification risks. So even if we are using a coded data, we have to make sure that powerful AI models could not re-identify, and then if there are third parties could abuse such data in that aspect. Think about the AI tools, if they are open or property AI tools, so these are some things to keep in mind. Again, as you all are aware now, so the AI and transplantation is it's gonna just grow further and further, and we have seen how exponential growth is occurring in this arena. So it's time to define our clinical problems, get the team diversity, and I really enjoyed how a team from the Dr. Abad team that there is the IT specialist. He raised additional points about the model, how to incorporate them, how to enhance them, and this is the beauty of having the diversity in our teams. Documentation of our models, so it's very important to document which model you are using, which date you are using, because these models, they evolve so fast, so it has to be done which model is used, and if you are reporting it to the literature to ensure that they are reproducible for our results. Continuous monitoring, of course, they need to be audited post-deployment, and in conclusion, just to be on time, hopefully, So AI is becoming more than a prediction. It's becoming a co-pilot that could really enhance and humanize the transplant delivery. Saudi Arabia has a unique digital tools, and these could be leveraged towards empowering our data scientists, our national healthcare professionals towards further improving and bridging the cultural, religious, and emotional gaps. So this is important to keep in mind. The data also from the Scott or other tertiary hospitals could be really integrated into a beautiful models that could be utilized, hopefully with more interdisciplinary collaborations between our clinicians, our ethicists, our AI developers, and hopefully we will have more adapted and more culturally sensitive solutions. And with that, I thank you for your time and happy to take questions together. Thank you very much.
Assalamu alaikum. It's a pleasure for me to introduce Dr. Sani. I can have like an hour to introduce Dr. Sani, but he has a special request. He just said, introduce my name only, and I think that's enough. So Dr. Sani, he will talk about the donation advisor tool, which is an AI algorithm to predict the time to death and standardizing donation after DCD eligibility assessment. Dr. Sani.
Thank you. I had the pleasure of meeting many of you yesterday, so I appreciate not going through the formalities of the first few slides. Again, you can connect with me on LinkedIn, and I'm very appreciative of being here, the organizers, and the two speakers before me. I think they really laid the groundwork. I aim to present how AI is now a potential use in the donor. So an example of what we've been talking about, I think Mamatha talked about the transplant recipients and selections, and I'm going to start a little bit earlier than that. I do have a conflict of interest, and then I'm going to talk about a clinical decision support tool called Donation Advisor. I have a patent on that, but no commercial entity at this point. Yesterday, I spent most of the day promoting donation after circulatory death, the benefits of it, and how it helped most countries in the western side of this globe, in North America and Europe, to almost double the potential number of donors and transplants. However, there were some setbacks. In fact, when you look at the outcomes of DCD versus brain death donors, that the outcomes of these grafts are actually as good as brain death donors now. So that's an amazing thing. It didn't start out that way. But we've also recognized that the number of organs per donor for DCD is much less, around 2 organs per donor, whereas brain death donors have 3 to 4. The reason for that is ischemia. DCD is a success, but it's still an occasional event. And what's really key for DCD over brain death donation is the timing of death. Because for DCD, as you start withdrawal of life-sustaining therapy, blood flow goes lower, saturations go lower, eventually to anoxia and aperfusion. These means these organs are then going to be transplanted in a semi-ischemic state. Now, organ reperfusion is changing that, but right now, this is the current state. For kidneys, they're pretty strong. So most transplant teams will accept them after 2 hours of withdrawal, what we call the dwindles, from the start of withdrawal to death determination. For other organs that are more sensitive, like the liver, actually surgeons only wait half an hour. And if it's at 31 minutes, those surgeons will what we call stand down and not recover that potential organ. So when we assess a donor, we actually look at the potential for them to pass away and die within that 2-hour limit, starting from withdrawal life-sustaining therapy. There are so many factors: how sick they are, whether they're, what ventilation they're on, how many pressors they're on, how large they are, how old they are. And often, these are very subjective decisions. And sometimes DCD is not even offered. So they are not brain dead. They might have wanted to be a donor, but the clinicians say, we don't think they're going to die in time. We are not sending our transplant team, and DCD is not attempted. However, in our jurisdiction, we almost always try to go forward with a DCD process, even if we think it's unlikely. And in fact, what we've seen is 30 to 50% of the time, we get it wrong. That means we send transplant teams there, we tell families they're going to be a donor, and they don't end up being a donor because that individual dies after the 2-hour limit. That's terrible as far as efficiency for those transplant teams. And what about for that family? They've already had a loved one lost, consented to donation, and now lost that opportunity. We need to do better. We recognize that the inability to predict which patients will be a successful DCD donor and which organs are suitable for transplant because of this ischemia profile is still too unclear. And there's lots of evidence of the harms of DCD. So we said there must be tools to predict who's going to die in time, and there are. But we don't use them because they're not good enough. I was at a conference like this almost 10 years ago with a gentleman named Andrew Seeley from Ottawa. He's a thoracic surgeon and intensivist. We were playing tennis. I lost badly. As a result, I had to buy coffee. After that tennis match, we started thinking, how could we solve this problem on the back of a napkin? I realized that his work in variability chaos science, which looked at heart rate and blood pressure and oxygen variability in an intubated ICU patient, was predicting outcomes. He was working on sepsis. And this had been done before. Think about fetal heart rate monitoring. When it goes bradycardia, or in fact the variability decreases, we rush for a cesarean section because outcome is going to be poor. It's the same thought process, but at the end of life. And we realized that if we monitor dying patients, we could incorporate those models into a prediction tool. We had a team of scientists. I'll highlight Nathan in the middle, who's our biomedical engineer and our AI specialist. And we recognized that the study we had done a few years at the same time, looking at dying patients, 600 dying patients in 3 different countries, we had a lot of data that could then be analyzed, blood pressures and heart rates. You might notice the green one, very regular, with low variability because this patient is dying. If we took this and analyzed this, we created a model with a derivation cohort and a validation cohort to see whether we could identify a pattern not based on anything clinical, just the physiology. From there, we use machine learning things that have been nicely explained using simple logistic regression, using Shapley examinations and random forest, and stacking them to see if we could bring in all the clinical things that we're using, all those other prediction models, as well as this new physiologic basis to create a better clinical decision tool. And in fact, what we found was the variability assessment on its own had an AUC of 0.77 to predict accurately between 30, 60, and 120 minutes of death. But when we added all the other clinical predictions, including what the bedside physician felt was going to happen, that we could raise that to 8.3 and in fact to 8.8 eventually. We recognized for clinical use, it was better not to use numbers. So what we did is split it into a high predictability of death a medium predictability or a low predictability of death within a certain time period. That was the first thing we did. We also recognized that if we use that variability science during withdrawal assist, that dwindle period, that we could actually help clinicians, the transplant surgeons, look at what was happening to those organs, kidneys and livers and lungs, to the ischemia profiles. Right now, they get a standing at 30 minutes, a blood pressure and a saturation. We were going to continuously monitor them along the entire course of their withdrawal to create an ischemic profile, and I'll show you that in a second. What did we actually do? We took this tool then, after the decision to withdraw life-sustaining therapy, after the decision to move forward with an organ donation, and then took the data that was already being collected for donation and inputted it into our tool. We added in the physician prediction and then monitored the patient, collected lots of gigabytes of data, and quickly turned that around. Within a 5-minute process, we're able to deliver a report to the clinician and say the likelihood of dying within 2 hours was X. Then, this is kind of an example of our organ donation eye transplant tool that just downloads the data directly. The forms were initially the vital signs, which includes things like medications and pressures. There's about 13 clinical parts to this. Eventually, we thought about CT scans, but they didn't help us at all, and other things, culture results, didn't help us at all. What did help us was the subjective prediction of the physicians, in fact. So we made sure that was included. And we did a feasibility trial. Now, this feasibility trial, we did not plan to actually use it in real time. We used our tool, but we didn't deliver the information in real time because we didn't want to, in this initial step, change the outcome for donors. As we did this, we then interviewed the clinicians after the fact with the tool for the donation and critical care physicians and the ODO. We gave the pre-donor assessment to say this is the likelihood of dying in time. And for the transplant surgeons, we added in the ischemia profiles. And we asked them, would you have used this? What was beneficial? And in fact, this is using evaluation science, which we talked about yesterday, to adapt our tool into a format as we're developing the tool, not after the fact, to a usable way. So again, this is the prediction model, and you could see that the positive predictive value was 0.95 and the ROC was 0.83. In fact, this is an old slide, and our newer version of the tool is much higher than that. So we're really happy about this. We streamlined the tool. Initially, it was 12 pages long to 2 pages, one for the donation and one for the transplant. This is a highlight of the donation. You can see at the bottom, we've got an overall probability of death within 30 minutes, 1 hour, and 2 hours. And then we split it up into just the physiology, just the clinical tools, and just the clinician prediction. Remember, this is a clinician decision support tool. This is not using AI to replace the things that our experience gives us. It's super important that this is an objective tool to support our decision. Where does it help us? Imagine if a surgical team doesn't feel that this is likely to be a donor, not going to die in time. That decision is owned by one person at 3 a.m. What if they had a tool to say, you know what, I didn't think so, and this tool supports me? What if that surgeon might be too tired or doesn't have the team, but our tool says, no, likelihood is really high? Do you think that tool, that surgeon might be negotiated a little bit? These are things where we think a decision support tool can help. This is the ischemia profiles in real time while the surgeon is in the operating room waiting for that patient to die. Not just the surgeon, the nurse, the anesthetist, the OR is on hold. This is a huge demand on resources for a DCD donor. And continuously we're seeing the profile of the systolic blood pressure, the mean blood pressure, the saturations, the time under. Most surgical teams have a threshold for blood pressure under 50, how long this patient has been under 50. You can imagine if time to death is 2 hours for 2 patients, but the first patient, 1 hour and 59 minutes, the blood pressure was 90 and the sats were 90, versus the second patient, where after 30 minutes, the blood pressure was below 50 and the sats were 0. 2 different ischemia profiles that this tool now can elucidate for that surgeon in real time very quickly. Using evaluation science, we adapted the report actually 5 times to get to something that we think clinicians will use quickly. So we think that we're ready to deploy this in real time to really impact donation decisions. We've heard from the clinicians that it's useful and it's usable, and in fact, they would use it more than 83% of the time, which I think, talking to surgeons and ICU doctors, that's pretty high uptake on this initial tool. And I think we looked at barriers and drivers so that we can get the implementation part right in our next phases. This is some of the more qualitative comments. I think it's great. You can tell Andrew Healy, who's our donation lead in the province. I think the second one was important for me. Even the clinicians are quickly outlining, I think it's for the families. And this will help their expectations to know how likely their loved one is going to be a DCD donor. The last one highlights the surgical use of this. This is not going to be easy. To implement tools, you need to prove it. Now, we've shown it's feasible, but I think we need a randomized controlled trial, which we were just, it's the next slide. And we need to find out how to respond to false negatives. Right now, we go for every potential donation, and 30% of the time, there's no actually recovery of organs, and we walk away. There's financial costs, but what if we get to a point where we're doing it the other way, where actually we're recommending that you don't go forward with a donation, and that patient dies within 2 hours? How am I going to feel about that? Now, in fact, that happens all the time. We say no to donors all the time, and they die within 10 minutes. So I think we're going to follow that, but it won't be a new problem for us or an added problem. It'll be the same problem. We also think that it'll be a tool that will impact decisions on dying patients, but we still need health regulatory approval. And lastly, which I think was just talked about, it's trust in AI. This whole idea of something else making decisions for very smart people. And it's not just the clinicians, it's families. We talked a lot about trust yesterday. Is a model like this going to add trust or detract from trust? And so that's the work that our team still wants to do before we want to jump into AI technology. And it's really about change management. So we just got funding to do an 18-month, 4-center step wedge cluster feasibility, which is really implementing the tool in real time, working with our ODO to see if we can implement it, we can use it, and what the impact is on donors and transplant outcomes. How many organs are recovered and how do they do? So once we do that feasibility step, we'd like to do a definitive trial. So we've still got a couple of years in the making of this. And that proposed outcome of our definitive trial, what are we looking for? We really want improved proportion of successful retrievals, right? If you're going to go for DCD and consented and the process go for, you need to be a recovered individual. That those recoveries have enough organs recovered. And in fact, maybe we increase the number of organs recovered because we have the ischemia profiles, that those organs work, and that the family experience is improved. So as a summary, we're going to try to implement the tool which has a pre-withdrawal component for the donation side and a post-withdrawal side for the ischemia profiles for the transplant side. And I think this will help us together. It's about efficiency, right? Do things in the right way, which I'm not saying we're not, but we can do it better. And effectiveness, doing the right things at the right time. And really that's results oriented. It's a quality metric. For me, as a pediatric intensivist, I always fall back on the easy sell for me. This is about patient experience. That I think we can better inform families, potentially higher consent rates, to be honest. I work a lot with coordinator burnout, and I think this impacts burnout in a big way for coordinators to have to tell a family donation didn't occur, and higher trust in the entire transplant system. So from that napkin, I'm here to you today, and I'm hopefully be invited again to tell you the update on how well we're doing. And one day, maybe it looks like this on somebody's iPad in the ICU and operating room. I want to thank all the collaborators and funders and the time that you've given me here to share this tool and have further conversations about, as you develop DCD in the region, whether a tool like this might be something to start off with rather than somewhere along the way as we've implemented it. So thanks very much to my collaborators, and thank you for your time. Thank you.
Thank you. I think
it's not working. المايك ما يشتغل. Okay, it's working now.
Okay. I'd like to thank all the speakers for the elegant lectures. Any questions from the audience? Okay, we'll start.
Hi, Rio Hiroshi from the United States. Excellent set of talks. I'll direct my first set of questions to Sunny. Sunny, I'm a transplant surgeon. In the US, no one looks at withdrawal support to flush times anymore. We all, really the time that we really care about is time from agonal to flush. And the definition of agonal changes depending on the surgeon. Some of us use the moment that the systolic blood pressure drops below 80. Some of us use the 80-80, like either systolic blood pressure below 80 or SATs below 80. Some of us don't even consider the SAT. They can be 0 as long as the systolic is still above 60. We don't count that as time. So that's our way of integrating our quote-unquote ischemia time. I get a moment-by-moment on my phone, every single parameter, every single minute after extubation. So I know the blood pressure, I know the SAT, I know the heart rate, I know the respiratory rate. And so for me, unless the blood pressure has gone below 80 or 60, none of that time from extubation to that moment matters, whether it's an hour, half an hour. So I just wanted to comment that we already at that phase, not in an AI fashion, but in a surgeon, maybe not so intelligent fashion. But my comment is, I don't know that I need that tool to tell me that the organ's ischemic or not. And the issue is that these targets are changing because of the advent of NRP. Many of us have used 70 minutes of ischemia time on the liver if they're undergoing NRP afterwards. And we've tolerated more warm ischemia time, quote unquote, with transmedics and others. So my comment is, how do you adjust for that? Yeah. And tell me the real worth of your real-time ischemia tool if I'm doing it in my head already.
Right. I hope everyone knows, Rio, and how respectful those comments are. Thank you. I mean, that feedback is what we're looking for in the tool. This is implementation science. How do we do that? I think you identified two key issues, that every surgeon has different qualities, and that's why a profile that's standardized will help you make your decisions. Now, you're doing it. Not everyone is doing it, and some of your colleagues, even in your center, are doing it differently. And so what we want to do is standardize that process for you so that you're not doing it in your head, that we're doing it for you, but you're still making the same decision you're making, whether it's 60 or 40. We're giving you the tool so that it comes up quickly and easily and systematically at every center you go to, for every donor, and for every surgeon you work with. So that's what we hope the tool will do. The second point is about NRP and emerging technologies. I really worried about this as NRP is normothermic regional perfusion. It's ECMO for the deceased donor. Once death is declared, they basically put the abdominal and sometimes thoracic organs on ECMO. So that reperfuses very quickly, which takes away what I pitched to you as time to death as a problem. So I was very worried about this, and after talking to more and more people, in the States especially, is who do you deploy NRP to? This is not just a surgical team now. This is $150,000 worth of equipment you're sending to an OR and a donor. Are you going to send it for all potential deceased donors? Or maybe with a tool like this, you could say, listen, the likelihood of dying is 3 minutes here. I don't have to use NRP for this patient. We can use our other perfusion techniques. So we think this is an evolving tool for the evolving needs of the patients. And I think we'll have to see how NRP pans out. In fact, we've been talking to Angie Wall in Texas, who does a big pool of NRP, and maybe at your site, to see what a tool like this would do for you. And I think that's where implementation science is so helpful here. Super questions.
Excellent answers, and Angie is the right person as one of the people, and the people in Utah are also the right people. They deploy NRP to 100% of the DCDs. So they deploy NRP in that fashion, whereas it's variable. The interesting thing is that this can be used by OPOs, because sometimes OPOs deploy transmedics when the transplant centers have not agreed to accept them, and then they procure those organs, put them on transmedics, and then they're able to allocate those organs post facto, rescuing those organs that weren't able to be placed pre-DCD withdrawal support. So outstanding, thanks.
Yeah, thank you for that. Yeah.
Okay, if you allow me, I have several questions, one question for each one. I enjoy the presentations, by the way. For Dr. Mamatha, usually machine learning and predictive model built based on the integration with AMR, or health record system. So providing that access for AMR, how can you make sure that the data is valid, the data is clean, the source of data is well identified to get better result from the machine learning?
Yeah, so thank you for that question. I think for any studies, regardless of whether you're using AI or not, it's very clear that the data that is fed needs to be clean and free of bias as much as possible. So I think this is a consideration regardless of what what question you're wanting to address, and regardless of the tools you want to use to address them. Where AI tools particularly shine is when you have multiple variables, longitudinal changes in those variables, and then when you want to consider not just clinical and laboratory variables, but also other types like omics data or radiomic or pathology. You want to bring it all together, then I think there's a great deal of opportunity there. But of course, certainly you must ensure that the data that is fed in there is clean and that there's relatively limited missingness in the variables when you train the model. Yeah.
I think this is still a struggle to have clean data, to be honest. And it's maybe the same question would go to Dr. Mohammed, because you mentioned coding, and we have struggled with ICD-10 everywhere. And AI to develop a coding system will depend based on the clinical note, interpretation of clinical note, which has missing a lot of data again. So it will result in another problem similar to ICD-10. So how can we solve that?
Okay. So probably, thank you again. I think the ICD coding or miscoding is going to always be there. So probably the AI is just another tool and it needs oversight. It's a tool that could improve on its own if you start to program it. So the beauty of it that it can just go dive deep into the medical records and look at it and suggest the coding for the clinician. Again, I think the one who should be accountable for it is still the clinician or the personnel who is checking, is this code correct or not? And then I think this is the way, it's like a hybrid approach I will suggest now. Maybe Dr. Bat.
Maybe I'll add on to that. Yeah, okay. So what we do in our practice is basically I request that the data engineer extract a certain number of variables for my research study in question. So I'll ask them to retrieve data in an automated way from EPIC, which is our electronic medical record system. So he basically codes, the extraction of that data. But then after that, what I do is I will have my clinical fellows or students, residents, go over that data set, make sure that at least cross-check several of those data points to make sure that the data retrieved seems reasonable, clean, and then add in any missing data as needed, So I think that's actually a necessary process to ensure that whatever data you're using to train your model is clean.
Yeah, I think it's essential and it's very difficult work.
But rather than, it's in the old days, we would depend on manual data retrieval. Now that's no longer necessary.
That's great.
Yeah.
Professor Timsah, AI is a very interesting topic, not only in stock market or real estate. It's becoming, its use becomes increasingly as an integral part in medicine as well. And as we all know now, the organ transplant decision making as an AI clinical pathway starting from an algorithm in recipient donor matching system to the postoperative care. Now, how can we make sure that this AI algorithm remains transparent, fair, and free from bias? And what are the advancements needed in the near future?
Thank you for that important question. So again, the issue is with bias is always there. It's inherent. It's not only in AI, in humans. So there's always bias. So how to minimize it, how to mitigate it. In one of my slides, I put how to mitigate it. And I think at this current stage, it's just to try to make any data set, training data set, to be as inclusive as possible. This is what I will think about. And to have a transparent process of how the AI reaches that. So this is very important. So what's happening under the hood? Not like just, because now it's, again, the black box, the AI black box, that even the company itself may not know which algorithms that AI used. So I think this is something that's vital to use. And maybe with the new AI models, maybe it should have some indicators attached with it as what is the risk of bias. When we do a systematic review, we go with the risk of bias. So I think because it will alert me if I have a high risk of bias in this produced results, okay, I will dig more deep into it. Whereas if I have like 1% risk of bias and I have the humans to oversight and make sure that, then I will have less, I don't need to have so much high vigilance. This is the way I think about it, and maybe my other colleagues could have more insights, maybe. Risk of bias.
Yeah, I'll add to that, or I'll confirm my agreement is that there is always bias. In fact, I would look at, I'm always glass half full, maybe pediatricians are like that, but the idea is that the fact that we're asking the question here, AI is giving us the opportunity to re-examine biases. We always have had biases, whether sex, gender, pediatrics, anything. We're now actually using AI and the controversy around to really look at biases in general. And this is a really positive step. So I don't think we should be afraid of asking your question. We should also accept that biases exist, and us documenting and being aware of them is a better way to go forward. It shouldn't stop us from using AI. It should make us feel more comfortable because we're asking the questions.
Yeah, and I think I'll add to that. So I think it's important to consider that AI models can have a certain bias, and that the model's performance can decrease over time. So it is important, once you implement a model, to re-examine over time how the performance is, so there can be model drift over time, but also to examine how fair it is to different, say, subgroups of patients, or certain characteristics of patients. So it's important to assess that over time, so that you're not disadvantaging certain patients versus others. So to be as equitable and fair as possible in this deployment of AI tools.
Thank you very much.
I have one last question for Prof. Sani about prediction for disease donor. And like we have experience in developing a model for prediction of brain death. And I think that was easy because we have solid factor like fixed pupil, absence of gag reflex, GCS, and so on. But in disease donor, it was difficult because you are depending on two factors, which has a lot of co-founders that make it very liable, like blood pressure and heart rate. So how can you make sure there is no other co-founder, like sepsis, for example?
Yeah, excellent. So a couple of comments. One, there is some great tools to help us, or to being developed for brain death donors. The key to brain death donors is doing it early as possible. And so there's a group that we know well, Mikhail Chasse out of Montreal. And he's created a data lake. So if you get admitted to his hospital, anybody gets just put into a data bank. And he can pull whatever he wants out of this water, not specifically, at any time. And his algorithms are predicting who's going to have a negative outcome, whether it's sepsis or brain death. So I think that's there. For deceased donation, in fact, the heart rate and blood pressure variability is a signal we found to highlight deceased donation. So that was actually the real key to this new tool. That's what we're leaning on, that it's physiology that's giving us a signal. We are planning to add some novel brain biomarkers that actually get released only when the brain is dying. Only from the brain. And if we add that, which will be a potential part of the next study, I think that will add value to this. And the last thing that I'll add is the biggest confounder is how one withdraws life-sustaining therapies. I talked about this a little bit later, but if one person extubates versus one person turns down the oxygen, then the time to death differs. Our model incorporates that, so we'd be able to overcome that model. But I think we have to standardize that part of practice.
I think one day soon, very soon, we will have the AI giving us a scoring system combining multiple factors, donor, recipient, surgical, and we'll come to our patients telling them, well, you will be having this graft, and your graft survival is specific percentage, and your lifetime survival as well, a very specific percentage.
One last question.
Hi, my name is Yasser. I'm an organ transplant coordinator. My question is, regardless of the benefit of adding AI to the field of organ transplant and donation, do you think, Dr. Abdulrahman, that will make, Dr. Sani, that will make a risk in ethics in particular? I'm not talking about medical. You are the judge of this, but do you think this will make a risk in ethics? Because, I don't think AI will go for ethics and will decide for it. We are the human, and sometimes we'll make a mistake on it. But do you think the AI will follow us in that result?
Yeah, if I get the question right, you know, what is the impact of AI on
Absolutely.
ethics of donation,
Yes.
dying, and transplant? I think I'm going to answer it the same way I answered the previous question. There's always been ethical challenges in what we do. This is what we do. I think at times, and it's a royal we, it's all of us, tend to ignore or neglect that part of our job, which creates conflict. I think AI is forcing us to look at the same ethical issues and address them before we implement AI. So I think our ethical tension will become less because we're actually addressing it. There's still issues, but we are going to address it, and I think that's why AI is going to help us.
And if I may just add, the guidelines by Sadaya, they put in their ethical guidelines, they put exactly your valid points into perspective, and they put each statement or standards, what's the ethical theory, or so it's beautifully there outlined. So if any AI model abides by that one, we are on the safe side. This is what I would say from now. So they were proactive.
So that means we will have the final decision.
Ethics always has an ongoing query, human oversight, I think. So, but the final decision has to be with the humans. Otherwise, it's going to be a reverse world.
Okay, finally, if you feel that the final decision will be by the humans, why we add AI to our field?
So why you are using the computers? Why you are using the mobiles? So this is another tool that it's gonna enhance, empower. It's like the transplant society on steroids. So I think it's something that we need to ride the wave. I think this is my opinion.
Thank you.
Thank you.
Okay, I think it's time to conclude this session. I'd like to thank all speakers.
Thank you.
Thank you very much.
From good morning to good night. See you. That was very interesting. Thank you very much. Thank you for the opportunity. Yeah, that's a very engaged group. Thank you, guys. Thank you. We can get a picture. Yeah, let me get a picture. Formally. Ladies and gentlemen, we'll be serving an award momentarily for the best poster and the best oral presentation of the conference. So just give us 5 minutes just to calculate the scores, and we'll get back to you. Thanks.
announced that we're later on, so it might be a little bit later of the day rather than at 12:30 as we expected. Please accept my apologies. So most likely, I think it may be around 3 or 3:30, but it depends when is the forum going to be in. Thanks.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على رسوله الأمين وعلى آله وصحبه أجمعين. أما بعد، أصحاب المعالي، أصحاب السعادة، الحضور الكرام من الإخوة والأخوات، فأهلاً وسهلاً ومليون مرحباً وزيادة. أحييكم جميعاً بتحية أهل الجنة، تحيتهم يوم يلقونه سلام، فالسلام عليكم ورحمة الله وبركاته. في هذا المنتدى وتحت مسمى الأحكام الشرعية للتبرع بالأعضاء وزراعتها، أقول مذكراً لنفسي وإياكم قول الله تعالى: ومن أحياها فكأنما أحيا الناس جميعاً. حضورنا الكريم، تهنأ الحياة لمن يحيي إنساناً ليحيا لعبادة الله وتوحيده، يحييه لخدمة دينه ووطنه، يحييه ليرسم على محياه البسمة، يحييه ليزرع في صدره الفرحة، يحييه ليغرس في قلبه البهجة، ليكون بإذن الله تعالى في بدنه شفاءً وعافية وصحة. أيها الحضور الكرام، هذا المؤتمر أقيم ليرسخ في النفوس إحساناً ويعلن للعالم بكل فخر إنجازاً، ويبين ما في زراعة الأعضاء تطوراً وابتكاراً. وأقول لنا جميعاً في هذه الحياة فلنهدي حياة. ويسرني أن أدعو صاحب السعادة الدكتور طلال بن تركي القوفي، المدير العام للمركز السعودي لزراعة الأعضاء، فليتفضل مشكوراً في كلمته وترحيبه.
السلام عليكم ورحمة الله وبركاته. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. أصحاب المعالي الشيخ عبد الله المطلق، صاحب المعالي الشيخ عبد الباقي المبارك، وإحنا في انتظار الكبار معالي الشيخ عبد الرحمن السند، أصحاب السعادة، أشكركم شكر جزيل على تشريفكم لنا في هذا المنتدى التي يأتي ضمن فعاليات المؤتمر السعودي لزراعة الأعضاء 2025. لا شك أن زراعة الأعضاء علم لا يفتأ أن يتطور، والمملكة العربية السعودية ولله الحمد تعتبر الآن من الدول المتقدمة في هذا المجال، سواء كان في الخبرات أو في الابتكارات. ولكن السؤال الأساس يتوقف هذا القطاع في جله على توفر الأعضاء، والتي يواجه فيها تحديات كثيرة، بالإضافة إلى أن ممارسة زراعة الأعضاء تنطوي على أخلاقيات عديدة، ونحن كشعب مسلم ننتهج الشريعة الإسلامية منهج حياة، لا بد للشرع أن يلقي بكلمته في هذا المجال، لأن ديننا دين نهج نعيش فيه كل يوم. هذه المنتدى كذلك يعتبر فرصة للعموم والمجتمعات المدنية أنهم يلقوا التساؤلات التي ترد في خواطرهم، ونطمح من أصحاب المعالي إلقاء الضوء على هذه التساؤلات والحكم الشرعي فيها ليتحقق الطمأنينة في قلوب الناس. مرة أخرى أشكر وجودكم، وأتمنى أن يكون هذا المنتدى مثمراً. والسلام عليكم ورحمة الله وبركاته.
الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. أصحاب الفضيلة العلماء، أصحاب المعالي، السادة والسيدات الحضور الكرام من الفقهاء والأطباء والكوادر الطبية والمختصين والمهتمين بزراعة الأعضاء، أيها الحضور الكريم، إخوتنا وأخواتنا المشاهدين على البث المباشر، السلام عليكم ورحمة الله وبركاته. يسرنا ويشرفنا أن نرحب بكم أجمل ترحيب في رحاب هذا المنتدى المبارك، منتدى التبرع بالأعضاء، والذي يجمعنا تحت مظلة القيم الإيمانية الإسلامية والتعاون العلمي والعمل المشترك لما فيه خير بلدنا الحبيب وأمتنا. اجتماعنا اليوم هو تأكيد على وحدة العلم والمعرفة بين الشريعة والطب، وتآزر الجهود، واستمرار مسيرة البناء المعرفي والنهضة العلمية الطبية والفقهية في ضوء تعاليم ديننا الحنيف. فأهلا وسهلا بكم جميعا، ونسأل الله أن يبارك هذا اللقاء وأن يجعله نافعا ومثمرا، وأن يوفقنا وإياكم جميعا لما يحب ويرضى. دعوني أقدم زميلي في إدارة هذه الندوة المباركة والحوار المثري بإذن الله تعالى في جدته وأصالته، أخي الأستاذ محمد بن سعود العمر، رئيس حقوق المستفيد بفرع الوزارة بالأحساء، صاحب مبادرة الدليل السعودي للإذن الطبي بوزارة الصحة، أمين اللجنة الاستشارية الشرعية الطبية بدار الإفتاء، رئيس مجلس الإدارة لجمعية الدعم الديني الروحي لمرضى الطب التلطيفي، وعضو مجلس الإدارة لجمعية الدراسات الطبية الفقهية. واسمحوا لي أن أقدم الورقة الأولى، وعنوانها التبرع بالأعضاء وزراعتها بين الواقع والمستقبل. المحاضر هو الدكتور فيصل بن عبد الرحمن السويدان، استشاري طب الأعصاب والعناية المركزة للكبار والعناية الحرجة لطب وجراحة الأعصاب، واستشاري ورئيس قسم طب الأعصاب بمستشفى قوى الأمن بالرياض. والدكتور فيصل هو ذو باع طويل في العديد من الدراسات والمؤتمرات الطبية وتصميم المناهج والورش العلمية في مجال العناية الحرجة للأعصاب وطب الأعصاب والأخلاقيات الصحية، شارك في العديد من اللجان الوطنية والتشريعية في هذا الصدد، لا سيما مع المركز السعودي لزراعة الأعضاء، وهو مؤسس لشعبة العناية الحرجة للأعصاب في الجمعية السعودية للعناية الحرجة منذ ما يزيد على 13 عام. دكتور فيصل تفضل.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. بدي بالحديث بحضور أصحاب المعالي والفضيلة هو مثل بدء طالب العلم بالسؤال للمشايخة، ومثل السائل في المسألة يبحث عن حكمها. فباستعراض أحوال المرضى الذي يعانون من فشل الأعضاء، لي وقفات مع كل حالة، فاسمحوا لي أعطيكم مثال عما يعاني منه طبيب الفشل الكلوي، وما يعاني منه مريض الفشل الكلوي وكيف يزور طبيبه، ومريض الفشل الكبدي، ومريض الفشل التنفسي، ومريض الفشل القلبي، وكيف تكون حياتهم بعد أن كانوا هم العائلين لأهلهم. فإن كان أب أو أم كان يرعى أبنائه، وإن كان ابن فكان يرعى أبوه وأمه، ثم تحول من عائل إلى من يحتاج إلى إعالة. فبالوقوف عند مرضى الفشل الكلوي، وهم قد يكونون أكبر شريحة نواجهها حالياً، هم أناس يحتاجون لغسيل كلوي بشكل متتابع، قد يكون ذلك 3 أيام في الأسبوع، مما يحد من قدرتهم على ممارسة نشاطهم المعتاد وكسب العيش والقيام بالعبادات ورعاية من حولهم. ففي هذه الحالة تعطلت مصالح الشخص نفسه وكذلك من هو حوله، بل على العكس قد يكون بحاجة لمن يهتم ويقوم بشأنه. في مثل هذه الحالات نجد أن علاج المريض هذا بعلاج ناجع يعيده لحياته الطبيعية هو في منفعة ليس فقط للمريض، بينما من حول المريض. وقد يكون بإذن الله عز وجل هذا الإنسان الذي استغنى عن الغسيل الكلوي بعد التبرع قد يكون قادر على الإنتاج والعطاء والدعم، ويكون مجددا قادر على رعاية من حوله. يعاني مرضى الفشل الكلوي من عدة مشاكل، قد يكون أهمها هو تجمع السوائل في الجسم، حيث أن الكلى مسؤولة عن إخراج الفائض من السوائل ومعادلة الأملاح في الجسم والمحافظة على حموضة الدم. وقد يصاحب هذا تجمع السموم في الجسم بسبب فشل الكلوي، قد يصاحبه هذيان وفقدان المقدرة في اتخاذ القرارات، وقد يغيب عمن حوله في بعض الأحيان، وقد يدخل في غيبوبة لا سمح الله. كل هذه تجعله إنسان فاقد العطاء، فلا يستطيع أن يمارس ما كان يمارسه قبل هذا الفشل. وإن انتقلنا إلى الفشل الكبدي فهو شبيه إلى حد ما بالفشل الكلوي، ففيها وظائف الكلى خلاف ما تقوم به من إنتاج البروتينات المهمة للتوازن الجسماني والتوازن في قدرة الإنسان على محافظة على سيولة الدم، كذلك هو يحتاج الكبد للمحافظة على مناعته. ففقدان وظائف الكبد تجعله عرضة للالتهابات والعدوى وتجمع السوائل في البطن، وتدخل في الغيبوبة الكبدية، وهي من أكثر الأمراض خطورة على حياة الإنسان. فالغيبوبة الكبدية قد يدخل بسببها إلى العناية المركزة، وقد يبقى غائبا عن الوعي فترة طويلة، ويغيب عليه كثير من الأمور، وقد يكون حتى في بعض الأحيان غير مكلف لأنه غير مؤهل لذلك. وانتقلنا إلى الفشل التنفسي، فلكم أن تتخيلوا المريض الذي يتنقل من مكان لمكان وهو يسحب خلفه أسطوانة الأكسجين، وقد يكون بحاجة إلى جهاز يضخ الهواء إلى صدره مثل أجهزة التنفس الصناعي المحمولة، وقد لا يستطيع حتى مغادرة بيته أو غرفة نومه بسبب حاجته لكميات أو تركيز عالي من الأكسجين، والذي قد يحتاج كذلك إلى جهاز يدفع الأكسجين بضغط عالي حتى يتسع له صدره الضيق. ومن مشاكل فشل الجهاز التنفسي هي كذلك تجمع غاز ثاني أكسيد الكربون، وغاز ثاني أكسيد الكربون يؤدي إلى زيادة في السوائل في الدماغ. وفي هذه الحالات عند تجمع غاز ثاني أكسيد الكربون في الدماغ قد يفقد الإنسان كذلك قدرته على الوعي وفهم ما حوله، وقد تفوته من العبادات ما يفوته، وقد يخطئ في حسابه وفي تعاملاته المالية، وقد يقع منه ما يقع في مثل حال من هم فاقدين للقدرة الذهنية والعقلية. وانتقلنا لحال من يعانون من فشل القلبي، فمثل هذه الأحوال يكون الإنسان يجد الصعوبة بسبب الفشل القلبي حتى أثناء النوم، فلا يستطيع النوم حتى بشكل مستلقي متكامل، وقد يحتاج إلى وسادة أو وسادتين، ويعاني من ضيق في النفس. وفي كل جهد يبذله المريض الذي يعاني من مشاكل فشل القلب قد يصاحب ذلك خفقانا في القلب وتسارع في دقات القلب، وقد يصاحب ذلك هبوط في الضغط، وما يؤدي إلى تجمع السوائل في الرئتين، ويحد من جدوى العلاج الذي يستخدمه الدوائي. وفي هذه الأحوال نعلم أن في نهاية العضو المفقود نهايته لا يمكن استبدالها بالأحوال الطبيعية إلا من خلال زراعة الأعضاء. فبالوقوف على كل الأمثلة السابقة، من لديه فشل في الكلى، ومن لديه فشل في الكبد، ومن لديه فشل في القلب أو الرئة أو خلافها، نجد أن الإنسان فقد دوره لخدمة نفسه أولا، وقد تتأثر فيه أحواله في العبادات، وقد تتأثر أحواله في من يرعاهم، فإن كان أبا قد يتأثر حال أبنائه وزوجته، وإن كان ابنا قد لا يستطيع القيام بمهامه تجاه والديه، وإن كان متزوجا قد يضطر بسبب ظروفه الصحية الانفصال عن زوجه أو زوجته. ففي هذه الأحوال تقع الكثير من المفاسد بسبب هذه المشكلة المزمنة، وتعد مشاكل فشل الأعضاء هي من الأمراض المزمنة المكلفة جدا على النظام الصحي وعلى المجتمع. فمريض الفشل العضوي هو مستمر في معاناته ومستمر في حاجته للعلاج حتى يتوفاه الله أو يجد من ينقذ حياته. سأقف معكم في أحدث الإحصائيات، وقد طلبتها بالأمس لأعلم من في هذه القائمة وكم أعدادهم وماذا ينتظرون من المتبرعين والمحسنين. فأفادني الزملاء في المركز السعودي لزراعة الأعضاء أن هنالك 1266 مريض يعاني من الفشل الكلوي وفي انتظار إنسان محسن يتبرع لهم، وهنالك 214 مريضاً ومريضة يعانون من الفشل الكبدي وفي انتظار من ينقذ حياتهم، وهنالك 77 مريضاً تعاني من فشل التنفسي وينتظرون من يتبرع لهم برئة، وهنالك 98 مريضاً يعانون من الفشل القلبي قد لا يستطيعون مبارحة بيتهم وخروجهم من غرفتهم، وقد لا يستطيعون حتى النوم بشكل طبيعي على مخدة واحدة على وسادة واحدة. هذه الأعداد هي جزء لله الحمد بسيط بالنسبة لمن تمت زراعة الأعضاء لهم، وقد كشف الزملاء في المركز السعودي للتبرع بالأعضاء أن هنالك أكثر من 25,000 مستفيد في المملكة العربية السعودية منذ تأسيس المركز وبدء البرنامج في زراعة الأعضاء، استفادوا من نقل الأعضاء وكان لهم حياة بعد ممات بإذن الله عز وجل ومشيئته سبحانه وتعالى. بذلك أختم، والسؤال أو التساؤل الذي لدي: هل نستطيع مساعدة إخواننا وأخواتنا من هم أمس الحاجة ليعودون أعضاء فاعلين في مجتمعهم، يخدمون أنفسهم ويخدمون ذويهم ويستعينون بهذه الأعضاء في عبادتهم ويستعينوا بها لقضاء حوائجهم. جزاكم الله خير. أنا جمعت اللغتين فأعتذر منكم. أشكركم جميعا على حسن استماعكم. بارك الله فيكم جميعا، وهذا ما لدي. بارك الله فيكم.
جزاك الله خير وبارك الله فيك وأحسن الله إليك على هذه المعلومات المهمة للجميع أن يعرفها. اسمحوا لي أن أشرف بالتعريف بمن أسعد بمزاملته في إدارة هذا المنتدى. هو صاحب السعادة الدكتور صالح بن عبد الله الخنين، استشاري في طب التخدير والعناية الحرجة للأعصاب، ولديه زمالة طب التخدير الأعصاب وطب العناية الحرجة للأعصاب من جامعة تورنتو بكندا، رئيس المجلس العلمي لطب التخدير بالهيئة السعودية للتخصصات الصحية، وهو كذلك أمين مجلس الإدارة للجمعية السعودية لطب التخدير، عضو اللجنة الوطنية للأخلاقيات الصحية بالمجلس الصحي السعودي، وهو كذلك عضو اللجنة العلمية للدليل السعودي للإذن الطبي الصادر من وزارة الصحة. فحياك الله دكتور صالح. والآن نسعد بسعادة الدكتور عبد الله بن فيصل المفلحي، بورقة عمل يتكلم فيها عن الجراحة الطبية للتبرع بالأعضاء وزراعتها. أما الدكتور عبد الله فهو استشاري جراحة زراعة الأعضاء وأورام الكبد والبنكرياس، ولديه زمالة الاسترالية في جراحة زراعة الأعضاء، وكذلك زمالة كورية في زراعة وأورام الكبد والبنكرياس. ويعمل هو حالياً وفقه الله في مركز زراعة الأعضاء وجراحة وعلوم الكبد بمدينة الملك عبد العزيز الطبية بالحرس الوطني، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. شكرا لكم على الاستضافة. سوف أقدم عرض بسيط يتكلم عن جراحة التبرع بالأعضاء وزراعتها. بادئا ذا بدء سوف أتكلم باقتضاب عن بعض الإحصاءات التي تتعلق بمرضى الفشل العضوي. كما تفضل الدكتور فيصل السويدان، لدينا حالياً في المملكة العربية السعودية أكثر من 18,000 مريض فشل كلوي مسجل على قوائم الغسيل، ولدينا أكثر من 1800 مريض في قوائم الانتظار وحاجة ماسة للزراعة بمختلف الأعضاء. لو فرضنا أن لدينا 10 مرضى من مرضى الفشل الكلوي ممن لديهم الداء السكري النوع الثاني، حسب الإحصاءات العلمية ممن هم على الغسيل الكلوي، إذا لم تتم زراعتهم في غضون 5 سنوات، نسبة الوفاة في هؤلاء الأشخاص أكثر من 50%. ومثال آخر، مرضى الفشل الكلوي من النوع ومرضى داء السكري من النوع الأول، وهم في أغلب الأحيان مرضى في صغارا في السن، وممن هم في قوائم الانتظار على الزراعة، إن لم تتم زراعتهم في غضون 5 سنوات، أكثر من 80% من هؤلاء المرضى نسبة الوفاة تكون عائلة لديهم. مرضى التليف الكبدي، وبالذات في الحالات المتقدمة الذين يكونون في حاجة ماسة للزراعة، إذا لم تتم زراعتهم في غضون 3 أشهر، نسبة الوفاة تكون أكثر من 70%. قال الله تعالى: ومن أحياها فكأنما أحيا الناس جميعا. هذه الآية العظيمة تتجلى جليا في زراعة الأعضاء. عندما يتم التبرع بالعضو، فنحن بما لا يدع مجالا للشك أنك تحافظ على حياة المريض وتنهي معاناته، ولكن لا يتوقف عند هذا الأمر. تنهي معاناة أسرة كاملة تعاني مع هذا المريض. كثيرا من الأسر ممن توقفت حياتهم بسبب وجود مريض فشل عضوي في أسرتهم. بالتبرع بالأعضاء كما ذكر الدكتور فيصل، نحقق الاستدامة الصحية ونخفف العبء على النظام الصحي. نحمد الله أننا في هذه الدولة العظيمة التي تجعل المواطن وصحة المواطن من أولوياتها. وكما لا يخفى عليكم جميعاً مبادرة خادم الحرمين الشريفين وولي عهده الأمين في التبرع بالأعضاء، الذي سجل ارتفاعاً ملحوظاً بعد مبادرتهم في التسجيل في البرنامج في زراعة الأعضاء. في العام الماضي في 2024 تم زراعة أكثر من 1700 عضو من متبرعين أحياء في المملكة العربية السعودية، وتمت زراعة أكثر من 393 عضو من متبرعين المتوفى دماغيا. كيفية الحصول على الأعضاء كما ذكرنا إما أن يكون من متبرع على قيد الحياة أو من متبرع متوفى دماغياً. المتبرع الحي يستطيع أن يتبرع بكلية، جزء من الكبد أو نخاع العظم. سأتكلم عن الجانب الجراحي بما يخص التبرع بالأعضاء من المتبرعين الأحياء. أي ممارس طبي سواء جراح طبياً عندما يقدم عليه المتبرع ويبدأ في الإجراءات والفحوصات، سلامة المتبرع أولوية قصوى وتوضع نصب عيني الممارس الطبي. أهلية المتبرع أو شروط التي يجب أن تنطبق على المتبرع: يجب أن لا يقل عمر المتبرع عن 18 عاماً، أن يكون المتبرع في أهلية كاملة صحياً وجسدياً ونفسياً، لذلك لا يقيم فقط بالأطباء، يقيم بالأخصائيين النفسيين ويقيم بالأخصائيين الاجتماعيين، للتأكد من أن يكون القرار أو قرار التبرع صادراً عن اقتناع وبإرادة حرة، أن يكون المتبرع لائقاً طبياً، أن لا يشكل التبرع بالعضو البشري خطراً مباشراً بأي طريقة على المتبرع، أن يتجاوز المتبرع الفحوصات التوافقية والمناعية، يشرح للمريض أو يشرح للمتبرع بشكل واضح أن لديه الحق في العدول عن قراره في أي وقت ما قبل التبرع، أن يحاط المتبرع بشكل واضح بجميع النتائج المؤكدة والمحتملة والمترتبة على التبرع بالأعضاء. التبرع بالكلى ما قبل الجراحة أو ما قبل العملية، بعد استيفاء جميع الشروط يتم مناقشة المتبرع في المجلس العلمي والتأكد من ملائمته للتبرع، والتأكد من سلامة العضو المتبقي للمتبرع، والتأكد من إمكانية زراعة العضو المتبرع به بسلامة وإمكانية نجاحه بإذن الله. باختصار عن العملية الجراحية: المتبرعين بالكلى في أغلب المستشفيات يتم دخولهم في نفس يوم العملية. مدة العملية تقريباً المعدل 3 ساعات. تتم العملية الآن في أغلب المستشفيات عن طريق المنظار الجراحي، وهذا ما يعني 3 فتحات في البطن، كل فتحة لا تكون أقل من 1 سنتيمتر، وفتحة صغيرة في أسفل البطن لإخراج الكلى. وهذا مقارنة بالماضي عندما كانت العملية تعمل عن طريق الفتح. الفرق بينهم أن المتبرع نسبة الألم أقل، عودة المتبرع لحياته الاجتماعية أسرع، ومعدل المكوث في المستشفى ما بعد العملية أقل، حيث أكثر من 90% من المرضى يغادروا في غضون 24 ساعة من بعد العملية. عملية التبرع بالكلى عملية آمنة أثبتت عن طريق الدراسات والنتائج. المضاعفات المحتمل حدوثها هي المضاعفات التي يمكن أن تحدث مع أي عملية أخرى داخل البطن، عن المضاعفات البسيطة كالتهاب الجروح، كالغثيان، النزيف البسيط، مثل أي عملية أخرى لا تتجاوز نسبة 5%. المضاعفات الخطيرة التي ممكن أن تؤدي إلى الوفاة لم تسجل على مدى 40 سنة من الممارسة الطبية في المملكة العربية السعودية، وأثبتت أن هذه العملية آمنة بإذن الله. نسبة تأثر وظائف الكلى إذا حافظ المتبرع على النمط الصحي فهي مقاربة لغير المتبرعين، وحدوث الفشل الكلوي بسبب التبرع نادر جدا، أقل من 1%. التبرع بالكبد الجانب الجراحي التبرع ما يفرق الكبد عن العضو عن الكلى هو أن الكبد لا يوجد خيار مؤقت. الكلى يكون المريض على الغسيل، بينما الكبد عندما يتم وضع المريض على قوائم الانتظار يعنى أنه لا يوجد أي حل آخر سوى الزراعة. عندما يتبرع الشخص لطفل غالباً يتبرع بجزء الأيسر من الكبد، وعندما يتبرع لشخص بالغ يتبرع في أغلب الأحيان بالجزء الأيمن من الكبد. ما قبل العملية يتم تقييم المتبرع بصفة كاملة، التأكد من أن ما يتبقى للمتبرع كافي، لا يوجد أي أمراض أو مشاكل في الكبد ممكن أن تؤثر على الوظيفة، ويتم التقرير ما بعد العملية من قبل اللجنة العلمية بملائمة التبرع. الجانب الجراحي يدخل المتبرع في يوم العملية. معدل عملية التبرع بالكبد على حسب الجزء المأخوذ تقريباً 6 ساعات، تعمل عن طريق الفتح الجراحي أو عن طريق المنظار أو الروبوت الجراحي، ونحن في المملكة العربية السعودية من الرائدين في هذا المجال، ومعدل المكوث في المستشفى من 4 إلى 5 أيام. عملية التبرع بالكبد عملية آمنة، نسبة المضاعفات البسيطة ما بين 5 إلى 10%، نسبة المضاعفات الخطيرة لم تسجل على مدى 40% في المملكة العربية السعودية من الممارسة الطبية. بصفة عامة لا يشكل على المدى الطويل التبرع بالكبد أي خطر على وظائف الكبد على المدى الطويل. شكرا لكم على حسن استماعكم.
جزاك الله خير دكتورنا الغالي. ورقتنا الثالثة عن الحكم الشرعي للتبرع بالأعضاء وزراعتنا. نتشرف بالاستماع لصاحب المعالي فضيلة الأستاذ الدكتور عبد الله بن محمد المطلق، عضو هيئة كبار العلماء والمستشار بالديوان الملكي، عضو اللجنة الدائمة للفتوى سابقاً. معاليه له عناية عظيمة واهتمامات كبيرة في الفقه الطبي، حيث حالياً يرأس اللجنة الاستشارية الشرعية الطبية بدار الإفتاء، وشارك في العديد من المؤتمرات والندوات وورش العمل الفقهية الطبية، وصدر لمعاليه كتاب بعنوان زاد المريض. حياكم الله يا دكتور.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على نبينا وحبيبنا وقرة أعيننا محمد بن عبد الله الصادق الأمين، صلى الله عليه وعلى آله وصحبه أجمعين. أحبتي في الله، الموضوع الذي نحن الآن نتحدث فيه اسمه ماذا؟ التبرع. فإذا أراد الإنسان أن يتبرع من غير أن يضر بنفسه أو من حوله، هل الحكم العام في الشريعة مدحه وتأييده، أو أن يقال له لا تتبرع؟ هذا المسألة الأولى، مسألة العنوان الذي اجتمعنا من أجله، مسألة التبرع. يا أحبابي بارك الله فيكم، هذا الموضوع قتل بحثاً، وصدرت فيه فتاوى كثيرة جداً. صدر قرار هيئة كبار العلماء في 1402، نص الموضوع منه بعد المناقشة وتداول الآراء قرر المجلس بالإجماع جواز نقل عضو أو جزئه من إنسان حي مسلم أو ذمي إلى نفسه إذا دعت الحاجة إليه أو من الخطر في نزعه. 2. كما قرر بالأكثرية جواز نقل عضو أو جزء منه من إنسان ميت إلى مسلم إذا اضطر إلى ذلك وأمنت الفتنة في نزعه ممن أخذ منه وغلب على الظن نجاح زرعه في من سيزرع فيه. 2. جواز تبرع الإنسان الحي بنقل عضو منه أو جزء منه إلى مسلم مضطر إلى ذلك. ثم صدر بيان من هيئة كبار العلماء عام 1442 بجواز التبرع بالأعضاء بعد الوفاة، وأنه من الأعمال الصالحة التي تسهم في إنقاذ حياة الآخرين، مشيرة إلى أن هذا الفعل يدخل ضمن مقاصد الشريعة الإسلامية في الحفاظ على الحياة والمحافظة عليها. وشدد البيان على ضرورة أن يكون التبرع وفقا للضوابط الشرعية والطبية. وصدر قرار مجمع الفقه الإسلامي في دورة مؤتمره الرابع بجدة في المملكة العربية السعودية في صفر 1408، وفيه يجوز نقل العضو من مكان من جسم الإنسان إلى آخر من جسمه مع مراعاة التأكد من أن النفع المتوقع في هذه العملية أرجح من الضرر المترتب عليها، وبشرط أن يكون ذلك لإيجاد عضو مفقود أو لإعادة شكله أو وظيفته المعهودة أو لإصلاح عيب أو إزالة دمامة تسبب للشخص أذى نفسيا أو عضويا. 2. يجوز نقل العضو من جسم إنسان إلى جسم آخر إن كان هذا العضو يتجدد تلقائيا كالدم والجلد، ويراعى في ذلك اشتراط كون الباذل كامل الأهلية وتتحقق الشروط الشرعية المعتبرة. 3. تجوز الاستفادة من جزء من العضو الذي استؤصل من الجسم لعلة مرضية لشخص آخر كأخذ قرنية العين لإنسان ما عند استئصال العين لعلة مرضية. 4. يحرم نقل عضو تتوقف عليه الحياة كالقلب من إنسان حي إلى إنسان آخر. 5. يحرم نقل عضو من إنسان حي يعطل زواله وظيفة أساسية في حياته وإن لم تتوقف سلامة أصل الحياة عليها، كنقل قرنيتي العين كلتيهما. 6. يجوز نقل عضو من ميت إلى حي تتوقف حياته على ذلك العضو أو تتوقف سلامة وظيفته الأساسية فيه على ذلك، بشرط أن يأذن الميت قبل موته أو يأذن ورثته بعد موته، أو بشرط موافقة ولي أمر المسلمين إن كان المتوفى مجهول الهوية أو لا ورثة له. 7. ينبغي ملاحظة أن الاتفاق على جواز نقل العضو في الحالات التي تم بيانها مشروط بألا يتم ذلك بواسطة بيع العضو، إذ لا يجوز إخضاع أعضاء الإنسان للبيع بحال ما. أما بذل المال من المستفيد ابتغاء الحصول على العضو المطلوب عند الضرورة أو مكافأة المتبرع وتكريمه فمحل اجتهاد ونظر. 8. كل ما عدا الحالات والصور المذكورة مما يدخل في أصل الموضوع فهو محل بحث ونظر، ويجب طرحه للدراسة والبحث في الدورات القادمة. بعدين المؤتمر الإسلامي الدولي المنعقد بماليزيا انتهى إلى القول بجواز نقل الأعضاء بشرط الضرورة ونص على حرمة المتاجرة بالأعضاء الآدمية. ولجنة الفتوى في المملكة الأردنية الهاشمية صدر قرارها المتضمن جواز النقل بشروط 5. هذه منها موافقة الميت أو والديه أو وليه عند وفاته أو ولي الأمر المسلم إذا كان المتوفى مجهول الهوية. 2. وأن توجد الحاجة أو الاضطرار. 3. وأن لا يكون بمقابل مادي. وانظر نص الفتوى في انتفاع الإنسان بأعضاء جسم آخر حيا كان أو ميتا. وصدر في هذا أيضا فتوى عن مكتب الإفتاء بوزارة الأوقاف والشؤون الإسلامية بدولة الكويت. وصدر أيضا فتوى من لجنة الفتوى بالأزهر. وصدرت أيضا فتوى من لجنة الإفتاء للمجلس الإسلامي الأعلى في الجزائر، واشترطت رضا المنقول منه ما لم يكن ميتا، فلولي الأمر الحق في أن يأذن بالنقل. هذه يا إخواني آراء المجامع الفقهية وبعض لجان الفتوى، مما يدل على أن هذا الموضوع قد خدم من أعلى جهات الإفتاء. أحبتي في الله، التبرع عمل صالح، وأعظم التبرع ما حصلت معه جودة الحياة. وما من شك في أن التبرع بالأعضاء سبيل لجودة الحياة والبعد من الوفاة التي يسببها هذا العضو المتألم. ولذلك فإن هذه الآية الشريفة التي قرأت وتقرأ وهي عمدة من يراها، فمن أحياها فكأنما أحيا الناس جميعا. هذا الموضوع يا أحبابي بارك الله فيكم من أنفع المواضيع، وهي إعادة للأمل بعد أن ذاق صاحبه الويلات العظيمة ورأى الموت في أوقات متعددة. وفي هذا الموضوع تيسير على العباد ورحمة بالمصابين والمنكوبين وتخفيفا للألم من هؤلاء المتألمين، وكل ذلك من مقاصد الشريعة. فإن الشريعة تأمر بما ينفع وما يستفيد منه الخلق المسلمون وغيرهم، وتنهى عما يضر. ومن قواعد الشريعة لا ضرر ولا ضرار، ومن قواعدها الضرر يزال، وقد أمكن أن يزال هذا الضرر بالتبرع الذي لا يضر. أحبتي في الله، إن الله تعالى امتدح من أعان أخاه ومن كشف كربته ومن نفس عن مصيبته ومن أعاد له أمل الحياة السليمة. ولهذا أحبتي في الله، هذا العمل الذي مدحه الله يأتي من فوق عمل الإيثار. عمل الإيثار عندما يؤثر الإنسان أخاه، هذا رأيناه كثيرا. يصاب أخوك تذهب للمستشفى وتقول أنا أتبرع به، أتبرع بكليتي له، لأني لا أريد ولا أتحمل أن أرى أخي كل أسبوع يذهب إلى جهاز الغسيل مرتين، وأنا تأكدت من الأطباء أنهم لا يضرني ذلك. ولذلك يسأل بعض طلبة العلم: هل التبرع بالأعضاء يجب في بعض الحالات؟ فنعرض له مثال: لو أن والد إنسان أصيب بتعطل الكلى، وقال الأطباء: ابنك هذا موافق ولا يتضرر بشيء، فطلب الوالد من ولده أن يتبرع له، قال: لا والله يا أبوي أنا خاف، ما رأيكم، يجب ولا ما يجب؟ الطب يقول لن تتضرر، والألم والتعب مع الوالد يراه الابن، والآن ليس للابن عذر إلا أن يقول أخاف. هل يعذر؟ يأتون إلينا الفقهاء يسألنا، قل له: والله ما تعذر، أنت بس تأكد أنك لن تتضرر. إذا تأكدت إن شاء الله قالوا هذه العملية ما منها خطر، فتبرع لوالدك، وهذا من الإيثار الذي يحبه الله ويحمده العقلاء من الناس. أحبتي في الله، إن التبرع بالأعضاء في هذا العصر نعمة من الله، رأيناها واقعا ملموسا عندما يبتلى الإنسان بالتبرع بالتلف في الكليتين أو في الكبد، ثم يفقد كثيرا من أعماله ويتألم كثيرا من واقعه، ويتنكد أولاده وزوجته ووالداه، ثم ييسر الله له السلامة والعافية على يد أحد إخوانه. نحن نعرف كلنا أن هذا فتح مبين وعمل من الأعمال الصالحة، وأن على الإنسان أن يسارع إلى فعله عند الحاجة. أما التبرع يا إخواني من الميت فهذا أخف، ونحن نعرف يا إخواني أن الميت بعد أسبوع ما مصير أعضائه، إن مصيرها التلف والدود، وتخسر الأمة شيئا يمكن الاستفادة منه. أنا أعرف يا أحبابي أحد الذين أعرفهم جيدا توفي ابنهم في حادث، والأطباء استدعوا أهله قالوا: ترى خلاص الآن الابن ميت، بس نريد نعرض عليكم التبرع بالأعضاء. أنا جارهم قريب منهم، قلت لهم: فلان تعرفونه؟ قال: قلت: توفيت زوجته وتبرع بكليتين وقرنيتين وجزء من الكبد وأعضاء أخرى، لكن تقريبا يمكن 7 8 استفادوا من هذه المرأة التي توفيت فجأة. ولدكم الآن شاب عمره الآن 22 سنة فقد حياته، هذه صدقة جارية، وقف، ما دام الناس يستفيدون منها فهي وقف، صدقة جارية. هل الآن لا بعدين نتأخرها، فقرروا أنهم يتبرعون. لكن إحدى البنات الله يصلحها سألت أحد المشايخ الكبار فقال: لا تشجون بطنه، لا تسوون فيه مثله، لا، احذروا، خلوا ابنكم يروح لربه ما مثل به. المهم اتصلت الأم وقالت: يا شيخ ترانا هونا، لأن سألنا الشيخ وقال: وأنا والله ماني مطمئنة أنه يفتح بطن ولدي ويؤخذ منه كذا. وقلت: أنت بس تمنعين صدقة جارية تكون لكم وتهبونها لابنكم ولن يتضرر ابنكم شيئا. يعني ابنكم لو جئنا بعد مدة وطلبنا منها أعضاءه لا نجدها أنها قد تسلط عليها الدود وعادت ترابا كما كانت في البدء ترابا. المهم يا أحبابي أن بعض أحبابنا يرون في الفتوى المنع براءة للذمة، هم يرون هذا، ونحن نرى أنه زيادة في الأجر، والخلاف موجود من عصر الصحابة إلى الآن، ونحن لا ننتقد أحد، كل إنسان يفتي بما يرى أنه أنفع وأنه أصلح وأنه أقرب إلى الله تعالى. ولهذا نحن نطالب إخواننا الآن في مركز زراعة الأعضاء أن يركزوا على هذا الموضوع وأن ينشروه للناس. الآن ما شاء الله خادم الحرمين الشريفين وولي عهده تبرعوا بالأعضاء بعد الوفاة، ينشرون هذا الفكر. والحمد لله عندنا الآن يا إخواني التلفزيون السعودي، وعندنا إذاعة القرآن وإذاعة نداء الإسلام وبقية الإذاعات، وعندنا أيضا يا أحبابي بارك الله فيكم قناة المجد ولها جمهور أيضا. لو أنه يعقد ندوات الآن، إخواننا الأطباء وإخواننا الشرعيين يعني يحبون نشر المعرفة ويحبون كسب الأجر، ولهذا أدعو أن تقام ندوات علمية ويفتح فيها السؤال والجواب، يعني يسألون المشايخ والأطباء، تكون الندوة من طبيب ومن الفقيه، وتكثف مثل هذه الأعمال. ترى إذا انتشرت تنتشر المعرفة ويسمع الناس الحكم الشرعي ويسمعون من الأطباء. هذه الأعداد التي ذكرها الإخوان الذين استفادوا وعادوا إلى ممارسة الحياة الطبيعية بعد التبرع، مهم جدا يا إخواني أن يسمع الناس ذلك. وأنا أعرف الإخوان الشرعيين كثير في جميع الجامعات، جامعة الإمام، جامعة أم القرى، جامعة الإسلامية، في أيضا المشايخ الموجودين الآن في القضاء وفي غيره. كل هؤلاء الآن يا إخواني مستعدون أن ينشروا المعرفة. وأنتم تعرفون رأس القمة خادم الحرمين الشريفين وولي عهد الأمين سجلوا في هذا الموضوع. أنا أعرف يا إخواني قبل ما أدري كم 20 سنة دعيت إلى مثل هذا الاجتماع وأنا شوي صريح، تكلمت ودعوت وقالوا تبرعت، سجلت تبرعي. انتقدني بعض الإخوان قالوا: أنت الآن عملت وتبرعت وما تدري يا ابن الحلال، أنت سيمزق جسدك إذا مت، كل اللي في بطنك بيشيلون. طيب أنا مت، يشيلونه ولا يخلون؟ ها؟ أنا مت، المهم أنا أفدت أو لم أفد، استفاد مني مريض أو لا، هذا اللي يهمني. أما أني سيفتح بطني ويخرج، أنا أعلم أني بعد سنة سيكون غالبي ترابا، جسمه اللي تشوفون سيكون تراب، لكن إذا نفعت سأكون قد سجل لي حسنات. ودعا لي أناس كثير. لاحظوا الآن، يوم من الأيام أنا مع أحد المشايخ الكبار ركب قرنية وصار يشوف. قلت له يا شيخ وش وضعك الآن؟ أنت الآن ركبت قرنية. قال والله يجزاك خير، بس إني ما أدري هو مسلم ولا كافر. يقول اللي أعطاني مسلم ولا كافر، المهم أنه أحسن إليك، المهم أنه يعني قدم لك معروفا تدعو له بسببه إن كان مما يستحق الدعاء. أحبتي في الله، الموضوع كثير، لكني أعرف أنا أن إخواني المشايخ شركاء معي في بيان الحكم الشرعي، ولذلك تركت أكثر ما في هذه الأوراق، لأني أعلم أنهم سيكون تطرقهم إليه أحسن من ما كان عندي. أشكركم على حسن استماعكم، وأسأل الله تعالى أن يوفق هذا المركز بكل خير، وأدعوه إلى أن يزيد نشاطه في توعية الناس. بقي عندي مسألة أريد أن أقولها. يأتي إلي ناس غير سعوديين يريدون أن يتبرعوا، يقولون نريد أن نتبرع. رأينا أن أخواننا اللي تبرعوا لم يتضرروا، ما طريقة التبرع؟ رحنا لهم وقالوا لا، أنت بالسعودي، أنت بالسعودي ما نقبل تبرع. ونحن صحيح أن الجنسية ما هي بالسعودية، لكن الهوى والقلب وهذا اللحم، يقولون كذا، هذا اللحم تراه ما انبت إلا في السعودية. يقول لا ننسى جميل السعودية. فهل عندكم من طريق إلى أننا نتبرع؟ هكذا يقولون لنا ونحن أنقلها لكم. وإذا كونتم لجنة لدراسة هذا الموضوع، ترى أنا من ضمن إن شاء الله اللي بيحضرون، ونرجو الله أن ينفع بنا. أشكركم مرة أخرى، وأدعو لكم وأدعو للإخوان القائمين على هذا المركز، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. أحسن الله إليكم وغفر لكم وجزاكم الله عنا خير الجزاء. للتبرع بالأعضاء وزراعتها شروط وضوابط سيتحدث عنها صاحب المعالي الشيخ عبد الباقي بن محمد آل الشيخ مبارك، وهو عضو في هيئة كبار العلماء، والشيخ له سيرة ومسيرة في السلك القضائي من عام 1409، وما زال على رأس العمل، فهو حالياً عضو في المحكمة العليا. عمل سابقاً رئيساً بالمحكمة الجزائية بالأحساء، رئيساً لمحكمة الأحوال الشخصية بالدمام، وكذلك كان قاضياً بمحكمة الاستئناف بالدمام. فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. الحمد لله الذي خلق الإنسان في أحسن تقويم، ووهب له أعضاء وكرمه غاية التكريم، والصلاة والسلام على سيدنا ونبينا محمد إمام الأنبياء
وسيد المرسلين القائل: ما أنزل الله من داء إلا أنزل الله له دواء. أما بعد، لا شك أن هذه المسألة من النوازل الطارئة على المستوى الطبي والمستوى الشرعي أو الفقهي. ومثل ما تفضل أستاذي وشيخي الشيخ عبد الله حفظه الله وحفظكم جميعاً أنها خدمت، وفي نظري المتأخر، لأنني لم أدخل في بحث هذه المسألة إلا بعد ما كلفت للمشاركة في هذا المنتدى المبارك الموفق، وأتقدم بالشكر للقائمين عليه والساعين في تهيئته وما يترتب عليه من ثمرات تخدم في هذا الجانب. جزاهم الله عنا خير الجزاء. ففي ظني من خلال هذه الدراسة المبسطة أن الخلاف في موضوع التبرع بنقل الأعضاء انتهى ولا ينبغي البحث فيه. أما الخلاف ينبغي أن يرتقي إلى ما هو يعني أرفع درجة من ذلك. صحيح أن الحديث عن البيع لا شك أنه ربما يكون صعب وبعيد، وإن كانت النصوص فيها ما يشير إلى شيء من ذلك، لكن مسألة المقايضة كأن تكون هناك مكافأة للمتبرع. وأنا من خلال عملي وأنا أسمع زملائي الأطباء في هذا المنتدى وهم يشاركون عن التبرع، ويعني أقول لعل من قبيل ما يقدم لإخواننا يعني الوافدين أو المقيمين عندنا أن يكون هناك لهم يعني مكافآت، إما إقامة دائمة مدة معينة أو سكن مجاني، وكذلك أيضا من السعوديين أن يقدم لهم مكافأة مسكن وما إلى ذلك. وهذا شيء طيب وحسن، لأن يقابلها شيء عظيم وهو إحياء الناس وأخذ الأجر. من ما أضيفه أنا مما رأيت من يعني الجانب الجزائي والعقوبات التي تحكم بها المحاكم، خاصة على من جهة يعني إخواننا الوافدين، يحكم بسنوات طويلة، يترتب على ذلك كلفة للجهات المعنية، السجون وما إلى ذلك. كم يكلف السجين؟ وهذه التكلفة ضرورة لا تنفك عن استقرار الحياة وحفظ الأمن وما تقوم به دولتنا الموفقة المباركة. ضرورة. لو يعني فرض أو قيل أننا نقايض هذا المحكوم عليه ب10 سنوات، أنك إذا أزيلت عنك المدة كاملة أو نصفها أو أكثر أو أقل عن طريق لجان تدرس هذه الجهة مختصة، مقابل تتبرع بكلية، لا سيما أن الدراسة والتجربة أثبتت أنه لا ضرر عليه. هذه إضافة. أنا حديثي طبعا قد يكون عن الشروط والضوابط، وقد تحدث عنه الزملاء الكرام، خاصة الأخ الكريم الدكتور عبد الله المفلحي، لكن سأسردها على شكل سريع، وإن أمكن أتحدث عن بعض التجارب الجزائية. طبعا من الشروط أن لا يكون المتبرع بمقابل مالي، هذا مقرر، والتحقق من حاجة المستفيد المريض، يعني أن يكون هناك فعلا ضرورة ملحة لهذا الأمر، أن يكون التبرع برضا واختيار دون إكراه أو إلجاء أو شيء من ذلك، وهو البلوغ والعقل والإرادة الكاملة. أن لا يؤدي التبرع إلى هلاك المتبرع أو ضرر فادح به. التثبت إذا كان التبرع من غير الحي، من ميت، أن يكون هناك تثبت من حصول الوفاة. أن يكون المستفيد ممن يرجى له النجاح والاستفادة الحقيقية. أن يكون تحت إجراء طبي وموثوق به. أيضا من ضمن هذه الأمور الذي أضيفها على مسألة الطب، ولا شك أن الطب مرجع، وقد قرر عامة فقهاء الإسلام أن الرجوع إلى الطبيب المسلم المؤتمن في جميع الأمور اللي تتعلق بالأحكام الشرعية، في الفطر في رمضان وفي سقوط بعض التكاليف، المرجع فيها إلى الطبيب. حتى في القصاص في الأعضاء يشترط الفقهاء أن لا يكون هناك حيف، يعني أن يكون في تجاوز على الجزء المختص منه، فالمرجع في ذلك الطبيب. فمتى ما قرر أن القصاص ممكن ولا هناك حيف يفعل، وقد يحصل هذا الشيء، لكن هذا يعتمد فيه على غلبة الظن. نعم. في ضوابط إضافية للتبرع من الأحياء، أن يكون العضو ممن يمكن العيش دونه، كالكلية أو الزيادة في ما يتجدد مثل ما تفضل الدم، الكبد، الجلد أو غيرها. ألا يترتب على المتبرع ضرر بدني يعني يسبب له إعاقة أو إشكالية، ألا يؤدي التبرع إلى اضطراب نفسي شديد، وهكذا. التبرع بعد الوفاة، يعني الحقيقة شيخنا الشيخ عبد الله أستاذي وشيخي يعني دائما حديثه ماتع، ولو أطال في الحديث يعني تستجيب له القلوب، لأن الأصل في الإطالة تكون مملة، لكن الشيخ يبدع في هذا الجانب، وسبحان من وهبه. فالحقيقة الشيخ سمعت منه في بعض البرامج إضافة جميلة جدا، لا شك أنها تحتاج إلى دراسة كما ذكر، وهي لها علاقة بما ذكرت، مسألة الذي يعني يحكم عليهم بالإعدام وسينفذ فيهم، يعني قد يبادرون بهذا التبرع، إما كفارة عما فعلوه، وإما أن يكون يعني مقابل شيء مادي يكون لأولادهم، أو أي شيء من هذا، يعني تحتاج إلى دراسة والاستفادة منها. عموما هو بعد الوفاة أن يكون يعني موصي بوصية أوصى بها المتبرع صراحة في حياته، ويشترط فيها موافقة الورثة بعد ذلك. نعم، أن يكون طبعا من الأشياء الضرورية. خاتمة أؤكد فيها على أني مما فهمته من خلال دراستي لهذا الجانب أن يعني التبرع أو الذين يحرمون أو يعني يذكرون أن التبرع يعني لا يجيزه الشرع، هو لا شك أن هناك نصوص وقفوا معها، وربما يعني جعلهم يقفون جانب الورع والاحتياط، لكن في ظني أن هناك نصوص كثيرة ربما أقوى أغفلت. فعلى سبيل المثال من يستدل بقول الرسول صلى الله عليه وسلم: كسر عظم الميت ككسره حي، وهناك نصوص في هذا المعنى: حرمة الميت كحرمة حي إلى آخره. هذا النص لا شك أنه يعني يحترم ويقدر ويؤخذ به، لكن لم ينظر إلى الجانب الآخر. ما ذكر في هذا السياق المقصود به العبث أو التجاوز، أنك تكسر عظم الميت بدون سبب أو تبالغ أو شيء، لكن انظر إلى الجانب الآخر. أنت إذا احتجت إلى ذلك لأن يكون هناك جانب مشرق، جانب عظيم في قول الباري عز وجل: ومن أحياها فكأنما أحيا الناس جميعا. والله لو اجتمع بلغاء الأرض منذ خلق الله آدم إلى يوم تقوم الساعة لا يستطيعون يأتون بشيء من بلاغة وإعجاز هذا النص. يعني تحيي شخص كأنك أحييت الدنيا كلها، البشر كلهم، والله شيء عظيم. طيب أنت لما تتبرع، شوف الجانب المقابل هنا كسرة، لما تتبرع مقابل مثل ما تفضل شيخنا الكريم، أنت الآن انتقلت إلى الدار الآخرة، والأعضاء هذه مآلها إلى التلف. انظر المقابل من المآل إلى ما ستقوم به من إحياء نفس كاملة، سيصلي، سيتبرع، سيصوم، يعني ينجب أولاد، إلى يوم القيامة هؤلاء الأولاد يتسلسلون في ميزان حسناتك على شيء لا يضرك أيضا، لا يسبب لك أي إشكالية. فالنظر إلى هذه النصوص مع الأسف، أيضا النصوص الأخرى: من قتل نفسه بحديدة فهو كذا إلى خالدا مخلدا، ومن يتحسى سمه إلى آخره. هذه النصوص على الشخص الذي يجني على نفسه عبث بدون سبب وأسأل الله عز وجل أن ينفعنا وإياكم، وشكرا مرة أخرى، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. شكر الله لكم شيخ عبد الباقي على هذه المعلومات الماتعة. وورقتنا الخامسة عن الأحكام الشرعية لحالات التبرع بالأعضاء. ضيفنا صاحب المعالي الأستاذ الدكتور عبد الرحمن بن عبد الله السند، الرئيس العام لهيئة الأمر بالمعروف والنهي عن المنكر، وفضيلته عمل مديراً للجامعة الإسلامية، ولمعاليه اهتمام بالفقه الطبي نعرفه، حيث لمعاليه بحث بعنوان الضوابط الشرعية للعمليات التجميلية، وشارك في العديد من ندوات الإدارات مع إدارات التوعية الدينية بوزارة الصحة، وشارك في ندوة عن أحكام العمليات الجراحية، وندوة أخرى عن أحكام أعضاء الجسم وعمليات تحسين القوام، وندوة ثالثة ورابعة عن أخلاقيات الفحوصات الطبية، والعديد لمعاليه من نشاط مع الجمعية السعودية للفقه الطبي. فنرحب بفضيلته ولكم المجال.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، أحمده جل جلاله بمحامده بجميع المحامد بما يليق به جل جلاله، وأشهد أن لا إله إلا الله وحده لا شريك له، وأشهد أن نبينا محمدًا عبد الله ورسوله صلى الله وسلم وبارك عليه وعلى آله وأصحابه وسلم تسليماً كثيراً. أما بعد، فإني سعيد بالمشاركة في هذا المنتدى العلمي المتميز بموضوعه وبمباحثه ومحاوره المهمة. ومن المهم في بداية هذه الكلمة المختصرة أن نبين ما تقرر، وهو محل الإجماع الاجتهادي المعاصر في مسألة التبرع بالأعضاء. فإن مما استقر فقهاً في هذا العصر جواز التبرع بالأعضاء وفق الشروط والضوابط التي ذكرها المجيزون. فهذه مسألة لا حاجة إلى أن يعاد البحث فيها مع استقرار الفتوى في هذا العصر من خلال المجامع الفقهية والاجتهاد الجماعي بجواز التبرع بالأعضاء على التفصيل المذكور في هذه القرارات والفتاوى. ومما استقر فقهاً أن الأعضاء ليست محلاً للمعاوضة من جهتين: من جهة عدم ملكية الإنسان لبدنه، ومن شروط صحة المعاوضة استقرار الملك، أن يستقر المالك على هذا الملك. وهنا هذه المسألة وهذا الأمر منتفي في ما يكون عليه الإنسان في بدنه، فهو ليس مالكاً له، وإنما مؤتمن على بدنه، وليس له التصرف في بدنه تصرف المالك. ومن جهة أيضاً ثانية، وهي عدم مالية الأعضاء، فليست أموالاً تقبل المعاوضة، وما دام أنها ليست مالية فليست محلا للمعاوضة. هذه أمور مستقرة فقها يجب أن تنطلق كل الدراسات والبحوث على ما بعد هذين الأمرين العظيمين في مسألة التبرع بالأعضاء. وإذا تأملت أيضاً في هذه القرارات فهي قد مضى عليها سنين عددا، يعني أول قرار مجمعي كان قبل أكثر من 40 عاماً، وبالتالي فإن أيضاً ما استجد في باب نقل الأعضاء طبياً يجب أن يظهر وأن يبرز إلى الفقهاء وإلى المتخصصين في العلوم الشرعية المطلوب منهم النظر فقهاً في مسألة التبرع بالأعضاء، فإن الحكم على الشيء فرع عن تصوره. ومن المتقرر فقهاً أن ما كان النظر فيه معتمد أن ما كان النظر فيه يعتمد على أهل الخبرة والاختصاص فليس للفقيه أن يتكلم فيه إلا من خلال حكم أهل الخبرة والاختصاص، كما قال الإمام ابن القيم رحمه الله في بيع المغيبات، يعني الزروع التي تكون في الأرض، ليس من شأن الفقيه أن يقول ذلك فيه غرر كبير أو ليس فيه غرر وجهالة، وإنما مرجع ذلك إلى أهل الخبرة، والفقيه بابه أنه يجوز ذلك أو لا يجوز من خلال ما علمه من كتاب الله وسنة نبيه صلى الله عليه وسلم وما علمه من قواعد الشريعة ومقاصدها. ولذلك النظر في هذه المسائل وفي هذه المسألة على وجه الخصوص لا ينفك أبداً عن أهل الاختصاص الأطباء. أنا سعدت كثيراً بما سمعت من سعادة الدكتور سويدان وسعادة الدكتور عبد الله في عرض ما يتعلق بالأثر الطبي على المتبرع. وأنا أطلب من المركز من خلال ما سمعت، وأنا أعتني وأزعم أنني أعتني كثيراً بمسائل النوازل الطبية، ما سمعته اليوم من هذا التقرير الطبي في مسألة عدم وجود الضرر على المتبرع فيما يطلب من صور التبرع المشروعة، هذا الحقيقة يجب أن يذاع وأن يخرج إلى الناس، لأنه ينبني عليه مسألة أعظم من مسألة التبرع. وقد أشار إلى ذلك معالي الشيخ عبد الله المطلق في مسألة النظر إلى حتى أقصى من ذلك، وهو مسألة الوجوب، خاصة إذا توقفت حياة هذا الإنسان على التبرع وأنت قادر على التبرع وليس هناك أي ضرر على هذا المتبرع، فلا أقل من أن يقال أنه فرض كفاية يجب أن يقوم به من يكفي لسد هذه الحاجة، بل هذه الضرورة القائمة في نفس ستتلف لو لم تتدارك بمثل هذا التبرع. ومن باب القياس فإنه لو كان على إنسان إذا مر بشخص أشرف على الهلاك، يعني مثلا إنسان كفيف ويسير وحده وأمامه حفرة، لو وقع فيها مات لأنها بعيدة القعر أو تكون مليئة بالماء ونحو ذلك، فلو تركه ألا يأثم؟ وأيضا تنبيهه أليس واجبا؟ بلى، لا يجوز له أن يتركه، بل لابد أن يقدم له ما يكون سببا في إنقاذه. وهذا أيضا متقرر في الفقه بأنه يجوز حتى ولو كان فيه ضرر يسير أكبر مما يتحقق من المنفعة المرجوة، فإنه تقدم بالأخذ بأعلى المصلحتين ودفع بأخف الضررين. لو أن امرأة لا بد من شق بطنها ميتة لاستخراج الجنين، ذكر الفقهاء جواز هذه المسألة، وأن بقاء الحي واستخراجه ولو كان بشق هذا البطن لأجل حياة هذا الجنين أن ذلك جائز. وهذا يجعل كثير من الناس الذين يتحججون بأن شق البطن وأن إخراج هذه الأعضاء بعد الوفاة للاستفادة منها أنه من باب المثلة ونحو ذلك، أن هذا مندفع بما تقرر فقها بأن مصلحة الحي مقدمة على مصلحة الميت، وأنه وإن كان فيه شق للبطن وهذا فيه شيء من ما يصيب هذا الميت، ولكن لإدراك حياة الجنين جاز ولو كان هذا فيه شق البطن. هذا أيضا متقرر فيما يكون في المتبرع بعد الوفاة. وأنا أعجب ممن لا يزال في نفسه من التردد في هذه المسألة مع ظهور النفع والمصلحة. ليس هذا فقط، بل إن الناظر في نصوص الشريعة في الكتاب والسنة يجد أن الإحسان بدفع الهلاك عن الحيوان سبب لمغفرة الذنوب ودخول الجنة، فكيف إذا كان ذلك في سبيل إنقاذ حياة إنسان بل ومسلم بل وقريب؟ النبي صلى الله عليه وسلم أخبر عن رجل سقى كلبا فغفر الله له، وعن امرأة بغي من بني إسرائيل سقت كلبا فغفر الله لها، غفر لها الذنوب والخطايا والسيئات بسبب أن سقت كلبا، فكيف بمن ينقذ حياة إنسان بل مسلم، بل أحيانا من الأقارب، من ربما يكون والد هذا المتبرع أو والدته أو من أقاربه من إخوته من أخواته زوجته زوجها ونحو ذلك. فهذا يدل على عظم هذا الأمر وأنه من أعظم ما يتقرب به إلى الله جل وعلا. ولذلك لا تعجب من المبادرة الكريمة من ولاة أمرنا بالتبرع بالأعضاء من خادم الحرمين الشريفين ومن ولي عهده بعد الوفاة، وأن ذلك كان في الحقيقة من باب جعل ولاة أمرنا أسوة وقدوة لما لهذه المسألة من عظيم الأثر في الثواب والأجر ورجاء ما عند الله جل وعلا. فالإنسان يحرص على أن يكون له أبوابا من الخير يفعلها، ومن أعظم ومن أجل ومن أشرف ومن أحسن ما يبقي الإنسان له من أثر أن يكون له في أعضائه النفع للناس. كم من شخص سينتفع من هذه الأعضاء التي مصيرها إلى التلف وليس لها فائدة. ولذلك فإن الناظر في نصوص الشريعة وفي قواعد الشريعة ومقاصدها لا بد له مع ما سمعنا وتقرر طبا ومن المختصين ألا ضرر البتة، قد يكون في حكم المعدوم الضرر مع عظيم النفع واستنقاذ حياة إنسان أشرف على الهلاك، أن ذلك من أعظم ما تنفع به إخوانك من المسلمين ومن المسلمات. لا بد أن يشهر ذلك وأن يستعلن به وأن يظهر ذلك جليا. أنا أحمل إخواني وهم أهل لهذه لما حملوا من هذه المسؤولية، مسؤولية الإعلان والبذل الجهد في المركز السعودي لزراعة الأعضاء، أن ينشطوا مع إخوانهم من المختصين في الشريعة في دعوة الناس إلى التبرع وبيان الفضل المترتب، بل وأحيانا ما قد يكون وصولا به إلى الفرض، وأن يكون من فروض الكفاية، وأنه قد يأثم الناس لو تركوا هذا حتى يهلك لأنهم لا يريدون أن يتبرعوا له. هذه مسألة مهمة ولا بد أن تقرر وأن تبين للناس حتى يعلموا ما وصلت إليه هذه المسألة من الأهمية، وأن لا تبقى هذه المسألة من المسائل الاختيارية والتشجيعية فقط، بل يتوصل بها في بيان أحكامها الشرعية إلى ما يجب أن يكون عليه الحال. وأنا أظن لو كان هناك مما توصل إليه الأطباء في هذا الوقت بما عرض قبل 40 سنة لكان الحكم أكثر في الوضوح، وتعدى مسألة الجواز إلى ما هو أعظم من ذلك من الاستحباب والوجوب في بعض الأحيان وفي بعض الصور. ولذلك فإن هذا المنتدى أحسب أن لو لم يكن من ثماره إلا استثارة هذا الموضوع مرة أخرى بأن ينشط المركز وينشط أهل الاختصاص وأهل الاهتمام سواء من المختصين في الجوانب الطبية أو من إخواننا من المختصين في الشريعة، أن ينشطوا في هذا الجانب، وأن تكون هناك أكثر من لقاء ومن منتدى ومن مؤتمر، وأن تضاعف الجهود والأعمال في بيان مثل هذه المسائل. أؤكد أيضا على مسألة قد يكون الشيخ عبد الباقي ذكر مسألة الحوافز، فمما تقرر فقها عند المعاصرين المنع بجانب حتى ولو كانت عن طريق الحوافز، لأن هذه تصبح على سبيل المعاوضة، وإن كانت سميت هدية فإن النظر في العقود إلى الحقائق والمعاني لا للألفاظ والمباني، وبالتالي تصبح على سبيل المعاوضة، وهذا ممتنع شرعا، وليست الأعضاء محلاً للمعاوضة مطلقاً. ولذلك فإن الانتقال إلى مسألة الحكم الشرعي في هذا الأمر والانتقال به إلى ليس بمجرد الجواز إلى ما هو أعظم من الاستحباب والحث إلى الوجوب على الأقل الكفائي، فإننا بذلك قد أدينا ما يجب في هذه المسألة. أسأل الله جل وعلا أن ينفعنا بما سمعنا، وأن يكون لهذا المنتدى الأثر الكبير الذي نتطلع إليه. وأنا أستحث الإخوان في المركز وكل المهتمين بهذا الشأن أن ينشطوا في هذا الباب تحقيقاً لمقاصد الشريعة ولدفع الضرورة والحاجة القائمة بما سمعنا من هذه الأرقام الكبيرة، والتي تنتظر أن يحسن إليها جماعة المتبرعين. نسأل الله أن يشفي مرضى المسلمين وأن يجعلنا هداة مهتدين. صلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه أجمعين.
وأحسن الله إليكم معالي الشيخ، جزاكم الله خير وبارك فيكم وفي علمكم وعملكم. تجربة مريض. سنكون مع تجربتين، الأولى لمن استقبل كلية من أخيه، والآخر من استقبل جزء من كبده من صديقه. فاسمحوا لي أن نكون معهم مباشرة. الأول الأخ العزيز الأستاذ فيصل بن سعود الزعبي، ويبلغ من العمر 37، وهو مستقبل لكلية من أخيه. تفضل أستاذ فيصل. تفضل.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. أيها الحضور الكريم، السلام عليكم ورحمة الله وبركاته. الحمد لله الذي جعل بعضنا رحمة لبعض، وجعل من التراحم والإيثار أبوابا للأجر والحياة. أتحدث إليكم اليوم وفي قلبي مشاعر لا يمكن وصفها بعد أن منحني بعد فضل الله أخي وعضيدي الأمل بعد مشوار طويل من الألم، فكانت لي شريان حياة، فقد تبرع بإحدى كليتيه فأنقذني من ألم طويل ومعاناة لا يعلمها إلا الله. لم يهبني فقط جزءا من جسده، بل وهبني حياة جديدة وأملا جديد. وسوى سجدة شكر ما زلت أكررها حتى هذا اليوم، بل كل يوم أعيشه، فأني أتذكر هذه النعمة. إن التبرع بالكلى ليس فقط عملا إنسانيا نبيلا، بل هو صدقة جارية وثواب دائم وأثر لا يمحى في حياة الآخرين. كم من مريض اليوم ينتظر، ومن نفس تتوق لحياة طبيعية لا تقيدها أجهزة الغسيل ولا سجون الألم. أنا اليوم بينكم بفضل الله، ثم بفضل شجاعة أخي الذي لم يتردد لحظة أن يكون سببا في شفائي بعد الله. وأدعوكم من أعماق قلبي أن تكونوا مثله بعطائكم وجودكم، وأن تفتحوا قلوبكم وتنشروا الوعي وتحملوا الرسالة. ليس كلنا يستطيع أن يتبرع، ولكن كلنا يستطيع أن يحدث فرقا بالكلمة، بالدعم وبالتوعية. فالتبرع حياة والتوعية مسؤولية. ومن ضمن المواقف رأيت شخصا في أول يوم له في جلسة الغسيل فاقد الأمل ومكسور الخاطر ومنهزم، ونسي أن الأمل بالله كبير. أتيت إليه وحاولت أن ألاطفه، فأرسلت له بعض أبيات بالشعر النبطي، فكنت أقول: المراجل مدرسة يا فشل ولا نجاح، ما توفى كل رجل عن القمة سلا، لا تضيع حكمة الصبر في كثر الصياح، هي مفاتيح الفرج، هي مذللة البلاء. الحسايف يوم ليلك يطول بلا صباح، القناعة والرضا نور للي مبتلى. انظر بعين البصيرة ترى العليا جناح، اترك العالم تحت ورق دايم للعلا. السعيد اللي قنع من زمانه واستراح، والتعيس اللي تذمر على كل الملا. ما فشلنا بالصبر، ما فشلنا بالكفاح، ما فشلنا بالمراجل، فشلنا بالكلا. وأضيف على ذلك لو لم أكن زارعا لكنت متبرعا. ختاما، من أحياها فكأنما أحيا الناس جميعا، فلنكن سببا في حياة إنسان. والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. جزاك الله خير أخي فيصل، وأسأل الله سبحانه وتعالى لك أن يمتعك بالصحة والعافية والسلامة من كل سوء يا رب، ويجزي أخوك كل الجزاء. وبارك الله فيك على ما سمعنا منك. والآن أيها الأخوة والأخوات، مع الأخ العزيز خليل بن عبد الله الشدي، يبلغ من العمر 32 سنة، وهو قد تبرع مأجورا بإذن الله تعالى مشكورا بجزء من كبده لصديقه. تفضل أخوي خليل.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف الأنبياء وأتم المرسلين سيدنا محمد عليه أفضل السلام وأتم التسليم. وفي قوله تعالى: ومن أحياها فكأنما أحيا الناس جميعا. الحمد لله الذي جعل من العطاء حياة ومن الإحسان نجاة. في هذه اللحظة التي أتحدث فيها أمامكم لا أتحدث فقط كمتبرع، بل كإنسان آمن أن الحياة لا تكتمل إلا مع المشاركة مع الآخرين. ومن باب الصداقة ومن باب الإنسانية، لقد من الله علي بفرصة أن أهب جزءا من كبدي إلى صديق غال علي، وكان ذلك القرار من أعظم التجارب التي مررت بها بحياتي. عندما رأيت الصديق يتألم ما هان علي أن أتركه في هذا الحال وأدير ظهري. التبرع بالكبد ليس مجرد إجراء طبي، بل هو رسالة حب ووفاء وتكافل إنساني. لله سبحانه وتعالى خلق في أجسادنا ما يمكن أن يكون سببا في إنقاذ حياة غيره، وجعل في العطاء قوة لا يشعر بها إلا من منح بلا تردد. لا يمكن وصف شعور الفرح عندما ترى من كنت له بفضل الله سببا في تغيير حاله من أفضل إلى أفضل. وكما ترون ولله الحمد، أنا الآن أتمتع بصحة جيدة ومتعايش بصحة جيدة، وأمارس حياتي طبيعية جدا. وأدعو كل من يستطيع أن يتفكر في هذه النعمة أن يدرك أن التبرع بالأعضاء ومنها الكبد هو باب واسع للأجر، ووسيلة لإنقاذ أرواح كانت على وشك الانتفاء. فهنالك آلاف المرضى ينتظرون بصيص أمل، ونحن نستطيع أن نكون هذا الأمل. رسالة اليوم: لا تترددوا أن تكونوا سببا في نجاة آخرين، فإن الحياة التي تهبى لغيرك تعود إليك أضعافا من الطمأنينة والرضا. شكرا لكم ودمتم سالمين، والسلام عليكم ورحمة الله وبركاته.
وعليكم السلام ورحمة الله وبركاته. بارك الله فيك أخوي خليل، وأسأل الله سبحانه وتعالى أن يمتعك بالصحة والعافية. وأنتم في هذا السن، سن الشباب، تتبرع لصديقك. ويعني نسمع كثيرا من الذين يتبرعون أنه لأمه أو لأبيه أو لأبيه أو لأخته أو لأخيه، ولكن يعني قليل ما نسمع أن يتبرع الإنسان لصديقه. فأسأل الله سبحانه وتعالى أن يجزيك خير الجزاء، وبارك الله فيك وفيما قدمت.
ندعو فضيلة العلماء الفضلاء والزملاء الاستشاريين الأطباء للحضور للمنصة للإجابة على تساؤلات الزملاء والحضور. لو كان أحد من الحضور لديه بعض الأسئلة فالمجال مفتوح. الميكروفون الزملاء الإخوان للأخ هنا. تفضل.
السلام عليكم. جزاكم الله خير وكتب أجر الجميع. محمد المزيد، استشاري عناية مركزة
قرب الميكروفون لو سمحت.
شكرا جزيلا. محمد المزيد، استشاري عناية مركزة الأطفال.
أنا ما نسمع، لو تقرب
طيب الصوت واضح الآن؟ طيب، محمد المزيد، استشاري عناية مركزة الأطفال. سؤالي لفضيلة المشايخ، دائما نتكلم عن حكم التبرع بالأعضاء خصوصا من المتوفى، فبيان حكم الوفاة الدماغية يكون مهم في هذه المسألة، خصوصا لما نتكلم عن التبرع بالأعضاء اللي يعتمد عليه حياة الإنسان مثل القلب أو الرئتين. فلو تفضلتم في توضيح حكم الوفاة الدماغية، وهل تعتبر وفاة حقيقية أم لا؟ وجزاكم الله خير.
بسم الله والحمد لله والصلاة والسلام على حبيبنا رسول الله. هذه مسألة يا إخواني كبيرة جدا وفيها أبحاث، وبعدما استقر الأمر فيها نوعا ما أعاد بعض الإخوان البحث فيها وأتى بمعلومات وكذا. فنحن اليوم في التبرع في الأعضاء. أما تحديد الحياة هذه التي أشار إليها حبيبنا جزاه الله خير، هذه إن شاء الله تسوون ندوة ثانية وتغدونا ونشوف.
إن شاء الله. لعل الدكتور فيصل السويداني يوضح بعض الشيء في هذا الخصوص من وجود لجنة لدى مركز زراعة الأعضاء في هذا الصدد يعني باقتضاء.
طيب، شكرا لك دكتور محمد على مداخلتك وسؤالك. نحن نعمل حاليا في نسخة محدثة من الدليل السعودي للوفاة الدماغية، ويشارك في هذا الدليل عدد من الأطباء والطبيبات السعوديين المتخصصين في المجال الوفاة الدماغية. والقاعدة الأساسية لدينا هي اليقين لا يزال إلا باليقين. فالأساس أن الإنسان حي إلا إن ثبت عكس ذلك. أتكلم عن الوفاة الدماغية، والدليل هذا موجود في المملكة العربية السعودية وقيد التطوير والتحديث موائمة مع أهم المعطيات العالمية. وأحب أطمن الجميع لله الحمد أنه المعايير السعودية بالنسبة للمعايير العالمية هي الأكثر صرامة في هذا المجال. بإذن الله عز وجل تشوفوا النسخة القادمة بإذن الله عز وجل قريبا بين أيديكم، تطمن الجميع بإذن الله عز وجل فيما يخص الوفاة الدماغية.
بس تعليق بسيط. هذه المسألة أيضا هي مرجعها إلى أهل الاختصاص والأطباء. فإذا تقرر أن المتوفى دماغيا هو طبيا متوفى تماما، ولو كان القلب ينبض والدورة الدموية تعمل، ولكنهم في حكم الطبي أنه متوفى، فالحكم كما قلنا في ذكر الأثر أو القول لابن القيم رحمه الله، المسألة ليست إلى الفقهاء وإنما إلى الأطباء، لأنهم يحكمون على ما يقوله الطبيب. فإذا قال الأطباء وأهل الاختصاص أن هذه وفاة طبيا ويعتبر متوفى، لأن الحكم إنما ينبني على ما يكون عليه حال الإنسان، وهذه الحال من الذي يخبر عنها حتى نعرف حقيقة الحال؟ هو المختص صاحب الخبرة، الأطباء. وهذا الذي جعل مجمع الفقه الإسلامي أحد المجمعين يرى أن الوفاة الدماغيا وفاة، والآخر يخالف لهذا الاختلاف، وهو مسألة من رأى أن الوفاة الدماغية من خلال نظر الأطباء أنها وفاة حقيقية، حكم بأن الوفاة الدماغية يعتبر متوفى ويستفاد، لأنه في الحقيقة لا يمكن أن يستفاد من بعض الأعضاء التي تتوقف حياة الإنسان عليها إلا عند المتوفى دماغيا. لا يمكن أن ينتقل قلب من إنسان حي، لأنه من شروط جواز التبرع ألا تتوقف حياة المتبرع على هذا العضو المتبرع به. وكذلك الوفاة الطبيعية قد يكون هناك تلف لهذا العضو قبل الانتقال، لكن ليس هناك أحسن من مرحلة المتوفى دماغيا في الاستفادة من الأعضاء، خاصة ما يتعلق بالكبد وبالرئتين وبالقلب وبالرئتين وأيضا بكامل الكبد. وبالتالي هذه المسألة مهمة جدا، واستفاضة النظر فيها والبحث فيها من أهم ما يجب على زملائنا في المركز السعودي لزراعة الأعضاء.
أحسن الله إليكم. عندي إضافة بالنسبة أثارها الدكتور محمد المزيد جزاه الله خير. فيه ندوتين أقيمت قديما يمكن 1436 أو 37 فيما يتعلق عن الموت الدماغي في الجانب الطبي والجانب الفقهي. يوجد موجودين الآن في اليوتيوب، أعدوها إدارة التوعية الدينية بصحة الرياض بالتعاون مع المركز السعودي لزراعة الأعضاء. اسمح لي الدكتور قبل، تفضل لو تعرف بنفسك.
السلام عليكم، أنا اسمي صالح الدماس، طبيب أمراض صدرية وتخصص زراعة رئة. أولا شكرا لأصحاب المعالي المشايخ والزملاء الاستشاريين، والشكر خاص لأخي دكتور طلال على ترتيب هذه الحلقة المهمة جدا لنا كأطباء. كما تعلمون عدد المتبرعين على المنصة كبير جدا، ولكن المعضلة التي تواجهنا عندما يأتي وقت استئصال الأعضاء حتى وإن كان الشخص قد أوصى بالتبرع هو كما قال فضيلة الشيخ المطلق معارضة الورثة أو ذوي المتوفى دماغيا للاستئصال. سؤالي: هل بالإمكان من الناحية الشرعية، ربما له أيضا جانب قانوني، اعتبار ما أوصى به المتوفى دماغيا وصية نافذة ويجب إنفاذها بغض النظر عن رأي الورثة الأب أو الأم أو الإخوان؟ هل يمكن للفريق الطبي أن ينفذ وصية المتوفى دماغيا ويقوم باستئصال الأعضاء دون اعتبار لرأي العائلة أو الورثة؟ جزاكم الله خير.
تفضل أصحاب معالي.
والله أنا ما فهمت سؤاله جيدا، لكن أنا أشوف أن الإخوان اللي يعيدون البحث في الوفاة الدماغية أنهم بيعطلون على أهل المركز عملهم، لأن تابعنا قبل بضع سنوات مؤتمر عقد في إحدى المحافظات واستقدم له ناس من خارج المملكة من الدول المتقدمة طبيا، ووقع الخلاف بينهم كما يقع في سائر الأمور. فالآن هذه المسألة أنا أشوف أنها إذا عدنا البحث فيها معناها أننا في نظري سنقفل على الإخوان الباب، لأن هؤلاء الذين يمنعون الوفاة الدماغية يقولون يعني أنكم لا تستطيعون أن تأخذوا من المتبرعين الأعضاء في هذه المرحلة لأنهم لم يصلوا إلى الوفاة، باعتبار أنه يمكن أن تعود لهم الحياة. أنا أشوف أن هذا سيعطل العمل الذي تقوم به الآن جميع دول العالم في التبرع بالأعضاء. ولهذا يعني إذا أثيرت هذه المسألة ينبغي أو يجب أن نكون مستعدين لها تمام الاستعداد عشان نخرج بكلام أو يعني معلومات موثقة مقبولة لا يحيد عنها أحد. أما ما دام المسألة فيها أخذ وعطاء والناس قائمون أمورهم ماشية ويتبرعون بالأعضاء، واستفاد أناس كثير. أنا والله ماني من الذين متحمسين إلا إذا وجد العلم، إذا وجد العلم الحقيقي الذي ينقل الناس مما كان معهم عندما قرروا الموت الدماغي وبينوه. فأنا يعني أقول للإخوان صحيح المسألة مهمة، لكن يجب أن يستعد لها استعداد كامل، لأنه سيغير في نظري أنا عمل الإخوان في ميادين التبرع بالأعضاء، مو عندنا في جميع العالم الإسلامي، الذين يرون لهذه البلاد ريادة ويقتنعون بكلام علمائها ويقتنعون بعمل أطبائها، والحمد لله عندهم لها مكانة مرموقة. فأنا أريد أن نكون على هذا المستوى، وإذا أردتم بحثه فاستعدوا له، وأنتم يعني كل من سار في طريق إلى الله سيؤيده الله يعني يرى الآثار الحميدة لذلك. لكن أنا أخشى أن ننتقل من شيء ثبت وعمل به إلى شيء يعني مشكوك فيه وربما تثور فيه مشاكل. الله يحفظنا وإياكم.
الجواب على السؤال يبدو أن الشيخ ترى ما فأنا أقول الموصي فيما هو مأذون له شرعا تنفذ وصيته ولا ينظر بعد ذلك إلى قرابته، فهذا أولى ما يكون به الواجب في تنفيذ الوصية. فإذا أوصى موصي بالتبرع بأعضائه بعد الوفاة ما يستأذن بعد ذلك الورثة ويقال لهم يحتاج إلى إذن تابع، يكفي هذا الإذن السابق الذي أذن فيه لصاحب هذا البدن بالتبرع بأعضائه، ولا يتسلسل الإذن إلى أو ينتقل الإذن إلى ورثته بعد ذلك حتى يقطع يعني الأمر، لأنه أذن في حياته بالاستفادة من أعضائه بعد الوفاة وصية، فيؤخذ بهذه الوصية إلا إذا كان هناك مانع آخر غير طلب الإذن. نعم.
شكر الله لكم.
الشيخ كلام الشيخ يعني 100%، لكن نزيد فقرة إن أيضا ما يقبل اعتراضهم، لا نطلب إذنهم ولا نقبل اعتراضهم، ما دام الرجل موصي ليس لهم حق يعترضوا عليه. الله يحفظكم ويحفظ الشيخ.
أحسن الله إليكم. في مسألة يعني قد تكون تشكل على كثير من الإخوان خاصة اللي يريدون التبرع. اللي في توكلنا الآن موجود في أيقونة على أساس اللي يريد يتبرع أو لا. هل موضوع توكلنا هذا هل يعتبر وصية؟
لا شك هذا توكلنا هو إيقان بأن المتبرع هو ذات الإنسان، لأنه في توكلنا فيما هو يعني تصرفات مالية وتصرفات أذنية كثيرة، ومنها هذا الأمر وهو الإذن بالتبرع بالأعضاء بعد الوفاة، فيعد هذا تصرف ثابت وموثق ولا يحتاج إلى شهود ولا يحتاج إلى أن أيضا يقيد عند غير هذه الوسيلة، ما دامت أنها معتمدة ورسمية وموثوقة ولا يمكن أن يدخل عليها غير المتبرع أو غير صاحب هذا الحساب، وهو الذي نفذ هذه العملية ونفذ هذا الطلب، فهذا كافي في أن يثبت أنه قد تبرع بأعضائه.
جزاكم الله كل خير. وإضافة لما قاله معالي الدكتور عبد الله المطلق على موضوع إشباع البحث على قضية الوفاة الدماغية، وليست يعني رؤية من رؤى هذا المنتدى، ولكن إن شاء الله تعالى سترى النور قريبا. هناك لجنة منذ ما يزيد عن 2 من مجموعة من الخبراء الأطباء، الدكتور طلال بنفسه يشرف عليها يعني بشكل مستمر، وإن شاء الله تعالى سترى النور قريبا بإذن الله تعالى فيما يخص هذا المجال. الأخ السائل هناك تفضل.
السلام عليكم، أنا ناصر حبتر، مقدم برامج قناة الإخبارية. من خلال حضوري لهذا المنتدى الرائع اتضح لي أن هناك فجوة كبيرة بين المجتمع وبين المركز. وإذا تحدثنا عن المركز فنحن نتحدث عن التبرع بكل أشكاله وألوانه. لازلنا ولا زال كثير من الناس في مجتمعنا يعتبر أن التبرع هو تنكيل بجثمان هذا المتوفي، وفيه يعني أشياء تبادرت لهم. يعني حسن اليوم بأن يكون عندنا علماءنا الأفاضل من كبار العلماء والمستشارين، وكذلك دمجهم بالكادر الطبي الذي يوعي هذا المجتمع. ألسنا بحاجة إلى تشريع؟ ونحن الآن في بلاد التشريع والأنظمة والحوكمة. ألسنا بحاجة إلى تشريع يسهل على الناس فهم هذه العملية؟ خاصة نتحدث عن كبار السن الذين لا زالوا غير مقتنعين بتاتا حتى وإن كان هناك موصي. بالنسبة لي أنا يعني خادم الحرمين الشريفين وسمو ولي عهده كان لي قدوة حسنة في أني اليوم متبرع ونازل على توكلنا. نحن بحاجة إلى تشريع يجتمع فيه العلم الشرعي والطبي من أجل إيصال هذه الرسالة إلى عقول الناس بشكل مبسط. كنت أتمنى أن يكون لدينا مشاهير حاضرين في هذا المكان، لأن لهم متابعين كثر ينقلون مثل هذه الفكرة، لكن نتوقع بأن مثل هذه الفعالية والفعاليات القادمة سيكون لها الأثر البالغ في إيصال هذه القيمة الكبيرة إلى عقول الناس. شكرا جزيلا وأعتذر على الإطالة.
شكر الله لك. هي ربما هو إضافة يعني
في نظام التبرع بالأعضاء موجود. يعني الجانب التشريعي والتأصيلي مشبع، لا من الناحية الشرعية ولا من الناحية النظامية، وصدر في عام 42 ولا لا؟ صحيح. قبل سنتين أو ثلاث أو أربع نظام اسمه نظام التبرع بالأعضاء. وبالتالي الجانب التأصيلي التشريعي التنظيمي مستقر، والحمد لله بنية التحتية في المملكة العربية السعودية في الجانب التأصيلي والتشريعي والتنظيمي، ولله الحمد تجاوزنا هذه المرحلة. باقي هو الأهم، هو الجانب التطبيقي والمبادرة وبث روح المبادرة في المجتمع. وهذا مبني الحقيقة على هذه المعلومات المهمة التي ذكرها الدكتور عبد الله والدكتور يوسف، أن التبرع ليس هناك أي ضرر على المتبرع في الحالات المذكورة، وأيضا عظم الأثر في إنقاذ حياة. اليوم يعني لم تنظر مسألة الجهاد في سبيل الله، تقديم النفس، وأن ذلك من أعظم ما يتقرب به الإنسان إلى ربه جل وعلا، وأنه ذروة سنام الإسلام. لماذا؟ لأن فيه حياة للناس في دينهم وفي أنفسهم. كذلك تقديم ما يكون به أصلا ليس هناك لا إتلاف على الإنسان ولا ضرر، وفيه إنقاذ حياة. المسألة ترى مسألة مهمة جدا في إيضاح هذا الموضوع للناس حتى يستشعروا عظم الأثر، وبالتالي عظم الثواب والأجر المترتب على هذه المسائل.
نعم. والجزء التنظيمي يعني تفضل دكتور عبد الباقي.
بخصوص ما تفضل به السائل الأخير الله يحفظه، الفجوة بين المجتمع وبين المركز السعودي لا شك أنها موجودة، وشيخنا الشيخ عبد الله أجاب إلى جزء منها، وهو ويعني في ظني ثلاثة. أحدها اللي تفضل به شيخنا، وهي مسألة الإعلام والتركيز عليه بجميع أنواعه. اثنين، التجربة. لما رأينا الأخوان اللي تحدثوا هنا لا شك أنها تعطي دافع وقوة. وأنا أعرف قريب زرع كلى من 20 سنة، ولله الحمد نشيط ويذهب ويحضر بعض المناسبات. 3 أبناء تبرعوا لآبائهم، أحدهم من أكثر من 10 سنوات، إلى الآن حياته جميلة وعلى أحسن حال. فنقل هذه التجربة مع ما قرره الأطباء يكون لا شك له أثر في تفاعل المجتمع. الأخير ربما يندمج مع الاثنين، التأكيد على ثمرة ذلك عند الشخص المتبرع. لا شك أن الذي يعطي يكون له أثر نفسي عنده. يقول الرسول صلى الله عليه وسلم: اليد العليا خير من اليد السفلى، واليد العليا هي اليد المنفقة، اليد التي تعطي. الأجر والثواب هذا مقام كبير جدا، يعني الدل على الخير له مثل أجر فاعله، من دل على هدى. الأحاديث الكثيرة، أنت لما تحسن في شخص في مثل هذا الأمر وتكسب له الحياة والإنجاب، بيتسلسل يوم القيامة كل حسناتهم وعطائهم وإنفاقهم في ميزان حسناتك. هذا مقام كبير ينبغي الالتفات له. أخيرا، الإحسان أو تربية اليتيم ورعايته. اليتيم، أنا وكافل اليتيم كهاتين في الجنة، لأن فيها الجانب الكبير هو جانب أنك تحييه وتعيش عيشة كريمة، وبعد ذلك تصور ما يأتي من بعد ذلك من خير وعطاء وإنفاق وأولاد عن طريق هذا اليتيم الذي قمت برعايته. ومعذرة، والسلام عليكم.
جزاك الله.
جزاكم الله كل خير. ويعني في هذا الصدد على الجزء التنظيمي هذا موجود، والمستشفيات في سياساتها وإجراءاتها وأقسام الجودة، يعني المركز السعودي لزراعة الأعضاء هو مرجعية لهم في هذا الصدد، وهي مدونة ومكتوبة يعني لدينا نحن في المؤسسات الطبية، وترتكز على التنظيمات التي وضعها النظام يعني في البلد. تفضل.
السلام عليكم ورحمة الله وبركاته. أسعد الله مساكم بخير أصحاب المعالي. كلامكم هو دافع قوي لنا نحن كمنسقي زراعة أعضاء في هذا البلد العظيم. لدي سؤالين. السؤال الأول: حينما يأتيني مريض أب لديه فشل كلوي ويحتاج إلى زراعة كلى، وأبناؤه يحتاجون أن يتبرعوا له وموافقون على التبرع، ولكن الأب يرفض، فما هو الواجب في هذا الشيء؟ هل نقوم بأخذ كلى الابن وزرعها للأب دون علمه أو موافقته؟ هذا أول سؤال. السؤال الثاني بالنسبة للسجناء. أعلم أن السجناء حينما يحفظون القرآن يأخذون نص المدة. معالي الشيخ عبد الباقي قال يعني يقدروا السجناء يتبرعوا بكلية ويأخذوا نص المدة أو يعفوا زي كذا. ما هو الحكم في هذا الشيء؟ وهل السجين السعودي لو قام بالتبرع بكلى أو بجزء من الكبد في حياته يعفى من المدة؟ ما هي الآلية في هذا الشيء؟ جزاكم الله ألف خير.
بالنسبة طبعا هذه مقترحات من فوائد وبركات هذا اللقاء، لكن هذه القرارات تتخذ بعد تشكيل لجان ودراسة ويحضر فيها أهل خبرة وفن وتجربة حتى تنتج عن هذه القرارات التي يكون لها أثر في مثل ذلك. بارك الله فيك.
السؤال الأول، أنا بعدين عشان الشيخ يفهم، بعد ما إنسان يريد أن يتبرع له أولاده والأب يرفض وهو المريض،
نعم.
فنقول لا ينظر إلى رفضه ما دام أنه في حال من هذا المرض وأن إنقاذ حياته مترتب على هذا التبرع ولو رفض. يعني هو رفضه من باب الشفقة بأولاده، أولاده راضون، لا يستأذن الأب في مثل هذه المسألة. هذا الرأي اللي يعني عندي. إذا كان الشيخ،
والله الشيخ الأخ أبو سعود عنده خبرة بالإذن الطبي، وهذا الظاهر من مواضيعه. ما رأيكم يا أهل الإذن الطبي؟
لا، هو ليس الأذن الآن، هو يقول المتبرع
يقول امتنع الشاي بامتنع.
هذا ليس هو الذي سيستفيد.
الإداري داري. بس هل يجبر؟
لا شيخنا الكريم،
ما بيجبر.
أنت مهم أنك تعرف هذه المسألة. لما تفضل عبد الرحمن يقول لك الابن يريد أن يتبرع ولكن والده يمنعه.
طيب
هل يستجيب أم لا؟ أجاب الشيخ عبد الرحمن، بس إضافتك جيدة يعني.
لكن الآن عندنا يا إخواني امتناع الأب نوعين. امتناع مثل امتناع البكر من الزواج. ما نبغي. فهمتوا ولا لا؟ ما يخالف. والامتناع الثاني الصملة، يقول الله لا يبيح عنكم ولا يحللكم ولا يمكن تعملون. هذا وش نسوي به؟ نبي الإذن من الإذن الطبي، نشوف وش رأيكم في مثل هذا الموضوع.
جزاك الله خير. أنا يعني صعب إني أتكلم بوجودكم، ما أجد حرج إني أتكلم بوجودكم يا شيخ.
لا عندك علم واضح بين.
هو يا شيخ الآن يوم جاي يعرفون بيقولون
أنا أشوف أن المسألة واضحة، يعني إذا كان يتوقف عليه حياة هذا الأب، وإنما المنع من باب الشفقة على الأولاد، والأولاد طبيا لا يتأثر بهذا التبرع، فلا ينظر إلى مثل هذه المسائل أبدا.
للتوضيح معالي
هذه مسألة يعني أنا فهمت من المشايخ الكرام أن التبرع من الابن لأبيه والأب يرفض، هذه مسألة، ولذلك مسألتك مهمة يا أخي الكريم. الثانية يريد أن يتبرع لشخص آخر صديق على سبيل المثال، والأب يمنعه والأم تمنعه، هل يستجيب ويطيع أبيه وأمه أو يطيع أباه وأمه؟ هذه أيضا مسألة، وفي ظني أن الإجابة عليها تحتاج أيضا إلى دراسة بعد إذن شيخنا الشيخ عبد الله إذا أراد أن
هو الآن عشان بس يوضح الفتوى، لو كان المتبرع من غير أبنائه يسمح، يعني ليس هو عنده الرضا في قضية الزرع، وإنما لأنها من أبنائه. لو كان المتبرع غير أبنائه يرضى.
أن سمح
مسألة إذا كان بهذا وهو مسألة الشفقة فقط لا ينظر إلى
الآن النظر من جانب الآخر. لو كان هذا مثل بعض الشيبان العنيدين يقول الله لا يبيحكم
لا يعلمون
ولا يحللكم،
ما يعلمون، يقول هذا متبرع ولا يخبون
هذا يأخذه الأطباء،
يخفون عنه.
نسأل الآن الأطباء هل ممكن أنكم تأخذون وتسوون العملية وهو ما يدري؟
بعد إذن الشيوخ
في عنصر
من الناحية الجراحية، من الناحية الجراحية هذه المسألة نواجهها صراحة، ما هو من الشيء القليل، بس نواجه هذه المسألة باستمرار. ولكن في معظم الأحيان عندما تجلس مع الأسرة وتشرح لهم الشرح الكافي الوافي للمريض وللمتبرع وسلامة المتبرع، في أغلب الأحيان يتم الموافقة. من نوادر الحالات يتمسك الأب أو الابن أو الشخص بقراره، ولكن مع الشرح الكافي وتفهيم الوالد مثل ما ذكرت فضيلة الشيخ، أغلب الأسباب هي الشفقة والخوف على الأبناء. ونواجه أيضا العكس، يجيك الابن يقول لك لا تقول لأبوي إن أبي أنا بتبرع له، ولكن طبيا يجب أن يعرف المتبرع مين اللي يتبرع له، بالذات إذا كان الابن من حقه أن يعرف هذا الشيء. من الحالات النادرة جدا اللي تواجهنا أننا نوصل لمرحلة الرفض، من الحالات النادرة اللي نوصل لمرحلة فعلا الأب متمسك برأيه. فالحل في هذه الحالات هي الشرح الكافي الوافي للأب أو للمريض، وتوضيح سلامة العملية بصفة عامة، إيش الأخطار وإيش الفوائد المترتبة، وفي أغلب الأحيان تحل هذا النوع من المشاكل.
جزاك الله خير. فيه بالنسبة لإقناع الأب مثل الحالة، توجد في المستشفيات أو خاصة المستشفيات الكبيرة العسكري الحرس وغيرها، الملك فيصل التخصصي، في لجان الأخلاقيات الصحية. هذا يجي الآن دورها، هم يدرسون الحالة ويشوفون الوضع، ثم يوصون أيضا أنهم يطلعون للأب هذا ويقنعونه بالمصالح والمفاسد. والحمد لله أبشركم أنا في أحد اللجان ونجحنا بعدد كبير والله الحمد لله منه. هذه واحد. أما بالنسبة إذا كان الأب عاقل وبالغ وكامل الأهلية، لا يمكن بالنسبة في وزارة الصحة إجباره في كل الأحوال. ما دام هو كامل الأهلية لا يمكن إجباره إلا في حالة واحدة، اللي كما ذكر في المادة 19 في نظام مزاولة المهن الصحية، يعني يكون الإذن حق متمحض للكامل الأهلية، فإن لم يكن فبوكيله، فإن لم يكن فبإذن وليه إذا لم يعتد برأيه، إلا ويستثنى من ذلك إذا كان قد يفقد حياته أو يفقد عضو من أعضائه أو يفقد وظيفة ذلك العضو. تفضل دكتور طلال. قرب المايك يا دكتور.
دكتور عبد الله، أنا لا أعتقد إنه نحتاج إنه
تقرب
لا يحتاج إنه المريض يعرف من أين مصدر العضو، بقدر ما إنه لابد يعرف مواصفات هذا العضو. حتى في الدول الغربية اللي تزرع فيها من متوفين دماغيا لازم يعرضوا حالة المتوفى إذا كان يشرب مخدرات لا قدر الله، أو إنه أي هذه، وله الحق إنه يرفض أو فبالنسبة لجواب الابن أتوقع إنه، وهذه حصلت حوادث حقيقية، إنه الأب لا يعرف من تبرع له ويفاجأ بعد العملية إنه ابنته أو ابنه هم اللي تبرعوا له وهو ما يدري. فأعتقد إنه إلا إذا كان في خطر أو فيه ضرر على المتبرع. أنا وجهة نظري هذه يعني لازم يكون فيها.
أنت حليتها الحين خلاص. بارك الله فيكم. يعني الدكتور طلال أيضا فصلها إلى جزئين، اللي هي الموافقة على العملية والموافقة على مصدر العضو. فربما بالموافقة على العملية، وأنا طبيب تخدير يعني، فدائما نأخذ آراء المرضى في الموافقة على العملية كجزء من متطلبات إجراء العملية، ولكن ليس شرطا أن يوافق على المصدر من أين أتت. تفضل.
السلام عليكم ورحمة الله وبركاته. أخوكم الدكتور يزيد الجاسر، أستاذ أعلام واتصال، ومهتم الحقيقة في موضوع زراعة الأعضاء وزارع كلية أيضا. فأرى تقاطعات كثيرة مع كلام أصحاب المعالي والأساتذة بأنه يجب أن يتم توعية الناس حول أهمية هذا الموضوع وفائدته عليهم. احنا في مجتمع حقيقة متدين بفضل الله، والناس لديها تحرج كبير جدا من موضوع الحكم الشرعي. فالنقاش اليوم حقيقة جميل أنه ابتعد من موضوع الحلال والحرام إلى أنه حلال، بل ربما أيضا يؤجر صاحبه. وهذا ما أعتقد أنه يعني برامج التوعية بأهمية زراعة الأعضاء تحتاج إلى الدعم من أصحاب المعالي ومن التوجيه بأن هذا الأمر له فائدة على المجتمع على الناس. مبادرة خادم الحرمين الشريفين الملك سلمان وسمو سيدي ولي العهد بالتبرع أيضا تدعم في هذا الجانب. ومثل ما قال الدكتور عبد الله الرقم والاحتياج كبير جدا، يعني 18,000 رقم اللي ذكره الدكتور فيصل في بداية اللقاء. 1000 هم في الحالة الحرجة الأخيرة الذي يحتاجون إلى زراعة في وقت عاجل ومهم جدا. أشوف اليوم يعني أنه التوجيه لحث الناس بالأجر والفضل الكبير سواء على المستوى الاجتماعي، احنا مجتمع بفضل الله متكاتف متعاون، ولكنه يخشى من هذا التحرج. فالدفع بالنقاش إلى يعني ترغيب الناس، حثهم يعني الأجر الكبير، الفائدة الاقتصادية، الفائدة الصحية اللي تنعكس على المجتمع. ومثل هذه المبادرات جميلة جدا. نشكر المركز، نشكر أصحاب المعالي، ونتمنى بمشيئة الله أن تستمر هذه الجهود، لأنها تصب فعلا بأثر ممتد من المريض وأسرته ومجتمعه وإلى ما لا نهاية. شكرا لكم.
جزاك الله خير. جزاك الله خير دكتور. ولعلك أثرت في نفسي مقترح، فلعل وزارة الشؤون الإسلامية والدعوة والإرشاد أن تخصص قد يكون هذه توصية، أن تخصص خطبة من خطب الجمعة بالحث بالتبرع على الناس. وهذه رسالة نرسلها لمعالي الشيخ عبد اللطيف آل الشيخ، لعل الله يسر سبحانه وتعالى أن يكون هناك تعميم لهذه الخطبة.
بارك الله في جهودكم يا شيخ. إذا سمحت لي أيضا، بارك الله فيكم، فعلا خطوة ممتازة وجميلة جدا. أيضا قالوا أصحاب المعالي حفظهم الله أنه وأيضا اقتداء بالرسول صلى الله عليه وسلم عليه، ما قال أنتم أعلم بدنياكم، بأن القضايا النقاشية توجه لأصحاب الاختصاص. على سبيل المثال بعض الإشاعات اللي تخوف الناس موضوع زراعة الأعضاء هي موضوع التحرج من الوفاة الدماغية. وموضوع الوفاة الدماغية في الأبحاث موجود جدا، حتى المملكة العربية السعودية والأطباء أعلم مني يعني تتأكد من إشاعة وإشاعتين لتتأكد أنه أعلى معايير التأكد من عدم يعني وجود أي إشكالية في موضوع الوفاة الدماغية، أنها ليست حتى موضوع خوف لدى الأطباء. فدعم أصحاب المعالي في والفضيلة في أنه والله الأطباء هم أعلم بهذا الجانب، ونحن نحث يعني من منطلق ديني إسلامي اجتماعي تربوي على المضي في هذا الموضوع. أعتقد أنه سيكون له أثر كبير جدا على مستوى المملكة بمشيئة الله، وعلى مستوى الوطن الإسلامي والعربي، بحكم أن المملكة دائما رائد في هذا المجال وفي كل مجالات تقودها. شكرا لكم.
بالنسبة للبرنامج التدريبي للخطباء، هناك إن شاء الله تعالى في معي الدكتور فيصل جاري إن شاء الله تعالى التحضير ليوم مكتمل إن شاء الله تعالى لتدريب الخطباء على المعايير المذكورة إن شاء الله تعالى، لعلها ترتب في الأسابيع القادمة بإذن المولى عز وجل. هناك سؤال؟
السلام عليكم، معكم العنود، أنا منسقة زراعة قلب من مستشفى الحرس الوطني. سؤالي لكم هو يشملني صراحة ويشمل كثير من الناس. إذا أنا موافقة للزراعة
ممكن الصوت يا أختي بس قليلا؟ نعم.
إذا أنا موافقة للتبرع في توكلنا وكل شيء، لكن إذا واجهت رفض من الوالد، الوالدة، الزوج، وكذلك كلامي ينطبق على كثير ناس يعانون نفس المعاناة، يواجهون رفض من الوالد، الوالدة، الزوج والزوجة، هل هذا يعني ممكن؟ هل يعقل أني أكون متبرعة بدون علمهم عشان ما أتجنب الصدام معهم وإقناعهم؟ وكثير من الناس ما زالوا مقتنعين بفكرة رفض التبرع، يعني يقولون باعتبار أنه خلاص الواحد يموت، يعني ما نبي نعيش في حزن آخر، أن أعضائك تؤخذ أو أحد يفتح الموضوع بعد الوفاة لا سمح الله. وشكرا لكم.
اسمحوا لي أجاوب هذا السؤال. طيب احنا لما نتكلم عن أي مسألة نسقطها على واقع المجتمع اللي يسأل السؤال. ففي الأبحاث والدراسات في علم الاجتماع وعلم النفس درست الموضوع هذا في مجتمعات مسلمة، مجتمعات عربية، مجتمعات أجنبية غير مسلمة. ما يميز الأبحاث، خليني أتكلم بكون دقيق، اللي طلعت عليها في أبحاث موضوع رغبة الإنسان في التبرع ووش اللي يمنعه. في مجتمعنا السعودي كان في نقاط تدفع للتبرع وفي نقاط تمنعه. من أحد الأشياء اللي تمنعه هي رغبة العائلة أو خوف العائلة. وكان المنظور في هذا الشيء طبيعة مجتمعنا اللي هي العائلة الممتدة أو extended family. العائلة الممتدة أن يكون في ارتباط مع أخوانك وعيال عمك وعيال خوالك، وفي ضغوط مجتمعية تكون حول الشخص تحدد مسار حياته، مو بس في التبرع، في أشياء ثانية كثيرة، وهذه يمكن من خصوصية المجتمع السعودي. فإذا كان مجتمعنا إلى الآن زي ما تفضلت متخوف من التبرع، ستبقى هذه الضغوط موجودة. إذا تحولت الدفة والبوصلة إنه لا والله مجتمعنا تقبل، حتكون لا، الضغوط من العائلة بادر. عندنا ابن عم، عندنا ابن خال، ابنة عمة، ابنة خالة، عندنا أقارب محتاجين، فيكون نستفيد من العائلة الممتدة الاكستندد فاميلي لدعم عملية التبرع للأعضاء داخل احتياج نفس العائلة بإذن الله.
لو تسمح بس تفضل شيخنا.
شيخ عبد الله تفضل.
ما سمعت السؤال، احنا يا شيبان ترى ما نسمع زين، لكني أنا يعني بجيب لكم نكتة بس. هذه امرأة أرادت أن تتبرع لزوجها، وقالت لها أمها والله ما تتبرعي له، يا أمي هذا أبو عيالي وتعبان وكذا. قالت أنت ما دريتي إن فلانة تبرعت وبعدين راح وعرف عليها وخلاها أخذ الكلية وتبرع. فأحيانا يوجد نماذج ما هي بطيبة يسحبها بعض الناس على هذا. يا إخواني ظلم، يعني كثير من الوفاء قصص رأيناها، قصص من. فإذا وجدت قصة واحدة لا يجوز إشهارها يا إخواني، لأنها تمنع من الخير. في بيوت قامت على الوفاء والعطاء ولا يزالون يعني الناس يرونهم مضرب مثل. ما أدري هذا هو الموضوع ولا؟
نعم. هذا السؤال اللي هي رغبة الشخص بالتبرع ومنع العائلة له من ذلك. بحكم زي ما تفضلت وجود حالات شاذة قد تكون لها أثر سلبي في فهم المبدأ وأثر على حياة الإنسان العائلية.
وبعدين أيضا يا إخواني ترى المتبرعة تقصد وجه الله حتى لو أنه تزوج، الذي عند الله ما يضيع. ينبغي يا إخواني أن تكون أعمالنا كلها من أجل الله، حتى تربية أولادك. هل ولد ذا اللي أنت تربيه الآن وتاخذ الشيء تضعه في فمه، تاخذه من جيبك أو من فمك تضعه في فمه، هذا ينبغي أن يكون تعاملك معه من أجل الله. يجي يوم من الأيام ينساك ويروح. ولذلك الآن نحن في الإفتاء يعني نبتلى بمثل هذا. أم تقول أنا رحت والله أني بايعت ذهبي وزوجته وسويت به، يوم تزوج قامت تحكم في امرته، هرب ويا امرته وخلد العجوز. وهي مسكين أنا عطيته وأنا بعت وأنا سويت وأنا عملت. إن كانت عملتيه يا أختي من أجل الله والله ما يضيع، والله ما يضيع. لكن كانت عاملته من أجل الدنيا راحت. ولذلك نوصل الناس بالإخلاص حتى جميع ما تعمل مع أصدقائك، مع زملائك، مع الزوجة، مع الزوج، انوي به وجه الله عشان ما يضيع. نعم.
شيخ عبد الباقي.
أنا عندي إضافة صغيرة. أولا هذا السؤال لا شك أنه مهم، إن كان اللي فهم من هذا أن المتبرع إذا أراد يتبرع لغير والده أو لغير إخوانه ومنعه والداه، هذه المسألة لا شك تحتاج يعني تأصيل ورجوع إلى كامل النصوص. لكن فيما يظهر لي والله أعلم أن التبرع إذا ما زال في نطاق عمل الخير والندب والسنة لا شك أن طاعة الوالدين فيه مقدمة فقط.
دكتور عبد الله كان عندك شيء؟ يعطيك العافية. تفضل دكتور.
السلام عليكم، بسم الله والحمد لله والصلاة والسلام على رسول الله. أخوكم منير المهنا. الشكر للمركز السعودي لزراعة الأعضاء، والشكر لأصحاب الفضيلة وسعادة الاستشاريين، والشكر لمدير الجلسة الأستاذ العمر. ما قصرتوا جميعا، جلسة مثرية تقدر مش بالملايين بالبلايين. الطلب الأول، وأرجو أن الإعلام ينقل هذه الجلسة بكل سؤال وكل إجابة. الصحف يجب أن. النقطة الثانية، أرجو من أصحاب الفضيلة المشايخ مثل هذه الجلسة اللي كانت مع موضوع الزراعة، هناك مواضيع طبية أخرى، هناك مواضيع مع مهندسين، مع عقاريين، مع ماليين، إداريين، مع مستثمرين إلى آخره، أن يعني نقوم بمثل هذه الجلسات الحقيقة لأنها توعي. في نقطة تفضل فيها معالي الشيخ عبد الرحمن السند عندما تكلمنا عن توكلنا، وقال معاليه إنه الرد بتوكلنا يعتبر بمثابة رضا. أنا بس ملاحظتي، هل ممكن التحوط بأنه قد يكون يعني هذا الجوال مهكر، أو قد يكون هناك عبث أو يعني والتحوط بالتأكد من الشخص وليس فقط باعتماد هذه الإشارة الإلكترونية اعتمادا كاملا بعد الله سبحانه وتعالى. شكرا جزيلا لأصحاب الفضيلة والاستشاريين، بارك الله فيكم جميعا.
السلام عليكم.
مسألة توكلنا بس. كل وسيلة للإفصاح عن الإرادة معرضة لما يبطلها أو يحدث فيها ما يعارض أثرها. الشهود وهم وسيلة من وسائل الإثبات المعتبرة شرعا قد يكونوا من الإقرار وهو سيد الأدلة كما يقال في القانون، والاعتراف من أعظم وسائل الإثبات، قد يكون تحت الإكراه، قد يكون. فما من وسيلة للتعبير بالإرادة عن الإرادة إلا ويكتنفها ما يكون ضد الإفصاح عن الإرادة على الوجه الصحيح. لكن في توكلنا الذي يمكن أن يكتنفه من إبطال هذه الإرادة أو وصولها على الحقيقة أقل بكثير من يمكن جميع الوسائل. فالاعتراض على أن الضمانات المحاطة بأبشر ضمانات عظيمة وكبيرة وقوية، وبالتالي لا يمكن أن يتردد المفتي أو المنظم إلى الاستقرار أو الاطمئنان على أن هذه الوسيلة تعبر عن الرضا والإرادة.
السلام عليكم ورحمة الله. عبد الرحمن التميمي، استشاري جراحة وزراعة الأعضاء. حياكم الله. نرحب بقدومكم، وفي الحقيقة حضوركم مهم جدا لمساعدتنا في برنامج زراعة الأعضاء في المملكة. أنا قبل ما أتحدث عن النقطة كان عندي بس تعقيب لسؤال الأخت. فإذا إن هي تبرعت بأعضائها وهي عاقلة بالغة حرة لها حرية التصرف وقت الحياة، فإن هي ماتت دماغيا فهي كانت تملك أعضائها وقت حياتها، وإن توفت دماغيا فهي لا تملك أعضائها بعد الوفاة. فمن باب أولى إن زوجها وأهلها ليس لهم حق التصرف بها قانونا بأعضائها بعد الوفاة. هي في نقطة مهمة بالنسبة للتبرع، وحقيقة ما ودي نخلط النقطتين مع بعض. عندنا في المملكة طريقتين للتبرع. التبرع ليس عندنا مشكلة فيه، لا من ناحية المرضى المستقبلين ولا المتبرعين، اللي هي التبرع أثناء الحياة. مجتمعنا مجتمع مسلم طيب كريم معطاء. تجده أول الناس من يبغى يتبرع لأمه ولا لأخوه ولا لأخته ولا زوجته ولا لابنه ولا ابنته، ما عندنا مشاكل فيها. حتى يعني في العيادات أو في المستشفى يعني عمليا لا نواجه مشكلة في التبرع أبدا. التبرع بالأحياء لا من المستقبل ولا المتبرع. هذا العدد اللي هو تبرع في الأحياء يمثل تقريبا 75 إلى 80% في التبرع في الأعضاء. اللي حنا عندنا مشكلة فيها كبيرة، ونطلب من اللجان الشرعية الدعم والمساعدة فيها، اللي هو التبرع بعد الوفاة. الوفاة اللي هي الوفاة الدماغية بناء على التعريفات الطبية اللي أهل الطب هم من يحكم في هذا الموضوع، وبناء على التوصيات الشرعية أحل الأمر التبرع بالأعضاء بعد الوفاة أو معظم القنوات الشرعية. هو ما نحتاجه مثل ما تفضلتوا فضيلتكم اللي هو الدعم عن طريق الخطب، عن طريق الإعلام، عن طريق المجالس العلمية، عن طريق المجالس الإرشاد والتربوية، بأنه نوضح فكرة ليس فقط جواز التبرع بالأعضاء، يمكن أنها تعتبر فرض كفاية، بل هي من البر، بل هي من الصدقة الجارية الصالحة اللي تبقى للإنسان بعد وفاته. شكرا.
جزاك الله خير. في تعليق؟
والله كلامه يعني واضح.
جزاكم الله خير. تفضل يا شيخ. شيخ عبد الرحمن. المايك. المايك وين؟
السلام عليكم. دكتورة ماريا العمري من المركز السعودي لزراعة الأعضاء. احنا نقابل الأهل وفي سؤالين تواجهنا خلال مقابلتهم لما نطرح فكرة التبرع. السؤال الأول وتكرر أكثر من مرة إنه إذا بعث هل يبعث بأعضاء ولا بدون أعضاء؟ السؤال الثاني احنا نقول لهم صدقة جارية.
لو تعيدين السؤال الأول.
السؤال الأول إذا بعث المتوفي المتبرع بأعضائه هل يبعث بأعضاء أو بدون أعضاء؟ السؤال الثاني احنا نقول لهم إنه صدقة جارية للمتوفي، يقولون طيب إذا سوى معاصي المستقبلين أو الزارعين إذا سووا معاصي هل تكتب لهم كمان معاصي جارية للمتوفي؟ شكرا.
سمي يا شيخ.
تسمحوا لي. بسم الله. يا أحبابي، البعث عندما يريد الله أن يبعث العباد للقيامة يكون الإنسان قد فني كله إلا بذرة صغيرة جدا اسمها عجب الذنب. ينزل الله تعالى مطر خاص بهذه القطعة الصغيرة جدا، مثل الصحراء الآن. لو نخرج الآن إلى الصحراء ويطلب منا أن نجمع بذور، ما نستطيع نجمع لنا كيلو بذور، لكن إذا نزل المطر كل الأرض تخضر. من وين؟ البذور موجودة. فينزل الله مطر يشبه ما يخرج من الرجل، وتنبت هذه الأجساد، تنبت حتى إذا استكمل نباتها نفخ في الصور فأطلقت الأرواح إلى الأجساد، يكون كأن معها ليزر. كل جسمه، كل روح تروح لجسدها فتدخل فيه، فيبعث الإنسان ويقول يا ويلنا من بعثنا من مرقدنا هذا، فيقال لهم هذا ما وعد الرحمن وصدق المرسلون. فجميع الأعضاء هذه كلها تفنى، حتى العظام تفنى، كلها تفنى مع طول الوقت، ما يبقى إلا البذرة الصغيرة. وهذا الحديث صحيح في صحيح مسلم. في زيادة يا شيخ؟
تسأل عن الإثم. إذا أحد استقبل عضو مني وارتكب إثم، إذا تبرعت الإنسان وعمل خلينا نقول معصية، هل بحكم عضوي؟
هذا يا إخواني الأرواح هي تتبع الثواب والعقاب. أنت الآن تعرف، أنتم الآن الأطباء أعرف الناس، هالخلايا اللي في الجسم يوميا تتغير، يوميا تتغير. طيب الخلايا اللي جت بالمعصية في وقت المعصية ألا تعاد ويجي أنت تغير هذه. العذاب يا إخواني يعود للأرواح، وأحيانا يكون معها قبل يوم القيامة الأعضاء، يكون معها ما يكون من الأعضاء. لكن مثل هذه الأمور اتركوها للغيب. الله تعالى قال الذين يؤمنون بالغيب ويقيمون الصلاة. نحن نؤمن بالغيب وأننا سنبعث وأن هناك ثواب وعقاب، وهذا متروك لرب العالمين.
شيخ تسمح طلب الشيخ قبلك، معليش
تفضل.
معذرة.
السلام عليكم ورحمة الله. عبد الرحمن بن محمد الفارس، مستشار في مكتب معالي الرئيس العام. بالنسبة لمسألة الوفاة الدماغية، هي وردت في نظام التبرع بالأعضاء في المادة 11. جاء في النظام مع ما ورد في النظام في شأن نقل الأعضاء البشرية من المتوفين، يكون التحقق من الوفاة لأجل التبرع بالأعضاء البشرية وفقا للأوضاع والضوابط التي تحددها اللائحة. فلعل اللائحة هل صدرت لم تصدر؟ هذا السؤال للمختصين، لأنها سيحدد معنى الوفاة الدماغية في هذا المجال. السؤال الآخر لمعالي الشيخ عبد الرحمن حفظه الله، إذا أوصى الإنسان بالتبرع والورثة من بعده لم ينفذ الوصية، هل يأثمون في هذا؟
أجاوب قبل ما تذكر عن اللائحة. نعم، يجب على أولياء المتوفى أن ينفذوا وصيته من بعد وصية يوصي بها أو دين. هذه الوصية إلى من أقام الميت عليها من ولي ومن وصي عليها لتنفيذ الوصية، يجب عليه أن ينفذها، وليس له أن يبطل هذه الوصية أو يعترض عليها أو يتوانى عمدا بغير عذر
من تنفيذ هذه الوصية. نعم.
أحسن الله عليك دكتور فيصل. بالنسبة للائحة
أي نعم هي قائمة.
سامي الشيخ باقي آخر سؤال عند الدكتور وننتهي.
ترى معنا هيئة الأمر المعروف. صلاة.
لا بالنسبة لنا موجودة، وهي تنص على وفاة كامل الدماغ وموصوفة بشكل دقيق للأطباء والممارسين الصحيين، ولها معايير محكمة بحيث لو قام بها الطبيب الأول وعاد الفحص الطبيب الثاني بنفس المنهجية يحصل على نفس النتيجة بإذن الله عز وجل.
اللائحة صدرت يعني؟
اللائحة البروتوكول وتشخيص الوفاة الدماغية موجودة وجاء التحديث لها.
يعني المتوفى دماغيا يعد طبيا متوفى ولو كان هناك نبض للقلب أو تنفس.
هذا المعمول فيه حاليا. اي نعم.
السؤال الأخير. السلام عليكم ورحمة الله. دكتور حسن العشي من تجمع عسير الصحي وحدة التبرع بالأعضاء. سؤالي لفضيلة العلماء: نحن نقوم بمقابلة الأهل بعد تشخيص الوفاة الدماغية لمحاولة إقناعهم بالتبرع بأعضاء المتوفي دماغيا، كما أن الطبيب وكما تفضلتم أن أهل الاختصاص كما أن الطبيب هو الأقدر على إبلاغ الوفاة الدماغية. ألا ترون فضيلتكم أن إشراك أهل الشريعة في لقاء الأهل لأنهم الأبلغ أيضا على تبيان الوجه الشرعي للتبرع بالأعضاء وحث أهل المتوفي دماغيا على التبرع بالأعضاء؟ فنحن نرى أن وجود أو التوجيه للمناطق بإشراك أهل الشريعة من مكاتب الدعوة والإرشاد أو من ترونه، بحيث يكون مطلعا على التبرع بالأعضاء وملما بأحكامه الشرعية وخطيبا وفصيحا، فهل ترون أن هذا سيساعد على تحسين التبرع؟ وإن كان فنرجو منكم إصدار التوجيهات اللازمة لذلك. شكرا لكم.
هذه عند الشيخ محمد.
هذه عند الشيخ محمد. نعم.
تعملون بها.
اي نعم. دكتور، في كل منطقة الآن من مناطق المملكة، في سواء كان في السابق في المديريات والآن في التجمعات، يوجد إدارة اسمها الدعم الديني والتوعية الدينية، ويوجد فيها كذلك مرشدين دينيين في كل مستشفى. فالمطلوب يعني في كل تجمع يضيف المرشد الديني في هذه اللجنة كما هو موجود الآن في الخدمة الاجتماعية. يعطيك العافية.
لو تسمح في إضافة
شيخ.
بخصوص يعني الموت الدماغي، ومثل ما تفضل شيخنا الشيخ عبد الله أنها عملية معقدة، وذكر أيضا معالي شيخنا الشيخ عبد الرحمن أن الإجابة في الحكم الشرعي أو الفقهي على المسألة هذه مبنية لا شك على قرار ورأي الطب. أنا عندي بس تساؤلات. أقول أن الميت دماغيا يقرر الأطباء نحوه ماذا؟ هل هو على وجه القطع واليقين أنه لا يمكن أن يعود للشفاء، أو على وجه غلبة الظن، أو على وجه الظن يعني يكون 50% أو من 50 إلى 99% أو 100%؟ وعلى ضوئها يقرر.
ما عاد يعود.
نعم.
يلا فيصل، الدكتور فيصل يعلق.
اليقين لا يزول إلا بيقين. احنا عندنا الأصل في دخوله أنه حي، لا يعتمد تشخيص الوفاة الدماغية إلا بيقين وفاة كامل الدماغ. وهنا نقطة مهمة، في دول تستخدم جذع الدماغ، وفاة جذع الدماغ، وفي دول تستخدم وفاة كامل الدماغ. وإحنا في المملكة العربية السعودية من بداية تشخيص الوفاة الدماغية، من بداية مشروع تشخيص أو تأسيس تشخيص الوفاة الدماغية، نستخدم وفاة كامل الدماغ، وهذه تقوم بفحصين من طبيبين في فترتين مختلفتين، مع إضافة فحوصات نسميها في المملكة الفحوصات التأكيدية، بينما بقية الدول تسميها الفحوصات الإضافية أو الاختيارية. ونحاول نثبت من هالفحوصات عنصرين مهمين. العنصر الأول انقطاع تدفق الدم داخل الجمجمة بشكل كامل، وفي انقطاع الدم عن الدماغ وفاة خلايا الدماغ. العنصر الثاني اختفاء نشاط الدماغ الكهربائي، وهذا العنصر يدل على أن الخلايا فقدت وظيفتها بشكل كلي، مع تصوير طبي طبعا اللي هو الأشعة المقطعية المغناطيسية لإثبات وما يسمى تحديد سبب الوفاة الدماغية. لا يقبل تشخيص الوفاة الدماغية بدون معرفة سبب الوفاة الدماغية، سبقه حادث، التهاب في الأعصاب، توقف القلب. فبدون التشخيص الأكيد المسبب للوفاة الدماغية مع انقطاع تدفق الدم أو انقطاع النشاط الكهربائي مع الفحص طبعا الطبي، يتعذر تحقيق تشخيص الوفاة الدماغية. وفي كل الحالات اللي فيها شك نقف عند الأصل اللي هو اليقين أنه أصلا هو ليس متوفى دماغيا.
شكرا لك.
جزاكم الله كل خير. ولعلنا مع ختام هذه الندوة نأخذ وعد من الدكتور طلال على تنظيم ندوة عند اكتمال الدليل إن شاء الله تعالى، لأن هذا الموضوع طويل ويحتاج إلى إيضاحات كبيرة إن شاء الله تعالى تأخذ وقت طويل بإذن الله تعالى. مع نهاية هذه الندوة نتقدم بالشكر الجزيل لفضيلة العلماء على إعطائنا من وقتهم الثمين في هذه الساعات المباركة، وندعو لهم بكل خير، وسعيدين جدا بوجودهم معنا ومشاركتنا في هذا المنتدى المبارك الذي قاموا بإيضاح الكثير من النقاط التي يكثر التساؤل عنها. شاكرين ومقدرين أيضا لزملائنا الاستشاريين الأطباء لحضورهم وانقطاعهم عن العمل في عياداتهم وغرف العمليات، ونسأل الله سبحانه وتعالى أن يبارك جمعنا هذا. وشكرا جزيلا لكم أيها الحضور على هذا الاستماع، ونعدكم إن شاء الله تعالى بمنتديات مماثلة بإذن المولى عز وجل. والسلام عليكم ورحمة الله وبركاته.